like kind of on-site also. When I say online, it doesn't mean people can have given their recorded lecture. So you can see Professor Mahesh, it's 10:30 p.m. in the United States at Baltimore, and he still, so you can see his commitment towards the education and imparting knowledge. So we should be very thankful to him also. And tomorrow also we'll have two lectures from the United States, from Harvard Medical School, and again one from UT Southwestern Dallas. So they will be, it will be kind of midnight over there tomorrow also, because the time zones in US, so many 6 zones are there. So we should be very thankful to them. The cross-sectional MRI and CT, the cross-sectional imaging has become the cornerstone of modern medicine practice, providing invaluable insights into the human body with unparalleled clarity and precision. So above all, the patients, but beyond the technical aspects, let's not forget the human element that underpins everything we do. Behind every image, every scan, there is a patient counting on us for answers, for reassurance, for hope. So it's a responsibility for all of us. We don't take it lightly, and one that drives us to continuously strive from excellence in our practice. So this was taken yesterday night. We have thanking all of those the team. I'm extremely thankful to build a good team. Although we were a little late, but we were able to finalize everything on time. So this is the program QR code. I'd request all to some of you can take a picture also, or you can scan. All the program details, the latest one is available at this QR code. So welcome to Lucknow also. It's a Nawabon ka shahar, शायरी का शहर. So I'll just start a small शायरी. CT से लेकर MRI तक की ये कहानी, हर एक पिक्सल, हर एक लाइन है एक नई कहानी. आओ चलें साथ खोजने नए रास्ते. रेडियोलॉजी की दुनिया में हैं हजारों वास्ते. ये कॉन्फ्रेंस है इल्म और जुनून का मेल. चलिए साथ चलते हैं नए सफर की ओर. So your feedbacks are also very important. Tomorrow afternoon session we'll collect all of your feedbacks also. So looking forward to an interesting interactive workshop and symposium. So minded Professor Mahesh wanted to at least 15 minutes or 20 minutes to have interaction, more interactive. So the purpose is not to just kind of monologue, just one-way talk. Ask question. This is the platform to ask question. If you have any doubt, all the speakers are ready to interact with you all. And also please don't forget to take pictures at selfie point outside this hall near the registration area that is made by our resident Dr. Shakib. So we hope you enjoy our time together. With that, I welcome you all. Thank you.
Thank you so much, sir. We are honored to extend an invitation to the chairpersons of our first session. For that, I would like to invite Professor Anit Parihar, sir, Professor and Head, Department of Radiodiagnosis, KGMU.
Professor Manoj Kumar, sir, Professor, Department of Radiodiagnosis, KGMU. Professor B.K. Ojha, sir, Professor and Head, Department of Neurosurgery, KGMU. Professor Archana Gupta, ma'am, Professor and Head, Department of Radiodiagnosis, SGPGIMS, Lucknow. Your expertise and leadership are highly valued, and we believe your presence will greatly enhance the quality of our discussions.
Check.
I would like to request the chairpersons to please introduce and invite the speakers for our first session.
Good morning, everybody. I welcome you all for this interesting interactive session. The first speaker is Professor M. Mahesh. He is MS, PhD, FAA PM, FACR, FACMP, FSCCT, FIO MP. He is Professor, the Russell M. Morgan Department of Radiology and Radiological Science. He is Professor of Cardiology in John Hopkins University School of Medicine. He chaired many societies and all, and he is also chair of ACR, Commission on Medical Physics, and a member of Board of Chancellors, member of National Council of Radiation Protection and Measurements, member of International Commission on Radiological Protections, member of a small group of experts on medical exposures, and United Nations Scientific Committee on the effect of atomic radiation. So I would like to invite Professor M. Mahesh to give his lecture.
Thank you very much, and I want to thank Dr. Dwivedi for inviting me. I wish I was in the background. Unfortunately, it had come, so I wanted to share my knowledge, my talk, and I want to. I hope you're hearing me.
Yes, we can hear you.
Okay, I'm going to share my slides. Given the time limitation, I don't want to take it too much time, but I'd like to thank Dr. Dwivedi and also all the organizers for inviting me to speak on this topic. So, you see? You can see my slides? Can you see my slides?
Yes, we can.
I'm not putting the presentation more. Just let me know when I put in the presentation more, you can all see.
Yes.
Yes, it is visible.
Presentation more? Okay. I'm not going to take so much time because there's given it 20 minutes of time. This topic is quite large and I give talk for hours on this topic. But I wanted the very aspect to touch topic on imaging pregnant and pediatric patients and what can be done in respect to radiation dose optimization. So, given the time frame, I'm going to stop only the important aspect and any questions I will have to answer. Here are my disclosures, and this is where I work at Johns Hopkins Hospital in Baltimore, Maryland, very close to Washington, D.C. And my talk will be only focused on two things: radiation exposure during pregnancy and radiation exposure in pediatric imaging. Let me start with this first one. First of all, the question is, why and when should we care? Why should we be concerned about these both imaging pregnant patient and also pediatric patient? The reason why we should be cared because this is how people think when you talk about radiation. Moment you say radiation, the concept goes in the mind is always these crazy ideas. Any radiation exposure can lead to all this extra. The reason is like we read comic characters, we see Marvel movies, and all of these movies and characters, if you see these superhuman features for both heroes and villains, exposed there because they were exposed to some type of radiation. And because of this, the general psyche about radiation is always either too extreme concern or too lax of a concern. However, we had to, as a professional, we had to understand what's it at stake and do apply the right way. So, if you look the biological effect of radiation, we group into two categories. One is called the stochastic effect, which is delayed effect. Example is cancer in exposed individual and also mutations in offsprings of exposed individual. The second one is called the non-stochastic effect, also called as the acute effect and deterministic effect. These are observed within days to weeks and the direct damage to tissue due to local cell death. The difference between these two is like stochastic is more of a probabilistic in nature. It's like buying a lottery ticket. You buy one ticket and you buy 10 tickets to increase your chances of getting the jackpot. Similarly, every radiation exposure will have a chance of inducing this effect, yes or no. So that's stochastic effect. Whereas non-stochastic effect is a deterministic effect, is a short term where the radiation dose is very high that can lead to hair loss, skin erythema, So these are the two broad categories of which we in the radiation world classify into the two broad category of biological effect. So directly touching on the radiation exposure during pregnancy, I just want to lay out some of the concept we have or the understanding we have. First of all, the information we have on the radiation effects on unborn is from studying on the animal models. And on the right hand side here you see the graph showing the percentage of the chances happening versus the days post-conception. The idea is the human pregnancy can kind of mimics the mouse pregnancy model. So the mouse exposed to various amount of radiation is looked at the effect on the mouse, and that's where we get a lot of an understanding of what the radiation effect on the fetus. So let's say show here, these radiation doses given to the mouse is very high, not the doses we used in imaging. So right off the bat I want to say, the radiation doses we use in CT, X-ray, and fluoroscopy are much lower than what I'm showing here. But in general, as you guys all know, the first trimester of any pregnancy or any one pregnancy is very critical. The same thing applies for radiation effect also. The most sensitive to radiation is between the first trimester, 2 to 15 weeks post-conception. So during that time, if the fetus is exposed to large quantity of radiation, the chances of prenatal or spontaneous abortion or embryonic death is very high. You can see here, it's very high. But it goes down as the pregnancy matures. And as the pregnancy matures, if the radiation to the fetus is during the second trimester or the third trimester, the chances there is not the prenatal or spontaneous abortion, it's more like organogenesis, some type of abnormalities, such as decreasing head size or mental retardation or congenital malformation and so forth. How do we know this one? The reason why we know is like the atomic bomb explosion which happened on Hiroshima and Nagasaki, the survivor have been studied for the last 75 years. A lot of our radiation protection or radiation risk estimates have come from studying this population, and that's where the understanding is. Having said that, how do we look at the and in the imaging world, what is the marker we use as kind of like a point for discussion is this is where it is. If the dose of 100 millisievert during the first 6 weeks after conception is generally considered cutoff point, above which therapeutic abortion is considered or even discussed. So let's say 100 millisievert is the number I'm showing you here. How does one get 100 millisievert? Generally, if you do a CT of the abdomen and pelvis on a pregnant patient or anybody, let's say the amount of radiation dose to the person is 10 millisievert. So it means during the first 6 weeks of a pregnancy, if a patient gets 10 CT of the abdominal and pelvic CT, only then the patient would have got about 100 millisievert. Generally what we see in the hospital is any pregnant patient getting any type of X-rays or CT, everybody is over concerned and overly cautious of it. I just wanted to lead through this one and dispel some myths and also some strategies which we can use. In order to do that, the three areas which utilizes X-ray radiation in any hospital is radiography, fluoroscopy, and CT. Nuclear medicine is another procedure where we use the patients as injected into isotope and so forth. Let's focus on these three things. So, in order to understand what is the risk to the fetus, we also want to know what is the dose distribution from each of these modalities. Very simplistically talking, if you're doing an X-ray or a fluoroscopy procedure, the highest dose is on the surface of the patient. And the dose decreases as it goes through because a lot of it is absorbed, a lot of it is scattered, and the amount comes out is what we capture in a film screen. So, in a fluoroscopy and radiography and fluoroscopy, the surface dose is the maximum dose the patient can experience. So if a pregnant patient gets a radiography and fluoroscopy procedure, depending where the fetus is, we can actually estimate what the fetal dose is. On the other hand, in a CT, since we are collecting dose around the patient, the maximum dose to the patient is on the surface and much less at the center. That's also one of the reasons when you're doing a large patient with a very huge obese patient, not even pregnant, any obese patient, you can see the image quality degrades at the center. And we in the field called as photon starvation, because not many X-rays are reaching that area, and that's when it caused the artifact and so forth. So this is the scenario for radiography and fluoroscopy versus CT. So now the question is, there are two scenarios. Let's imagine all the X-rays, any X-rays done on the patient, any X-rays which does not include the primary beam directly in the path of the abdomen and pelvic. Let's take scenario here. In this scenario, the chest radiograph, similarly chest CT, anything, it is coming in this direction, you have an image receptor. In this case, the fetus is not directly in the X-ray beam path. So, if at all, the first distinction we want to do is like, what type of imaging you want to be doing on a pregnant patient? If on the pregnant patient, if you're doing any X-ray, fluoroscopy or CT, away from the area of abdomen and pelvic, the risk to the fetus is so minuscule, because very few X-ray scatter will reach the fetus, and that's only by internal scatter, and that's also one of the reasons why we as professional society are now trying to avoid any type of apron put on the patient. It is not providing any extra protection. So in this case, the fetal dose may be as small as 10 microsievert. That comes out to almost same as 1 day of background radiation exposure. So remember here, this is the scenario where the fetus is not directly in the beam path. If that is the case, for a conventional X-ray, it is almost same as a natural background radiation. So if the radiation goes to the fetus when it is not in the path of the primary beam, such as for X-ray, it's usually about a background radiation. For fluoroscopy and CT, even less, about 5 millisievert. So my take-home message for the residents or any of the physician is, if you had to do a pregnant patient, as long as it's clinically necessary, and if that does not include the directly path of the beam of the abdomen and pelvic, you should not even hesitate to order the exam. On the other end, the second scenario, where the fetus is directly in the path of the X-ray beam, let's say this is a scenario, then we have to estimate where actually the fetus is, because the X-ray intensity decreases as it going from the center, from the entrance to the center. So depending on the time of the pregnancy and how large the fetus is, you can actually estimate the fetal dose. That's what we medical physicists do. After the study is done, we can actually calculate what's the fetal doses. And that can be as much as one X-ray, just X-ray 10 millisievert or so. Even that is not high, but however in this scenario, the best possibility is to assure that the clinically responsible, it is clinically appropriate, it is absolutely necessary to do a pregnant patient in the abdomen and pelvic area. If the study can give the answer in a quick way and also can save the patient, the radiation risk to the patient is quite comparatively less compared to the benefit the patient is getting. So here is one of the, just a chart telling what are the fetal effects from low-level radiation exposure. When we say low-level radiation exposure, we are talking about the radiation exposure which we see in medical imaging. So I'm not going to ask you to read this table, it's small, but I just want to draw your attention. For example, for the prenatal death, the only data, we don't have any data from the human studies, we don't have any absolute incident studies. So usually the only thing which we have is from the animal studies. For example, on the other hand, if there is a growth retardation situation can occur, if the dose has gone more than 200 milligram, none of the CT or the fluoroscopy or X-ray to the fetus for just one CT will not deliver 200 milligram. A typical abdominal pelvic CT can deliver up to 10 to 15 milligram, and that's where we can actually make sure that the techniques are protocoled properly so that we are not delivering high dose. If that is the case, we don't have absolute evidence for any of these things. My take-home message is if the clinical appropriateness is high, the benefit you get is very high, then the risk associated during the pregnancy is quite small. So let's say, look this, here is another table showing that the radiation dose level less than 100 milligray, 50 milligray, or greater than 100 milligray. Most of the imaging we do in radiology is typically less than 50 milligray. And here is what is shown. If the pregnancy at any week is done, if the study is less than 50 milligray, we don't have seen any potential effect for radiation. It's almost none. Only when the doses are more than 100 milligray, that's when there is a potential effect for other things, and that's when the physicians are called upon to interact with the patient to explain the risk associated and so forth. Another way is looking is typically what radiologists and physicists we do is like any radiation exposure, we give a risk number. And that risk number can cause unnecessarily fear in the patient unless it is explained properly. On the other hand, we are now trying to turn the table in a different way. Let's look at here the table. Even without any radiation, that is 0 milligrams, anybody, the pregnant patient getting no X-ray studies, even then, the probability of birth with no malformation is about 96%. Means every pregnancy carries about 4% chances of malformation or about 1% of childhood cancer. So even without radiation, pregnancy, there is some risk here. This needs to be explained before explaining what's the additional risk going to happen if the fetus is exposed to radiation. Let's say if the fetus or a pregnant patient gets a study and the fetus got about 10 milligray here, that means the risk goes from 96% of no malformation to 95.98. And the overall no malformation, no childhood cancer goes from 95.9 to 95.8. On the other hand, if you tell the risk from radiation is 0.12%, patients are a lot more concerned. But we are believing this, the way to tell the story, explain to the patient in this way, makes it a little bit more easy for them to accept the benefits they are getting from the X-ray studies. So, here is the general recommendation from not only the American College of Radiology on the use of CT in pregnancy, but also from the American College of Obstetric Gynecologists. Even they recommend is like, perform necessary examination only after clinical workup, which you all do, and counsel for radiation exposure to ask any question, ask the patient for any question and answer them. Similarly, ACR tells like, we need to keep the radiation low as possible so that we minimize the risk, and counsel for radiation exposure. So both of them are recommending is that don't avoid imaging a pregnant patient just because of radiation. Having taken all these things into consideration, and here are the approximate fetal dose estimation from various imaging procedures. I'm not asking you to read, but just want to draw a point. In nuclear medicine studies, if you do a whole body PET CT, in the first trimester that can result up to 15 milligray. Even that is less than 100 milligray, which we are usually concerned about. A typical CT of the abdomen and pelvic can go up to 25 milligray, depending on the technique we are doing. The other one is like exposure to pediatric imaging. So, for pediatric imaging, right off the bat, we are talking about long-term radiation risk, and that's called radiation-induced cancer risk. On the right-hand side is a plot showing an attributable lifetime risk per unit per sievert. Sievert is a very large quantity of dose. Typical imaging doses are 10 millisievert, 20 millisievert, 30 millisievert, or even less than that. So in this case, we broadly have this understanding that there is a 5% chance of developing cancer in their lifetime if the persons were exposed to 1 sievert of dose. That means the females are slightly higher risk in male. However, in reality, the pediatric population is slightly at a higher risk than the older population. For the reason is they're going to live for a longer time. In the US, when we are trying to tell this, we also try to put a perspective. What the perspective is, the natural incidence of fatal cancer in the US is 25%. 1 in 4% will die out of cancer in their lifetime. Therefore, if they got a radiation study done, their individual risk is going to increase very small, and that's where we are trying to emphasize for the physician is to make sure the clinical appropriateness is really high and is necessary. When it's high and necessary, we should not hesitate to do the study. Why do we worry about the children? Because the children are more vulnerable to radiation than adults, because younger bodies are more sensitive to radiation, and they live for a longer time, so there is a chances of developing the stochastic risk in the later. Second is, for the same technique, kids absorb more radiation than adults. Right now, the current practice is pediatric CTs are not done with the same protocol as the adult CT. We should not do that. We should have our own specialized protocol for doing kids with lower techniques and other things. So, here is the current understanding. Like, this is one data point I'm going to show you. In 2006 in the US, we did about 82 million CT procedures. How many were pediatric? It's approximately 10%. Means 8.2 million CTs were done on the pediatric. I'm guessing the same distribution around the world. Adult CTs are majority, pediatric CTs are much less, and among the pediatric CT, the majority of the pediatric CTs are done in head CT. Because a lot of the time, the parents bring the kids to the emergency room because they have fallen in the playground or have an accident, bike accident or something, and the first thing to rule out any type of internal injury, you do a head CT, and that's where the major part of the pediatric CTs are in head CT. So how can we minimize the radiation exposure risk to the child? One is, we want to image any type of imaging only when there is clear medical benefit, which you all know. The other one, when we are doing CT, right now the technology has advanced so much, it is always important to use dose modulation turned on. Dose modulation means the scanner will automatically change the technique based on the patient thickness. The second thing is, which is really a major improvement in the last, major impact is, we don't have to do the tube voltage as you do in adult at 120 kV. We want to use a lower kV, 100 kV or 80 kV instrument. And these things are usually helpful when the team of radiologists, radiographers, and medical physicists work together, routinely review the CT protocol, and make sure the CT protocols are assigned in such a way pediatric patients are done at a low kV, unless the patient is really large. Otherwise, you can do it this way to minimize any radiation exposure. The other easy to handle is imaging only indicated area. If you have to do a head CT, there is no need to expose the whole head, neck, everything. Or if you're doing a chest CT, limit to the area of the chest. You don't have to go all the way to the half of the abdomen and pelvic. The other major high-dose procedures is multiple scan, such as we do this triphasic study or four-phase studies. We try to minimize those things because that's quite a large amount of dose all at one time. So, what are the benefits of doing CT for a pediatric patient? One is, it's quick and fast, as you all know. I bet Lucknow hospitals, you have one of the latest scanners. The scanner, the joke is right now, it takes more longer for the patient, for the technologists to put the patient on the CT table than do the scan. Because the scans these days, with the advanced CT scanner, you can do a whole body in less than 3 seconds. So it's quick and fast, which means we can minimize motion artifact, especially for the kids. Sometimes we allow the mother to stand next to the gantry by wearing an apron and consoling the kid. Thereby, we can do a very fast scan without any motion artifact. And then we don't need to sedate. We can get very high quality images. Because we are doing faster, we can also minimize the contrast use. And sedation is seldom used in CT. On the other hand, sometimes there is a tendency to move the patient, pediatric patient, to MRI, assuming that we don't want to give radiation to the kids, therefore let's do MRI. Without keeping in mind that in MRI, it's a long procedure, and also there is the sedation, contrast and sedation issue, and that sedation has its own issues. So that those things have to be balanced. There are a number of websites and campaigns we have done in the past 10, 15 years. One thing which I want to draw all your residents as a resourceful sites is one is Image Gently. Image Gently is a campaign we started back in 2009, and now this campaign is basically to increase awareness for users to the need for decreasing the radiation dose to children. And this website has a lot of useful information, free information. And now because of this success, other continents have established their own safe Image Gently campaign. One such is the Asia, which I'm heavily involved with, is called Asia Safe campaign. Similarly, we have EuroSafe and Latin Safe. Basically, the idea is to bring the awareness about how to do the pediatric imaging with minimal risk. Similarly, for adult patient, we also have an Image Wisely campaign. Again, this website, you can check it out. It's all free educational resources. More than that, which I'm very happy to tell you about this particular website called radiologyinfo.org. This is one website which is developed between RSNA and the American College of Radiology, and in the radiation safety section, I have done a lot of work in this area. The website is purely for patients, in the sense patients can go there and try to find out more about the imaging and the radiation dose and imaging and so forth. And I'm proud to say this website gets about 2 million hits per month. So I would encourage any residents, anybody, to check out this website for additional resources. For those who are interested to know more about CT, I have a series of podcasts. All of them are only 15 minutes podcast. It's all free. It's on our website at Hopkins. It's called ctis.org.com. And if you can Google that, you can see that there are about 15, 20 lectures, very much geared towards clinician, talking about different physics aspect of CT, including physics of duality CT, image quality, cardiac CT physics, and so forth. And I would encourage you to take a look at it. So, in conclusion, the take-home message are the following one. One is, if you're imaging a pregnant patient, if the fetus is not in the path of the X-ray beam, exposure is minimal, you should not even worry about ordering that particular study. If the fetus is in the path of the beam, then you can take some steps to reduce the dose by adopting the dose optimization strategy. For imaging pregnant patient, one has to use the low tube voltage, dose modulation with CT, limited calibration. All these things will minimize the radiation exposure to the pediatric patient. So finally, the take-home message which I like to share is like, imaging, including CT, should not be awarded because patient is pregnant or patient is in pediatric, especially when the procedure is clinically appropriate. I would like to stop here and take any questions. Thank you.
Thank you so much, sir, for the wonderful talk. The floor is now open to any questions that you might have.
Thank you, sir. This is Dr. Bhatt from KGMU. It was a very lucid and informative and useful talk, and we know the gentle imaging is not only for pregnant women and children, for everyone, because radiation has got the detrimental effects that we have to minimize as much as possible. It was deliberated that after 27 weeks of gestation, radiation with reference to imaging, it has no detrimental effects as far as the imaging medicine is concerned. But beyond 27 also, radiation may have the long-term or maybe accumulated effects on the organism growing inside the utero. So what is the information, because molecular techniques, molecular pathways which we set in at that point in time will have certainly some long-term consequences.
It's a good question. When you talk about this long-term effect, that's what the stochastic effects is talking about, radiation is cancer, everything. And that's more like a chances, hit or miss case. It's like, for example, you have some probability
Thank you, sir. It was a very lucid presentation, and I'm sure that you have answered all the questions during your presentation. And it looks like there's no question from the floor. They are Dr. Divedi.
Thank you, sir. Can you hear me?
Thank you. Yes, I can hear you.
Thank you so much. So what time it is there?
It's about 11:15.
Oh, 11:15 p.m. So thank you so much for your time. It's a wonderful lecture. I just have a short question.
Sure.
You are going to ask?
I want to ask question. Professor Mahesh, I want to ask two questions. Actually, actually in India, when any lady is supposed to join any and if she is
Repeat the question, madam.
excuse me,
Can you repeat the question? I think the mic was cut off.
yeah, when any lady is going to join any job, she is supposed to go for medical examination. And if before going medical examination, she is pregnant, so we are not doing in that cases any X-ray. Even X-ray chest is being avoided in.
All right, so question got cut off. The question was like, what is your recommendation for those patients, those candidates who are kind of, needs a medical examination before their recruitment or something like that?
And the second question is,
Sure, go ahead.
yeah, you go on, Professor Mahesh.
No. Tell me the second question. I'll answer both of them.
The second question is about your recommendation in the radiation worker, female radiation worker, for working in intervention radiology.
Yes. So two things. One is regarding the workers getting a medical exam which included chest X-ray. As I demonstrated here, any radiation exposure which does not directly in the path of the abdomen and pelvic. So chest X-ray, first of all, is a low dose exam. Plus it's away from the feet, from the abdomen and pelvic, though I deem quite safe. So they should not be avoided. And I have encountered similar question, especially in international when they're migrating from one country to another, they have to get a chest X-ray. And I encountered a situation where a full pregnant person from Eastern European country, their family were blocking her to get an X-ray, worried about radiation. Luckily, I was able to convince them that should not avoid because of this, because we have demonstrated that the chest X-ray, first of all, it's outside the abdomen and pelvic, and the chest X-ray itself is very low. So that part is, the radiation dose is almost insignificant, they should not be avoided. Regarding your second question about what about women entering the interventional field? Actually, that is common question we get, and I teach medical students, and sometimes some medical students are so misunderstood, they don't even apply for radiology, they're so much worried about radiation. That should not be the case. As long as they all follow the radiation protection principle. If that is the case, then because as you all are monitored by a radiation bench, which is basically telling how much you're getting radiation, but if you're getting anything working around the field, the same thing applies for an intervention also. Especially for the intervention, pregnant patient, pregnant workers usually have to wear an apron, and also they wear a monitor underneath the apron, and that's how the regulations want it. So what we are seeing here is like, it's a misconception, misapprehension to go into the field. However, if you're doing properly all this radiation protection principle, there is no reason to avoid going to the interventional field, even when you're pregnant. We have our interventional radiologists doing the procedure even until the late stages of their pregnancy, and they are wearing an apron, they are standing behind the shields, and they're doing perfectly well, and their kids are fine. So I think that's one of the common myths we need to dispel, but with a caveat telling that they need to protect themselves with all these things. And again, putting one layer of apron is quite sufficient. I've seen some people try to put multiple layers of apron, and that is also not effective. Basically, they will strain the shoulder and backbone for unnecessary protection, because one layer of apron will protect 20 times any scatter coming. So one layer of apron which is tested repeatedly is quite
Thank you, Professor Mahesh.
So, Professor Prateek has a question from AIMS.
Hello, Dr. Mahesh.
Hello, Pratik.
I am just, my query is just in supplement to Dr. Emil Bhatt. Probably you have seen the very latest article. I think Dr. M. Rehani is one of the co-author, where it says that 100 millisievert of dose, which is generally even fetal cases, in accidental cases, 100 millisievert ICRP says that up to 100 millisievert it can go. With respect to the risk in other profession, you must have seen that in surgery, and they have compared it, and they say that still radiation effects could be higher than many of the professions. What is your comment?
So, you're bringing a topic, we're bringing this question, which is, we are in two sides of this one. I just want to let you know about this 100 millisievert and the cumulative dose debate going on between the IAEA position statement and the APA position statement, which I was involved. Fortunately, IAEA brought us all back last year, and we all hashed out, and now there is a consensus document which is published, which is accepted for publication, and which is, we want to try that smooth out of this unnecessary scale of this 100 millisievert number. Majority of the patients don't get 100 millisievert. Very small percentage of the patient who get lot of imaging do get 100 millisievert, but 100 millisievert is not the like a threshold number to be utilized. So Madan's and I appreciate Madan and his work, but we disagree. We agree to disagree, and that in that regard, the white paper is going to be coming in 2 weeks from now. Watch out for that. We are trying to hash out the differences and trying to tell more resources can be spent on education and training, and not to scare the people about 100 millisievert number.
Okay, thank you.
Dr. Mahesh, sir, last question. Chairpersons have certain privilege, and I'm using that privilege. I'm from therapeutic radiology, radiation oncologist, and many of our female workers, technologists and physicists and clinicians also during pregnancy, they avoid going to radiation treatment areas. What are the recommendations? Thank you, sir.
So the idea here is like, again, so like in radiation therapy or anywhere, everybody is monitored by a radiation badge. So the radiation badge should be an indicator that how much they are getting. And that's the idea of the whole regulatory requirement of wearing a radiation badge. So they should be wearing rather than unless they're worried about these whole things. The only concern in radiation therapy is like sometimes because of the high beam, the walls can be radioactive to some extent. So in that aspect, they have to monitor with the radiation badge. And usually the limit given to the pregnant workers is in the US, is allowed limit is 1/10 of what the radiation workers get. So that is the conservative determined estimate. So that's how it should be monitored. And if it is a brachytherapy and other things, there should be a concession for these pregnant workers to have their concern about this radiation to some answered in the right way. So there is always the juggling issue about if 30% of the physician community which are radiation therapists in a hospital, if they all learn do procedure, it's like every job has some risk for some benefit. And that's where we have to convince them, and we have to provide the protective basis and then leave it to them to take a decision. I hope I clarified some of the questions. I'm not sure whether I completely-
Sure, sir, you have clarified. Thank you very much, sir. And with this, we come to the end of this wonderful session, morning session by Professor Mahesh. It was really very informative and useful, sir. Thank you very much.
Thank you.
Now it's our proud privilege and honor to invite Dr. Prateek Kumar, Professor and Head Medical Physics Unit at the All India Institute Medical Sciences, New Delhi. Dr. Prateek Kumar had been awarded with AIMS Excellence Research Award twice in 2017 and 19, has published more than 81 research papers, 5 book chapters, and he has been awarded with Dr. Albert Jayachandra Endowment Oration in 2019 and many more laurels But without wasting much time, I'll invite Professor Prateek Kumar to deliver his talk. Thank you, sir.
Hello. Thank you very much, sir. Thank you, Chairman. This is my privilege that I am today here, and I want to thank the organizers to organize such type of wonderful workshop included in the conference where something hands-on practice is also there. These type of things are a bit rare in radiology, and which joins the physics team as well, and I want to congratulate the organizers for this. My today's topic is like MD-CT, multi-detector CT, and I will try to give some 15-20 minutes, next 15-20 minutes, some of the physics part, that how MD-CT and it works, and what physics aspect is there. We all know that CT has many generations, around 4 or 5 generations, various generations, but still we are using the third generation since it has got rotate type. I will not go into detail, but the main aspect of the third generation and further was the slip ring technology, where it was possible continuously to feed the power to the rotating gantry, to rotating X-ray tube as well as detector, and to take the detector measurements out without stopping the rotation of the X-ray tube and a detector. So this slip ring technology was really, it was marvelous in that way that even after that third generation, fourth and further generation, we are using slip ring technology even today. So, and with the slip ring technology, it got developed that we got the spiral CT or the helical CT. So continuously patient keeps moving in the gantry. Obviously, the first casualty in whole the setup, the advantage was that it was fast, and but the disadvantage was that it was too much heat production was there. So how much heat production was there, just to give you a perspective, like if 60 centimeter, 600 mm length scan we take in say abdomen pelvic area, and with 5 mm slice and pitch 1, so it leads to 120 rotations. It is 5 mm slice, so 600 divided by 5, it comes 120 rotations. And for 120 kVp we scan, and generally it is MA, what we take in CT is 250, 200, something like that, 250 MA. 1 second rotation, in one rotation, suppose it takes 1 second, so in that time it generates 3.6 into 10 raised to power 6 joules, which is a very high amount of heat generation. With respect to the, say, before slip ring, it is 120 kVp, 250 MA, same 1 second rotation, that it was generating only 30,000 joules. So obviously dissipation of heat becomes a problem, and that was the limitation in the beginning. So how to overcome that? Obviously, there were enormous heat led to the imaging of that time less than the 3 mm slice. It was impossible to take. Since thinner the slice, more will be the heat production, since more scanning will be there, and that time, since it is less than 3 mm, it was impractical to take the, reconstruction of coronal and sagittal oblique various views basically. So that time, this limitation to remove the heat in proper way, it was evident that people were doing low MAS imaging, where MAS was keeping less than 100, while it was in general it could be more than 250 or 300. So it was noisy image, low when number of photons are low, which is making the image will be noisy. So what was the solution? First solution they thought of, manufacturers thought of, that X-ray tube should be of higher capacity. Yes, they did that. The many Siemens tube, if you know, there are other tubes also, which they tried to make it ceramic tube or many other advancement. I am not going into detail, but they did develop X-ray tubes with higher heat capacity. And second, it was that X-ray beam should be expanded in Z direction. Z direction means along the length of the patient. So if slice thickness can be increased in Z direction side, in patient length side, obviously more number of detectors are involved, and so every detector may get some X-ray photons, and it was that way that heat can be minimized that way. So it came to the mind that multiple row of detectors should be there, and then came the concept of MD CT, multi-detector CT, or multi-slice CT. This reduces the total number of rotations. Since a number of rotations, say length is more, in one rotation we can cover more thickness of the patient, so number of rotations will be less, number of rotations will be less, so number of scans, number of rotations, less number of rotations are required, so less heat production that way. So this is one of the, we can see left side is the single slice CT, where all the detectors, if you see the detectors all in the lengthwise, this single detector. With respect to left, right side is a multi-slice CT, where the same detector can be divided into 4 rows. If we see, there are 4 rows. Detector is there, yeah. These are the 4 rows. If we see, these are the 4 rows. Same length can be divided into 4 rows of the detectors. So this is called 4-slice CT. Now, in the beginning, it was 4-slice CT only. And this is the Z axis, means patient lengthwise. Patient lengthwise, our detector is more. So our beam, which was fan beam earlier in single slice CT, it becomes the cone beam, since it has to cover more width towards the length of the patient. So difference between single slice CT and multi-slice CT is as follows. Detectors in single slice CT is one-dimensional, since it is, just one detector covers the whole length, single detector. There are large number of detectors, so typically 750 or more in a single row across the irradiated area to intercept the fan beam. Single element is monolithic. Monolithic means single element only. They are long enough, around 20 millimeter. So this length is 20 millimeter. This length is 20 millimeter or 2 centimeter. This length of the detector. With respect to that, what happens in 20 millimeter? It captures the umbra and penumbra both. The same detector. So obviously it is more efficient. Umbra and penumbra both are making the image. But this will not happen in the multi-slice CT. Since multi-slice CT, what happens? Umbra and penumbra will be captured by different detectors. So that is the disadvantage in case of multi-slice CT. So in multi-slice CT or multi-detector CT, each individual monolithic detector is divided into several smaller elements, as we have seen just now, and they capture each multiple parallel rows of detector, they capture the fan beam. So first it was in 1992, it was called CT Twin. It was by Elsint, which was manufactured as first multi-detector CT. It was 2-slice CT, that's why it was called CT Twin. Later 16 detector CT, 4-slice CT was also developed, then 16-slice CT was developed, and this first modern MD CT, which was having 16 rows of detector, what we call 16 channel detectors or 16 slice CT, they all having 1.25 mm long detectors, and 16 to 1.25 means 20 mm. So total 2 centimeter slice they can cover in the patient body. In principle, all 16 detectors row may simultaneously collect the data, and obviously these data simultaneously they are being collected. They were enormous data. Like just to give an example, a typical CT scanner may acquire 1,000 views per rotation. Means at every possible angle they take the views. So 1,000 views in one circle of the tube, X-ray tube. Suppose 800 detectors are there in one row. So it becomes 1,000 into 800 into 16. So it comes around 13 million measurements. And it happens in just one rotation, which takes 0.5 second, half second. So in half second, one has to process 13 million data in 16 slice CT. And even that time our computer was not so fast. So obviously it was a problem. So slowly as the computer speed increased, we went for further 64 slice and further. The first version of MDCT has simultaneous data collection in 4 slices, and these fed to the 4 channels. So slices and channel, each slice may be connected to the channel. So channel to take the data. This is the rays, 1,000, when we say 1,000 projections, these are the rays. I mean at every angle, X-ray tube which is rotating around the patient has to fire, and the detector on the opposite side will take the data. So at every possible angle, see in one circle, it may give you 100 projections, 100 views it can take basically. So that's why an enormous data. So what type of channels and detectors in MDCT we can see, and here we can see in the A, this is 16 row channels having 125 width, and this is jet side. You see the jet side. Jet side means patient length side. Here it is patient line. So it is 1.25 mm multiplied by 16, it becomes 20 mm X-ray beam width it covers. And here it is, since it is 4 slice, only 4 from 1, 2, 3, 4 will be taken. I mean 4 slices it will take to cover the 20 millimeter coverage here. If it is 8 channel, sometimes it is 4 channel, it is 8 channel where 8 detectors simultaneously can be activated and the data can be collected. This is 8 channel CT, 8 slice CT, where this thickness, now the thickness of the detector here in this B, it is 2.5. How they have come? 1.25 mm has been joined, so it becomes 2.5. This is called binning. We bin it. 2 detectors can be binned, 3 detectors can be binned, 4 detectors can be binned. So binning give you the slice thickness. In single slice CT, slice thickness is determined by the collimator. But in multi-slice, multi-detector CT, it is determined by the binning of the detectors, the small detector elements basically. Like in C and D, if you see, this slice detector thickness are not even. In A and B detector size are even. So C and D are called adaptive type, adaptive detector, where the central detectors are smaller, like 1.5, 1 mm long, but the here in the C, we can see the peripheral is 5 mm. In the similar way, here it is different. So here it is just to make having all types of thickness possible, so that from 1 mm to 5 mm we can get all types of thickness possible. That's why this type of arrangement has been done. This is called adaptive array. This is the binning. Like if you see the down one, bottom one, this is single detector, 2 detector you join. Joining means electronically join. Just you take the data from these 2, so it becomes binning of 2 detectors, binning of 4 detectors. So slice thickness you can choose at your willingness. So this is a 16 slice scanner which began in 2002, and if we see here thinner slices we got from 0.5 mm to 0.75, and the thicker element was 1 mm to 1.5 mm. If we see here, there was GE, Philips, Siemens and Toshiba we have compared here. GE, if we see, GE gives you 2 centimeter, 20 mm total length of the detector in the detector side towards the Z. This is a Z direction basically, Z axis towards the length of the patient. So here the middle one is 16 detectors of 0.625 mm length. then it was 4 mm, 4 slices of 1.25 mm, the peripheral. So this is adaptive. Philips and Siemens also has got adaptive, but the central smaller detector was 0.75 mm and the peripheral were 1.5 mm. Toshiba also has got 16 central detector, which is only 0.5 mm, while rest peripheral is 1 mm. So that's why we can get various types of detector sizes. But if we see total length in G was 2 centimeter, 20 mm. In Philips and Siemens it was 24 centimeter, 24 millimeter, so 2.4 centimeter. And Toshiba, it is the highest, 32 mm coverage, so it is 3.2 centimeter coverage basically. So this coverage tells you that how fast whole body scan you can take basically. Here if we see how when you go for taking the, making the specifications for getting any CT, then this things comes into picture. Like if we go for 64 slice CT scanner, so GE and Philips, they have simple 64 slice detectors having 0.625 mm width, first one. Siemens has got only 32 detectors, not 64. And they are adaptive, 0.6 mm in the middle and the periphery is 1.2, but they have a flying focus concept. What is flying focus concept? They have 32 detectors, not 64, but they give 64 slices image. They have flying focus. Focal spot means X-ray production spot. That they shift it after 32, they shift it by 0.3 mm towards the Z axis. And they get another group of the image from the same 32 detectors. So that way it becomes 64 slice, but they are using only 32 detectors. So that flying focus, that is a Siemens proprietary item basically. And Toshiba, again, they have 64 slice, 64 detector of 0.5 mm. So when you compare, it becomes a really problematic that where will you consider it is 64 slice, or you want to take detectors, number of detectors into picture. Since detectors are very costly, it does affects the cost of the system. Now, since our width of the X-ray beam is increasing, scatter is a problem in multi-slice detector or MDCT. Like MSCT beam width is much wider than the single slice CT. 64 slice have 4 centimeter or 40 mm beam width. So it leads to the scatter reaching the detector. So nearby detector should be protected from the scatter from the other detectors. So how to do? By just making septa, deeper septa. So each detector is separated by septa like this. Septa which prevents the scatter to reach to other detectors. If in MDCT there is one thing called cone beam CT. What is happening if you see the left side A, what happens? This X-ray beam is diverging. So when it starts, it is source at lower size, and when it hits the detector, it becomes diverged, it becomes wider. So it means when X-ray beam is entering into patient, it is smaller. When it is exiting on the other side, it is wider. So it means various separate other detectors, they are seeing different types of X-rays, since they are being detected by different scatter as well as different type of direct X-rays. So this gives you cone beam effects. These effects give streak artifacts. It becomes the streak artifacts basically for the thicker slice. This is for even single slice. A is the single slice SSCT. What happens in B when it is multi-slice CT? The periphery detector, they detect the different tissue basically, and this becomes a problem. So we use for that, manufacturer has come with the cone beam reconstruction basically. And in single slice CT, see there is a when it rotates, when X-ray tube rotates around the patient, it means 0 degree, 180 degree, then 160 degree. It means same tissue is imaged twice. X-ray tube is this side and then downside also, upside and downside. So when same tissue is imaged twice, artifacts can be reduced. But this does not happen for the peripheral detector in multi-slice CT. So cone beam CT becomes, in cone beam CT effects becomes more pronounced in multi-slice CT. So that's why various reconstruction algorithm we have to use. Now the pitch. In MD-CT, it is a bit slightly different concept. There are two pitch definition in multi-detector CT, MS-CT. One is called collimator pitch. It is table travel per rotation divided by the total X-ray beam width. Like here, the beam width is X. If you see left side, X. So table travel in one rotation inside divided by X is the collimator detection, collimator pitch. And another is called detector pitch, where table travel per rotation divided by D, just the width of the one single detector. These are the two pitch in the multi-slice CT. Like 20 by 20, if we see here, 20 centimeters suppose is the total X-ray beam. So it becomes 1. I'll take 5 minutes, sir, further. And detector pitch, if it is divided by 5, it becomes different. So this is the difference in multi-slice CT and single-slice CT in the pitch.
Prateek Kumar, time is up, sir. So try to
conclude,
sir.
I will just summarize it.
Thank you.
Jet sampling in MS-CT is a really, this is a challenge since multi-slice CT, when it moves the detector, whole detector, we take one by one basically, and in single slice it is easier, but it is difficult in multi-slice CT jet sampling since whole four slices or 16 slices we move. So we see further that how noise are affected. This is the low contrast noise, where noise, this is affected by pitch and interpolation algorithm. So it becomes more important for MS-CT basically, this low noise. And if we see here the consequences, what is there is 40 slices of 5 mm slice, 5 mm thick, and 320 slices, 0.625 mm slice. Our scan size is same. So obviously here, these scan where it is multi-slice, since every detector detects the less number of X-ray photons, it becomes more noisy. MD-CT, in general, MD-CT images are more noisy, so we have to use certain way to remove the noise. Advantages are that 3D is easier, 3D making is easier there. We can reduce the dose by MM modulation, and then cardiac CT, it is advantageous, since in cardiac CT we can get retrospective gating as well as prospective gating. Thank you very much.
Thank you, sir. We may take 2 questions because we are already late. So, Doctor, yeah.
Thank you, sir, and thank you for very wonderful talk. In short, I can say you have shown us scanned image of the scanner. And my question is, do we compromise with the flying focus technology, with the clinical aspects, with the reduced price of the scanner?
Yeah, in fact, price are reduced in flying focus spot. If I have understood, you are talking about flying focus of the Siemens. Yeah, so it is cost is reduced, no doubt, and I believe that clinically not much problem is there, since we do have flying focus spot in our center.
Dr. Dwivedi.
Thank you, sir. Just a short question. So often we encounter the same challenge, you were talking about, like even in radiation oncology or even in neurosurgery, other departments, while making the specification. So what should you suggest, like whether should we pick up like only, should we categorically write like 64 detector, then we take it out all the Siemens and other from the competition? So any tips or any suggestion, like even for 128 slice or 256 like that?
See, earlier it was slice war among the various manufacturers. Later it moved to the dose war, the least doses. They say sub-millimeter detector as well as the dose, lowest dose, less than 1 milligram, 1 millisievert dose, they say. See, ultimately, I believe that if you want to give the level playing field, yes, detector has to be there, but at the same time, if you say detector, somehow I feel with the practical things that image quality wise, I will say that image quality wise, they are not. Regulation says that the ARB in India follows single batch system. So even for pregnancy, they don't issue 2 batch. So that is one for India. Though in US, they do issue single batch for the fetal level to wear. Still, I inquired AERB, they say no, we follow single batch system, number one. Secondly, 1 millisievert is the dose limit for the occupational worker for fetus. So they should be posted where RSO confirms or they have estimated that it will not increase more than 1 millisievert during whole gestation period. That I wanted to add.
Thank you, sir. Now we move on to the next lecture. It's our distinct honor on behalf of myself and my co-chairpersons, I invite Professor Paneer Selvam from Sri Ramchandra Medical University, Chennai, and who's going to talk about CT image reconstruction. Professor Paneer Selvam, he is a postgraduate in medical physics as an adjunct faculty in medical physics at the same institution with more than 37 years of experience. He has been recipient of K. Subbarao Lifetime Achievement Award, Dr. V.P. Narayan Lifetime Achievement Award, Professor C. Retina Satpathy Endowment Oration. I invite you, sir, to deliver your talk. Thank you very much. Sir, we'll request at the outset to stick to the time. Thank you, sir.
Thank you, sir. Respected chairperson, distinguished faculties, residents, as well as the technologists and dear students. First, I'd like to thank the organizing committee, in particularly Dr. Dugesh sir and Mr. Binod Singh and Mr. Vivek for inviting me for this wonderful session. And initially they said I am supposed to talk on principle of CT, and they asked me to change it to reconstruction technique in CT scan, which is not an easy topic as such, but I'll see to that as much as possible. I'll try to make it simple. Particularly it will be useful for the residents and the technologist. Already Dr. Pratik Kumar has told that, one second. Okay. The basic concept he has explained that a thin slice is examined from multiple angles, as you see in this diagram, with pencil type of X-ray beam initially, and later on it has been converted into a wide fan beam. Whatever the radiation transmitted through the patient was counted by the detector system. All of you are familiar with that. That data is fed to the computer, and you know that we are going to expose the patient all the 360 degree. So the data is going to come all the 360 degree. It's not going to be a simple data, it is a complex data. Whenever you have a complex data, you know that you need a computer to process the data. Normally in the mathematical calculation we say it's a formulae, but here we call it as a complicated formulae, so we call a new terminology called a mathematical algorithm. So that is used as a reconstruction, as a tomographic image finally. So this is the basic concept behind image reconstruction. Coming to the image formation in CT, all of you please listen carefully that the sequence what actually involved in this is, As soon as you enter the patient registration, after that you do an accusation. You are familiar with that. And finally, what is the output we get is a raw data. And this raw data may not be useful where you cannot identify the anatomical details. So this has to be reconstructed. So we are going to see the technical principle behind what actually reconstruction means. That's going to be the goal of the talk for another 15 to 20 minutes maximum. See, coming to the image reconstruction, generating an image from the acquired data involves determining what actually the parameter we are looking into is the linear attenuation coefficient. We talk about the differential attenuation. Similarly, we are going to find out the linear attenuation coefficient of the individual pixels in the image matrix. That is the concept behind the image reconstruction. So for that, a mathematical algorithm takes the multiple projection data and reconstruct into a cross-sectional image. Coming to the image matrix in detail, all of you be familiar with what you mean by matrix. Matrix is basically made up of rows and columns. If you have a 256 rows and columns, we call it as 256 by 256 matrix, and we also use 512 by 512. Take a small example of this image matrix. When you take into the small square in this image matrix, whatever you see as an image, the small box, we call it as a picture element. The total image, we call it as a picture, and one small box is called as picture element, which we colloquially and technically call it as pixel. Similarly, when you take the depth aspect, for example, if you see the depth, as he was mentioning about the slice thickness, 5 mm or 10 mm, so the depth is going to play a role in the thickness, then this is going to be termed as volume element because the depth is involved. Now it is going to be called as voxel. Coming to the reconstruction aspect, take one voxel. As I shown in the image, this is the total image. I have taken one voxel here. That one voxel I am representing here. When I keep the cursor on this particular picture element, what actually you see in the CT image as a radiologist or a technologist, you look for the attenuation value, ounce filled unit. So what actually measure here is when I keep the cursor, how it actually calculated is the incident radiation is taken as N naught. I'm not going to the pure mathematics, a simple logical thing only. I'm going to justify you how the computer is going to help in this. Then whatever coming is going to be called as N, and what you see mu is called as attenuation coefficient. There is a simple formula. It says that how to calculate what is coming out. N is equal to the incident radiation, and this attenuation is basically an exponential function, so we call it as E minus mu is the attenuation coefficient, and X is going to be the thickness of this particular voxel. So this is for a single voxel, the equation is like this. Suppose if I am going to have a 2 voxel, my equation is modified into mu1 plus mu2. Suppose if I am going to have 4 voxel, the X-ray can come like this, like this, like this, and like this, because you know that a tube rotates all around the patient. So if you take a 4 voxel, you see 4 equation has come. Similarly, if I have a 256 voxels, I have taken as a 80 voxel here as an example, you see that so much equation is going to come. When any equation going to be increased and increased, the human thing we may not be able to calculate easily. You need some sort of an algorithm to do the process. Hence, we call this as a mathematical algorithm which the computer is going to do for us. That is the basic fundamental principle behind image reconstruction. Now coming to the actual core of my topic, algorithm of our image reconstruction. As I was mentioning in the previous slide, thousands of equations has to be solved. If I am going to say 5 into 5, you will answer 25. If I ask 10 into 10, you say it will be 100. If I ask 482 into 692, you will be blinking. So you need a support of a calculator to do that. That we call it as a small formula is embedded in the what you call calculator. It solves for us. Similarly, here we have thousands of equations. So to determine the linear coefficient, because you are interested when you keep a cursor on a particular lesion, you want to know what is the attenuation value, the Hounsfield unit. For that, you have to determine the linear attenuation coefficient of all the pixels in the image matrix. So remember, as a definition, even in your Viva, if they are going to ask, faculties like them are going to ask a question, what do you mean by algorithm? Algorithm is a mathematical method for solving a problem. That's all, simple definition. Then coming to the detail about the various methods, there are three important methods are there: back projection method, iterative method, and much more complicated one, we call it as an analytical method, where we have a filtered back projection and Fourier transformation. As far as the today's session is concerned, I will be highlighting, because it's basically a CT workshop. So I thought I'll more focus on filtered back projection, and definitely more emphasis I'll be giving on iterative reconstruction, which is the butter of the day. Because for all the reconstruction technology what we have now, we are focusing on the dose reduction techniques, and this iterative method is going to help us. Keeping this in mind, I would like to share an example, analogy for you to understand really what actually mean by reconstruction. You have a beautiful music party is going to be there, so you have different types of instruments are going to be played, and you are going to be an audience. For example, a person is sitting here, the music what is coming from the stage to the last row, a raw data is going to his ear. With the help of the brain, his ear is going to recognize two aspects. One aspect is from which instrument it is coming, that is the positional data. Which instrument means that sound may be from piano or maybe tabla or from the flute. So his brain recognizes from which instrument, because already he has listened so many times. So it is going to be recognized by him. And second thing is how much it is going to come. How much in the sense, sometime flute sound will be dominating, sometime drum sound will be dominating. So how much it is intensity of sound. So what his brain does is two aspects. Positional information, from where it is coming, how much it is coming. That is reconstruction. Please understand, the X-ray coming out of the body is a raw data. But what the mathematical algorithm does, from where it has come, whether it has come from gallbladder or from spleen, so that is going to be called the positional information, how much it is coming. Hypodense or hyperdense, we are able to distinguish because of that only. That is called as image reconstruction. I hope you understand the analogy. One more analogy. When you see into the light, what you see above is a white light, we call it. But when I put a prism inside, in between, and if I see it, I am able to distinguish the colors. So what is the color, from where it is coming, how much it is coming, I will be able to do that. So what the prism does is the Fourier transformation or the iterative reconstruction, isn't it? So this is the basic concept you should remember. Two aspects that reconstruction technology is going to adopt. One is from where it is coming and how much it is coming. So with this, I'll go directly to the subject. Back projection is also called the summation method, which is the oldest means of image reconstruction. Of course, none of the commercial scanner uses this now. What is the principle of back projection? Unless you understand the back projection, you may not appreciate the filtered back projection which is used currently. Also called a summation method, as I said, the block is scanned from the top and left, all the sides it is going to be scanned. For example, can you see a block where this block is cut and it is removed? Simple example I have taken from Christensen book only. So now when I am going to project the X-ray, see this part hollow is there, so more radiation is going to be there. So intensity is dark. Here the intensity of radiation is going to be little lesser, and in the final stage it is going to be much. So you see the difference in the shades. That only I am going to draw as a profile here. So here it's a maximum radiation is going to come, because hollow block, so it is radiation pass. So maximum I am going to receive. Periphery it is less. So you see a variation here, which I am going to call it as a beam profile actually, or we are going to finally get an image profile. Similarly, what happens is, in this back projection method, when I have a radio dense material, it leads to produce a localized spikes in the image profile. That is the drawback in this back projection method. When the rays from two projection are superimposed or back projected like this, they produce a crude reproduction. They produce information, but crude reproduction of the original object. So that is the problem with this. This is taken care of by the filtered back projection, where the images are filtered to counterbalance the effect of this sudden change. A filter is something you assume that whatever the spikes happen there, it is removed, and finally you see a beautiful spherical means spherical, square means square. So that is the basic behind the back projection technique, and filtered back projection is the updated one, so that these spikes, whatever you see, will be removed and you will be seeing a Paka image as such. Now, The important thing which I want to explain, maybe I'll be taking 5 minutes only on this, is iterative method. It starts with an assumption. For example, I am in a teaching field, a batch is coming to me, I'll assume that all are good students. When they come there, I feel it's all are good students. That is my assumption. When I'll be knowing about them, after the first test I'll be knowing about each one of them, how actually they are performing. So my assumption may be wrong. So what I'll be identifying 3 or 4 students maybe in the what you call below average. So I'll be identifying them as a teacher, and I'll be giving a different shot of training to improve, and maybe at the second test I'll analyze that their improvement is there. So I assumed initially 100% they are good, but initially they may be 40. In my second training they have become 60, maybe 70, 80. So when I repeatedly I am going to do the training program or teaching which is going to be effective for them, because I will be knowing how much they can grab it. Accordingly I can make it, and modification in my teaching I can do it, so that I can bring them from 40 to at least to 80 or 90%. So what I assumed, I am trying to bring closer and closer by what? By giving a training, isn't it? Similarly here, I am having an assumption that this is my image quality I want. But when I do with this one initially, I may not be able to get it. So I will be doing fine-tuning, I will be able to get the good image. Please remember at the end of the session, I will tell how actually they are doing it. So it compares the assumption with the measured value, makes the correction to bring the two into agreement, process is repeated unless both the values are same within the acceptable limit. This is the principle behind iterative method. There are different methods are there based on the correction sequence. They have a simultaneous reconstruction technique, ray by ray correction, point by point correction. Different methods are there, but the simplest one is what is the company commercially we have is the ray by ray reconstruction technique. This image also I have taken from Christensen, because it's very easy for us to understand. You also can go back and refresh it. See, I have taken a 2 by 2 matrix, simple thing, very difficult to take 256 by 256. I have taken 2 by 2 matrix. I have given an arbitrary value like this, 9715. This is my assumption. This is some assumption value I am going to give, 9715. So what I do is, first, so I am explaining you how the reconstruction happens inside the system. So when you look into this, 97, you add it, how much it comes? 16. 15, how much it is come? 6. This is my first work done by the iterative reconstruction. Second, it also does this in vertically, 9, 1, 10, 7, 5, 12. Then diagonally also it will do some calculation. 7 plus 1, 8, and 9 plus 1, 14. So this is the way first it will start. Then what it will do is, it will take this component 16 and 6. What it will do is, it will actually divide by 2. You may ask why 2? Because I have taken 2 by 2 matrix, so I am going to divide by 2. Now what happened? I will make a 2 by 2 same matrix, that is 4 pixels will be there. I will put 16 by 2 is how much? I will put 2 by both the area 8, 8, because 16 by 2 is 18. Similarly 6 divided by 2, 3, 3 it has come. Now what I will do, I will go to the vertical area and I will add up this 11, 11. Now originally what is this in vertical? 10 and 12. If you take this is 10, this is 11. So what is 10 minus 11? That is minus 1. Minus 1 divided by 2 is minus 5. What is originally 12 and what is this one? 11. 12 minus 11? 1. 1 divided by 2, 0.5. Don't get worried why I am dividing by 2. It is because it is 2 by 2 matrix. So now it is 0.5. 0.5 is a different. Now with this value, what is 8? 8 minus 5, 7.5. 3 minus 5, 0.5, this is 2.5. Here 8 plus 0.5, 8.5. 3 plus 0.5, 3.5. Like that I do. Similarly, now I will be doing a cross, 8.5, this one 11, this also 11. What is the original one? 8 and 14. 8 minus 11, how much? 3. Okay? What divided by 2? Minus 0.5. Here it is 14. Minus this one, 11, 3. Then it is going to be plus 1.5. Isn't it? This is 14, this is 11. Difference is 3 divided by 2 plus 1.5. Now what happened? You see, this one when you make it, how much it comes? Minus 1.5, isn't it? So 8.5 minus 1.5, now it will become 7. 2.5 minus 1.5, it become 1. Similarly, this side 7.5 plus 1.5, 9. 3.5 plus 1.5 become 5. Now you add up everything, it has become 9715, which was the original one. So that is called as iterative reconstruction. Make an assumption, do some mathematical work, and finally you achieve this. In case of CT scan, what do you mean by iterative reconstruction and how they are able to reduce the radiation doses? They are trying to reduce the noise as much as possible. Whenever you do something, you get some noise, you try to extract that noise. So your image quality, that is the reason by giving a low KVP parameters, they are able to achieve a better quality image, which in turn reduces the patient dose. That is the principal concept behind iterative reconstruction. Okay, so the iterative algorithm designed to work both in raw data and reconstruction domain. Principle, I'll give a 2 minutes theoretical explanation how to write for examine. Analysis noise in the raw data and adaptively apply the noise correction. I told you just now, no? What actually iterative recurrent, why it is superior? Because it analyzes the noise in the raw data and apply the noise correction, which in turn increases the signal to noise ratio with the low dose accusation protocol. And step 2, after the noise correction, iterative data enhancement algorithm done at the reconstruction domain. So the first model analyzes the physical property of the CT system at the time of accusation, and the second model characterizes both the electronics and the quantum noise in the raw data domain. Finally, the projection noise estimation take care of a noise as well as the artifact reduction, which enhances the image quality. That is the ultimate goal of the iterative reconstruction. A sophisticated iterative technique is then performed. As I mentioned, the objective is to optimize reconstruction for the particular body region being scanned by detecting, preserving sharp details, and smoothing the image at the same time. The complete iterative 3D reconstruction therefore increases what? SNR while improving the spatial resolution. Spatial resolution means ability of the system to distinguish two nearby object as a separate entity. That is called a spatial resolution. In summary, with the use of iterative reconstruction, image noise can be reduced while spatial resolution and structural edges are preserved and even improved, which as a physicist technically we call it as improved low contrast detectability. This iterative algorithm permits scanning to be performed at lower doses. That is a greater advantage. Dose reduction depends on the investigation. A range of 50 to 75% also can be reduced. When you look into this, without iterative reconstruction, they are able to achieve the effective dose of 20.07 millisievert. Means with iterative reconstruction, they can get around 6.8 as far as the abdomen pelvis CTs are concerned. Similarly, for chest CT also 7.8 for the regular filtered back projection, but in case of iterative it is 2.9 millisievert. See the huge difference in dose. Similarly, here also you see the DLP is around 383, it is 128, nearly 60% dose reduction, just 1 minute, sir. And similarly, I have put for different scans. Finally, the conclusion is nearly 50-60% you are able to reduce it. And chest 40 per MAS image acceptable with iterative 75% dose reduction, abdomen around 50%, and pediatric around 38% for chest it is 46 and 38 for abdomen CT. This sort of a drastic reduction in dose can be achieved. So the takeaway points in traditional filtered back projection, higher spatial resolution is accompanied by the higher image noise, but here delivering previously unattainable levels of combined noise reduction, resolution gain, improved contrast, and artifact suppression. So these are the different vendors have a different names for that. And as I said, to make a summary relative to the filtered back projection, as far as the dose is concerned, good reduction in percentage, low contrast detectability is increased, image noise is going to be reduced. So these are my various references. Any queries are coming? One message for dear students, ready to learn. A lot of complicated topics are going to be discussed today and tomorrow. You should have an interest in what you call ready to learn. That's very important. You should not stagnate in the comfort zone. Please come out of it. Wish you all the best. Thank you.
Thank you, sir. It was really a very complicated technique of reconstruction which has made the life of radiologist easier and comfortable.
Thanks.
So understanding the whole process of reconstruction, mathematics behind, the technology behind, and you have explained it in a very lucid manner. Thank you, sir.
Thank
Any
you.
questions from the floor? Durgesh. One who knows the most has the most questions as well. So this is Dr. Durgesh, knowing the most and has the maximum questions.
Hopefully I can answer.
So, sir, it's my responsibility also because you traveled so far. So someone must ask some question. If anyone has any question, I mean. So just let us know, like, if it is like even the novel, the new cities. Is there any other kind of deep learning based method also people have like started applying also, because we have not covered that because of the interest of time. Thank you.
Yes, sir. Basically, which we focus, I focus particularly in this session is on basically on the computer-oriented reconstruction technique alone. What you say is a deep learning, when the AI is going to be incorporated into that, there also when you make a multiple data, when you are going to analyze, there the focus is also going to be on noise reduction. Once the noise reduction is going to happen, ultimately the optimizing the image quality is going to be improved. Definitely the deep learning will be helpful in reduction of the noise, which in turn will going to improve the image quality and the reduction in the dosage also. Thank you.
Thank you, sir.
Thank you,
So
sir.
if there is no question, we move on to the next presentation. I now invite the interventional radiologist from KGMU, Dr. Saurabh, who is going to talk about the navigating the maze, making the life of technologist on CT scanner more comfortable. Dr. Saurabh Kumar, please. Saurabh, please try to limit your talk within 20 minutes. Thank you.
Thank you so much, sir, for the warm introduction. And a very good morning to all the respected faculty members on the dais, my seniors, colleagues, and ladies and gentlemen. So the topic given to me is a dilemma and challenging the daily CT scans we encounter in daily imaging. So it looks a little very easy topic, but to summarize the problems, it becomes a big challenge to me as well last night. So because we really face the problems in the daily routine CT scan imaging, but if somebody asks me to summarize all the problems in a short presentation, it's a big challenge. So just to have a look at the evolution of the CT imaging, so as we progress in imaging technology, right from 1895 to 2024 era, so as we develop in imaging, we have to face the challenges too much. So we progress in both the way. We advance the technology and at the same time we face the challenges progressively. So what are the common problems that we are facing in the routine CT imaging? The very first common challenge is resolution is too low. The common complaint of the resident to the technician, resolution is too low. I can't see what I am supposed to see. Then the another is can't scan the whole sample. This is the challenge from the technician side. And CT images all too dark, all too bright. Again a big challenge because you are imaging the patient to get the disease, to get the information about the health. Now there is no density contrast. If there is no density contrast, you cannot make out the disease pathology ongoing. And if the scan takes too long, it's a big cost from the patient side and it creates a lot of problem to you because everyone is in a hurry, nobody has a time. And files are too big. If the files are too big, it takes a lot of time in reporting, it takes a lot of time for the data reconstruction, data transfer, and all the reconstructions. Then the topic, another complaint is analysis of the images and all the things. And the another big problem is bariatric CT imaging challenges and solutions. So I'll discuss one by one. So resolution is too low. It's the biggest complaint from the resident side doctors on sitting on the computer system on the console. So because if I can't get the things what I'm supposed to see in the CT imaging, it's a big problem. Because it's of no use to me, because if I can't give the fine details to the consultant referring physician, it's of no use to me and the referral physician as well. So for resolution under 500 nanometer, we need to have a ultra high resolution CT scanner, or we can go for the synchrotron beamline imaging. But there are so many calls from the other departments, like somebody, some people try to know so what is the pathology of that, like suppose the patient is having some consolidation in the left upper lobe, and the patient is not responding to the optimal treatment line which is being given to the patient. Then physician asked, just tell me what could be the etiology. Means just they want to know the bacteriology, they just want to do microscopy, but that is again a big limitation from the CT image. We cannot say the histology. Just so we have a limitation. If they want to see the things, we can ask for the optical microscopy, scanning electron microscopy, transmission electron microscopy, and FIBSEM. Now then another problem is can't scan the whole sample. So there is suppose there is a big patient and we routinely encounter a morbidly obese patient who cannot fit into the gantry size. So then what will you do? Because you have a limited gantry, maximum available gantry diameter of 90 centimeter, and if the patient girth is having more than 90, then you can't do anything. You just explain, so sorry sir, we don't have an option for you. You can have some other option for your imaging and disease detection. Then the another problem is CT image. If the CT image is too dark or too bright, again there is a big problem in reporting and big problem in identifying the disease and characterization of the lesion. So if the sample is too heavily absorbing the X-rays used for the scan, the images will be all dark and the CT image will be bright, and vice versa. And in that cases, you need to tailor your dose protocol to get the optimal information of the patient health status. So another problem, if there is no density contrast, like if you have suppose you have scanned the liver, and if there is no density contrast, then again you won't be able to get the findings from the disease liver or the lesion. So you cannot characterize the lesion. So in that cases, we can go for the phase retrieval reconstruction and phase contrast imaging both. So now again, because everyone in this era, this time is in very hurry. So scan time, if you are taking too much scan time, so it creates a big chaos to you as well. So if the patient is in hurry, better counsel him, and in that case you need to have a good talking skill to have your good mental peace. And always remember, avoid hurry, worry, and curry, because all these worry, hurry, curry makes the big problem to you, to the patient, to you, and to all the healthcare workers related to all these works. So now another problem is if the file data is too big, and if the file data is too big, then your computer is going to take a lot of time in reconstructing, and you are in little hurry to make the reporting, to extract the imaging findings. But if the file is too big and your computer is not optimal to that big data processing, so you are again in a problem. And these are the commonly encountered problems, like when we see the cases in console, it takes a lot of time in getting the image processed. So and then is the storage space run out too fast. In that cases, you need to delete the older data very frequently. And in that case, sometimes you delete the data which was very important. So because to get the new images data, new patient, you need to have a good space. So how do we tackle them? So we have certain things like if we have a problem like this, if the analysis is taking too much time, so we can go for there is need of supercomputers. there is a need of reducing the file size by cropping down and use of cloud computing. These are the some methods to how to fasten your work. And if there is a storage problem, you can have a bunch of terabyte external drives to save data for your future use, and you can use NAS, Neta Text storage, and then cloud storage services. So now the analysis. CT image processing and quantitative analysis is a fascinating field in the era of research and AI. Like we are in the field of research and AI, so we need to analyze the data very frequently. We need to have a good data number, and we need to analyze to extract some result and some studies. So in that cases, to smoothen your work, we have some object research system, volume graphics, digicam solution, and thermophysics scientifics, which makes your job easy. Then comes a big challenge with the bariatric CT imaging. So because the bariatric patient, they are not fit for the conventional imaging, because in that case we need to have a scan with the adequate table load limit. Like suppose you have a good gantry diameter, but the patient is too heavy that it cannot be moved to the table, and table jams. Now it beeps. Now what will you do? You cannot lift the patient and put into the gantry. So, and then another point that you need to have a large gantry aperture, a large scan of field of view, and a high power generator is requisite for the bariatric imaging. So the large gantry aperture, so we have moved from the large gantry aperture. Previously it was around 70 centimeter. Now we have moved to till 90 centimeter. So these are some of the vendors like the Siemens, Philips, and Toshiba. So they have around 80 centimeter aperture, and then they have aperture of around 85 centimeter, and then the Toshiba Aquilon have a aperture of around 90 centimeter. So a little bit of this dilemma of imaging the morbidly obese patient is solved, but it's like you cannot fit the elephant into the small scan. So there are some group of patients which can never be imaged, which cannot be imaged on these provided these imaging systems. So the common CT artifacts are the bariatric imaging. So we have a quantum model and the noise, and the truncation and cropping artifact. So the quantum model and noise is the most common imaging artifact in the bariatric population. It can be minimized by the sequentially increasing the tube current product and the tube voltage. On the other hand, the truncation and cropping artifact is due to the excessive soft tissue falling outside the scan of view. So the quantum model and noise. So these are the some manufacturer given iterative reconstruction just to have a good image information. So these are given from the vendor side, and this is the image which shows as we increase the tube current and the voltage, so you get a good image information and reduce noise as well. Now the truncation and cropping artifacts. In a larger obese patient, when you put some patient in the gantry, some of his tissue falls outside the scan area, and in that case, then these two artifacts like truncation and cropping artifacts appears, and these may give a fast imaging, fast diagnosis, and sometimes you may miss the diagnosis. So the first image shows the truncation artifact. Like if you suppose the patient is morbidly obese and you put him in the gantry, then some of either this anterior abdominal wall, which is falling outside the scan area, and on the side you see the upper limbs, it again falls outside the scan area. So these findings will be missed, and the computer is so algorithm based that it will take as a attenuation, and the images will be very bright, and you can easily miss the findings which were going on here. And on the other hand, the cropping artifact, suppose the patient is lying not very exactly in the supine position, so some of the tissue is again falling outside the field of view. So suppose this tissue is falling outside the field of view, and you image the patient, and then in that case you miss the some diagnosis which I have. Suppose the patient is having a ventral hernia, and the patient was lying like this way, so you can easily miss the diagnosis. So before you put the patient in the gantry table, you need to have a good position, so as not to miss any pathology or anything which is going on to the patient. So the challenges in the bariatric patient, other challenges are intravenous access. vascular enhancement and parenchyma enhancement. Like intravenous access is a big challenge because the patient is so very heavy, you cannot have access in the veins. And the veins are, and the access veins are only in the peripheral side. And these veins are not optimal for giving a high flow contrast. Like it's like in, if the patient is thin built, you can easily access the brachial vein and the veins in the cubital fossa. So they are good for the rapid contrast injection. But the veins in the periphery, in the distal, like in dorsal of the hand, they're not good for the fast flow injection. In that case, if you do it, it may rupture the vein and there is a contrast exacerbation which may complicate the patient health as well. So intravenous access, if you have a problem in accessing the vein for the contrast, ask your radiologist register or the consultant sitting over there to have the access either image guided or some other route, rather than trying multiple punctures. Then vascular enhancement, another problem. So the degree of vascular enhancement is inversely related to the cardiac output, and since the morbidly obese patient, they have a compromised cardiac output because they have so many underlying pathologies going on. So a test bolus is usually necessary to determine the ideal scan time so as to have a good image quality and good contrast enhancement. Then another one is the parenchyma enhancement phase. So this parenchyma enhancement is actually a component of intravascular and extravascular compartment, and it's a dose dependent rather than a flow dependent. So the patient, like in morbidly obese patient, if you have no access in the large vein and you have only access in a small vein, then slow injection slow injection is the only way to give him the contrast, because you cannot be very fast. There is a risk of vein rupture and the contrast exacerbation. So in that case, it may help to image the patient who are morbidly obese. But the pitfall to this principle is, suppose the patient is having a hypovascular lesion in the liver and you have a long injection time of the contrast, that lesions could be easily be missed up. So how do we have a good optimal imaging, good information in the this obese patient? We can scan the patient at lower tube voltage. So these are the images that the patient was having image at the high voltage, and this was the same patient which was imaged at the low voltage, and you see the contrast, better contrast opacification of the pulmonary trunk compared to this side. So the take home message is know the limitations of your machine. Like you cannot image everyone, and you cannot give the histological details of the disease. So change the imaging protocol as per the patient habitus, and always follow the LRA to reduce the radiation dose to the patient, and do the needful whatever is possible to the patient. Thank you so much.
Thank you, Saurabh.
Thank you, sir.
It was a wonderful talk. Any question from the house? Any suggestions, comments, clarifications? I hope some technologists are also sitting in the hall. Do you have any question? If none, we move on to the next item on the agenda. Thank you, Dr. Saurabh Kumar.
Thank you, sir.
So this was the last presentation in this session. Now we close down it and invite the organizers to take over the proceedings. On my behalf and behalf of my co-chairpersons, Professor B.K. Ojha, Professor Anit Parihar, Professor Archana Gupta ma'am, Professor Sachin Khanduri, and Professor Manoj Kumar, I thank the organizers for giving us the opportunity to chair such a wonderful session. Very useful topics being deliberated. Thank you very much.
Thank you to all the speakers. A little announcement for the paramedical students. If anyone has posters, kindly give it to Ms. Shivangi.
A special commendation to each speaker for their outstanding contribution to the session. We extend a warm invitation to our esteemed chairpersons to please come forward and felicitate the accomplished speakers.
Chairpersons, kindly come forward. I would like to call upon stage Professor Prateek Kumar sir.
A huge round of applause.
Professor Paneer Sevlam sir and Dr. Saurabh Kumar sir, kindly come on stage.
Yes, sir. We extend our deepest gratitude to the chairpersons for steering the session with grace and expertise. For that, I would like to invite Professor Durgesh Kumar Dwivedi sir to felicitate Professor MLB Bhatt sir. Professor, I would request Dr. Anil Rawat sir to felicitate Professor B.K. Ojha sir.
Dr. Nitin Arun Dikshit sir to felicitate Professor Archana Gupta ma'am. Dr. Priyanka Yadav ma'am to felicitate Professor Anit Parihar sir. Dr. Saurabh Kumar sir to felicitate Professor Manoj Kumar sir.
Okay, sir. Thank you to all the speakers and chairpersons for this wonderful session. As we seamlessly move into the next session of the conference on recent advancements in CT, I encourage everyone to get ready for a continuation of thought-provoking presentations and discussions. We are honored to invite the chairpersons of this session.
Professor Abbas Ali Mehndi sir, Vice Chancellor, Era Medical University, Lucknow. Professor Ravindra Kumar Garg sir, Professor and Head, Department of Neurology, KGMU. Professor Anup Kumar Verma sir, Professor and Head, Department of Forensic Medicine and Toxicology, KGMU. Professor Shailendra Saxena sir, Head of Center for Advocacy and Research, KGMU. Professor Amit Nandan Dhardevedi sir, Professor and Head, Department of Radiodiagnosis, Banaras Hindu University, Varanasi.
Your expertise and guidance will undoubtedly enhance the quality of discussions. I would like to request the chairpersons to please introduce and invite the speakers of our second session.
So, can we start? Yeah.
Yes, sir.
So now I invite Dr. Gaurav Raj for this session. He is the first speaker of this session, and his topic is photon counting CT scan. So Dr. Gaurav Raj is currently working as the head Department of Radiodiagnosis, RML Institute of Medical Sciences, and earlier he was part of KGMU. Dr. Gaurav Raj.
Thank you so much. So, good morning friends. Photon counting CT. So this is the in thing. If you talk of CT scans today, if you talk in radiology, the latest advancement, you cannot talk leaving out photon counting CT. So to be honest, in the last 2 or 3 years, 2 years I would say, I have not seen an MD examination paper without a short note on photon counting CT or a long, question on photon counting CT, because this is the latest development, this is the thing which is going around. So whether you are a technician, whether you are a MD student, whether you're a radiologist, you need to know about this cutting edge development which has happened. To be honest, when I go to take Viva of MD students, BSc, MSc, technician students, those students who are doing well in Viva, this is my question for them. And I really give good marks to people who can answer this, because this technology, every one of you should know. Okay, so what is photon counting CT? The way it is advertised among radiologists is capturing the information of every single photon. What do I mean by that? So the history of CT scanner has been a long one. It started in 1973 when most of you were not born. Right, when one slice of CT scan took 5 minutes. Imagine one slice in 5 minutes. And from there coming to the 80s, 90s, and finally now when thousands of slices can be taken per second. We have come a long way, right? We have come through long generations of CT, starting from first. Right now we are working on the 7th generation. And as I told, the first generation started with 5 minutes required for a single image. The second was 18 seconds per slice, then third was less than 5 seconds to complete a single slice, and in 4th generation we added detectors. We started with 800, we added more than 5,000 detectors, and it was faster. Then finally we had 5th and 6th generation, which included spiral or helical CT, what we do today, right, which has a detector ring instead of a stationary detector, and we could take multiple slices from patient, acquired at about 1 second per slice. Now, this image is of a recent photon counting CT scan installed in Japan. It's a prototype. So right now there is just one company, Siemens, who is actually marketing this photon counting CT. Rest of them are all prototypes. So it is actually complex physics. It is beyond, 20 minutes to make you explain the exact complex physics. But what I can say how it works is, how a conventional CT works is that a conventional CT is a two-step process. That means first X-ray comes from the tube, it gets converted into light, and then that light is converted into electronic signal. Now, the benefit of this is it's a robust technique, it's mature, cost-effective, and reliable. But it is also limited, because when what happens is X-ray to light and light to photons or pixels means loss of signal, and it means more radiation dose. So what photon counting CT does on conventional CT, improves on it, is that it's a one-step process from X-ray right to the electron level. So it's fast, very fast. A single pulse can be about 10 to 20 nanoseconds. Right, so I'll try to make it simple. Suppose there is a bucket, right? There is a bucket and you've got multiple drops going into that bucket. Consider each drop to be, one photon. So these are colored photons. So what happens in a conventional CT scan is all the energy or all the information of all the photons are taken together. And along with it is taken the dust particles, which are the noise. What a photon counting CT does it removes the dust particle or the noise and just selects the ones which are useful for information. Now, this mechanism or this photon counting CT principle was actually there for a long time. It was first started researching way back in 2003, and they kept on researching, and it was actually in 2014 they came up with the first prototype of this machine in Mayo Hospital, Rochester, where clinical trials on patients were done, and it was in September 2021 that the FDA gave the first certificate and was approved for clinical use. So what are the benefits of proton CT? It has improved spatial resolution due to smaller detector size, higher iodine image contrast, high resolution imaging. We will look into each and every. But what was the exact challenge was this. So this is what made it so difficult to come out with this technology even after 15 to 20 years. It is this crystal. Because in photon counting CT, unlike the normal conventional CT, they do not have a porcelain scintillator conductor. They have a conductor made of a special crystal of cadmium, zinc, and telluride in its detector. And this crystal is a very unique thing because it is very difficult to grow this crystal. This crystal is available in nature in small amounts, mostly in Japan. It takes approximately 2 to 3 millions for crystals to form. So they thought of making it in-house. It takes 3 months to prepare one crystal, right? And with impeccable technology, with purity reaching to 99.9%. If the purity goes below 90%, you cannot have a pure detector, right? So consistent quality is needed, and because of this crystal, which was the limiting factor, they took 20 years to produce this CT scan. So this is a crystal growing lab where this detector technology gets its birth. Years of research and development have gone into this. Okay, so as you know, stapes, which is the smallest bone in the human body. So this is the normal conventional energy detecting CT where you, of course, can see the stapes. And this is the photon counting detector CT where you can see the stapes much better at 50% less dose. Okay, again coming back into the physics. So what happens in a normal CT scan, conventional CT scan, which is also known as energy integrating detector CT scan, is that light energy, first X-ray comes, it gets broken up here, then it is absorbed by a photodisk and converted into light energy. But what happens in this process is that there is a lot of dead spaces leading to noise, leading to signal to noise ratio decrease. So, but in a photon counting CT scan, they have a semiconductor, which I told you, made up of cadmium, which what causes is that it absorbs all the photons, it selects the photons which are best for image quality. So there is no noise. Small detector pixels, we all know that smaller is the detector size, pixel size, we get better high resolution images. What happens in modern day scanner, if you decrease the size of the pixels, you have to increase the dose. So 50% dose has to be increased if you are decreasing the pixel size, because smaller is the pixel size, better is the resolution, right? But in a proton CT, you can decrease the pixel size, but you do not have to decrease the dosage. Second, elimination of electronic noise. How do we do that? So what happens is, when an X-ray works, when a CT tube works, it gives a lot of radiation of all different energies. All energies which are more than 25 kV are used, all energies which are less than 25 kV is not used, and that non-usable energy is noise. Now what a photon counting CT does is, it completely removes this noise. So only all energies more than 25 kV are selected, resulting in a high resolution image, very high resolution image at a much less low dose. So this is a regular CT in a very low dose, and this is a photon counting CT in even lesser dose. Right. Intrinsic spectral sensitivity. What do I mean by that? So you know the latest, before photon counting, the latest thing was dual source energy, right? So what dual source energy was, that we had two sources of energy and we used to switch between the two energy levels, right? Getting various iodine maps. Now in photon counting, you can have multiple energy levels. That means, look, from 25 to 90, you can have 4 energy levels. That means it is as good as not dual, not triple, quadruple source, right? So this really helps in cardiac imaging. How does it help in cardiac imaging? It helps in cardiac imaging. Look, we have multiple images of different energy levels. So what you can do is, you can completely take out calcium or calcification from your images, right? So if artery is heavily calcified, you know, we do Augustin scoring, and usually if the artery is very heavily calcified, we are unable to report, we are unable to see the lumen of the vessel. However, in photon counting CT, with the help of this various energy levels, you can actually see, you can actually remove the calcium from the images, and you can report very easily all types of coronary angiograms. Then equal contribution of lower energy quanta. What do I mean by that? So what happens is, in a conventional energy, all types of energy, low energy, high energy, everything is bombarded. So the CT scan machine absorbs everything. But the photon counting CT, it selects only those photons which are useful for information. This means optimum image contrast and increase iodine contrast to noise ratio. This translates into lesser amount of contrast dose. Now that is a boon for us. We all know that we do not want to give the patient more contrast. More contrast means more reactions, more toxic agent into the body. Now what this photon counting CT does, it actually helps you to reduce the dose of the given contrast to nearly 50%. There are research trials going on which say that it will reduce the dose up to 25%. Okay, now coming to some clinical applications, it has redefined, or rather it is redefining oncology CT, because there is significant decrease in radiation dose in photon counting CT up to 70%, right? And then because of its high resolution, obese patients, you can very well image them. Also what happens is, because of the better iodine mapping, you can differentiate malignant tumors from benign tumors. Malignant tumors, you know, will have higher vascularity, higher iodine contrast compared to benign lesions. Pulmonology CT, because of the low radiation dose, screening for lung carcinomas has become a boon. So this is an image taken from a German journal, where a patient who was a patient of COVID was subjected to dual source CT. So all these images I'm showing you, we are comparing with dual source CT. That is the latest CT, right? Not with a conventional 16 or 64 slice. I'm talking about dual source energy CT. So here, when we image, we saw some ground glassing at the periphery of the lung, right? Then when the patient was subjected to dual source, we saw that actually these were not ground glassing, these were reticulations, right? So very high level of resolution. Okay, Also remember that photon counting CT enables us to do functional imaging. So this is a conventional CT, this is a high resolution photon counting CT, and this is a functional image of the photon counting CT. Okay, so this is a case, this is an interesting case. So you can see here it is the right pulmonary artery and there is a thrombus in it, and in the right pulmonary, the thrombus is extending into the upper lobe of the right pulmonary vessel. And what has happened because of this thrombus is this part, the upper lobe of the lung, is infarcted. So you can see that the perfusion of this lung is not good, though the ventilation is okay, but the perfusion is not good. These are all images from the photon counting CT, right? Then what they did was, they removed the thrombus, they did an endarterectomy. So you can see valopacification of the vessels, the thrombus has been removed, and you can see the perfusion has come back. Look how black this was, and now it is all red. The perfusion has come back. And of course, the ventilation is normal as before. Right. Also, neurology CT, neuroradiology has a lot of applications of photon counting CT. So look at this image. Look at the crisp image, right? You can go up to matrix 1024 into 1024, right? With now we are doing slice thickness. What we have in most departments, the most advanced scanners, it is 1 mm slice thickness, right? Here you can go up to 0.1 mm thickness, right? 0.2 mm thickness, right? With very thin 100 microns of resolution, right? Look at the resolution, you can see even the smallest of the branches of the vessel. Look at these black and white images, look at the colored images, excellent resolution. Okay, also photon counting CT is very, very useful to, remove the beam hardening effect. So this was a case which was done for an 85-year-old patient with post-surgical CT after spinal fusion, and they wanted to look, it was a case of traumatic fracture, and they wanted to look for screw loosening. So first they did a normal energy integrating CT, which is the normal conventional CT, and they thought that this was the area of screw loosening, the red arrow. Then they did a photon counting CT, and then they saw that no, the loosening was not on this side, the loosening was on this side. You can see how the artifacts are decreased, and then what they did was, they have done a mono-energetic reconstruction at 130 kV. What do I mean by this? What you can do in this photon counting energy CT is you take one sequence, you take one scan, and then you can reconstruct it at multiple energy levels, right? So they have reconstructed it, and actually you can see all the artifact is gone, the beam hardening effect is gone, and they can actually see the loose, screw getting loose because of this space here. So excellent images. So beam hardening effect again removed by photon counting CT. Cardiovascular CT, as I said, it is very useful, especially for stent visualization, especially for vessels which are heavily calcified, because the resolution is very nice. So this is a photon counting CT image. This is a coronal image of carotid artery at the bifurcation with atherosclerosis. So you can see this is the lumen which is left over, this is the lumen which is occluded, and this is the lumen which is calcified. Again, very, very high resolution, right? 100 microns going up to 0.2 mm slice thickness, right? Matrix of 1024 into 1024. Right. Another vessel angiography at carotid artery bifurcation, you can see the eccentric calcification. Right. There have been various studies, there are various studies going around in all parts of the world. This is a study from Zurich University in Switzerland, where they compared photon counting versus dual source CT of congenital heart defects in neonates and infants, and they found that the diagnostic image quality was 3 or higher in 95% of children done with photon counting versus 77% of dual source. Again, see, all the studies are being compared with dual source, which is the latest CT scan right now we have. Okay. Again, it is very, very useful for even musculoskeletal and for bone imaging. Temporal bone, which has a complex anatomy, and you need to see the inner ossicles. For cochlear implant, it is said that photon counting CT is going to be a boon. So here you can see that the same image, maybe a bit more better, is being taken at 85% lower dose. And we all know the Alara principle. We know how the radiation is becoming an issue. So again, a very useful technique. Again, one more image of how the beam hardening effect can be reduced. This is the conventional image. This is the photon counting image. This again is an image from the photon counting CT. Look how beautifully there are no artifacts. It has been removed. And a volume reconstruction. So thanks to the photon counting CT technology. So this was a poster they presented at RSNA. I was there, and actually photon counting CT is gathering so much of interest. So to summarize, it has improved spatial resolution. There is decrease in electronic noise and artifact reduction. You can see how the screws and all the metallic artifacts are reduced. Improved iodine ratio. So you can see the vessel opacification being much better in photon counting CT compared to conventional CT, and improved dose efficiency. That means lesser radiation dose. So is the technology perfect? Is it all good? There are no free breakfasts in life, so everything comes at a price. Yet the technology has a few challenges. First is it is a very, very complex physics. So if your physics is very complex, you need very sturdy hardware and software. You need people who can manage that. Crystal development of that crystal, I told you, is a challenge. Engineering concerns are there. The cost of the machine is extremely high. So actually I called a Siemens guy. I told them that, do you have this machine in India? He said, no, not yet, sir. I said, in Asia? He said, yes, in Japan and Singapore, we have some installations. So I asked, what is the cost? So he translated the dollars for me, and it came out to be 55 crores, right? Higher than even a PET MR right now. So the cost is significantly higher. So maybe in coming years, we'll see the cost come down, better engineering. Clinical benefits, just to summarize: reduced electronic noise, that means better signal to noise ratio. Increased iodine contrast to noise dose efficiency, means lesser contrast needed. Higher iodine signal at high kV, that means multiple scans with just one shot. Better spatial resolution, very high contrast, good spatial resolution images. Lower radiation dose, we have talked about it, significantly lower radiation dose, and reduced beam hardening and metallic artifacts. Conclusion: photon counting CT is a promising technique to overcome the shortcomings of energy integrating conventional CT detectors currently used in clinical practice. It enables very high spatial resolution and spectral imaging with lower doses. Since the introduction of this technique, a shift has been observed from solely preclinical studies to clinical studies. Now it is being conducted all over the world. Photon counting CT is promising in various clinical applications, but there are a few challenges. Thank you.
Thank you, Dr. Gaurav, for a wonderful presentation on photon CT. And it was something even new for me.
Sir.
And these images are quite fabulous.
Sir.
Great images. So I invite any question from the audience. Any question from the audience? So thank you for introducing. Sorry, yes.
Yeah. Sir. Yeah, I told you, sir. So it has not been introduced in India yet, but it is to the tune of 55 crores right now, sir. The only installation we have in Asia is in Japan and Singapore. It is extremely expensive, and that is basically because of this crystal, sir, the detector crystal. But right now there is a company known as Radiodiagnosis Technology. It's a Japanese company. It is proprietary, yes, sir.
Thank you. Thank you, Dr. Gaurav.
Thank you, sir.
Thank you, sir, for this wonderful talk. Now I would like to invite Professor Sandeep Bhattacharya, sir, Registrar, and Professor, Department of Physiology, KGMU, as a chairperson of this session. Now I request the chairpersons to invite our next speaker.
The next speaker for today's session is Dr. Neha Singh, Additional Professor at Ram Manohar Lohia Institute of Medical Sciences. She has been a visiting fellowship in breast imaging at Breast Screen St. Leonard's Hospital, Sydney, Westmed Hospital, Sydney, Wollongong Hospital, and Macquarie University Hospital, Australia in 2018. She has 58 research publications to her credit in national and international journals, completed 9 research projects as a PI, and running 2 projects on breast imaging. Her area of interest includes breast imaging, diagnostic neuroimaging, cardiovascular imaging, and oncoimaging. We would like to invite Dr. Neha Singh for her presentation on dual energy CTs, its principle and applications.
Talk on photon energy CT. It's time to move on towards the dual energy CT, its principles and applications. So what is dual energy CT? So this dual energy CT is the CT which uses 2 photon spectra, and that's why it is also referred to as the spectral CT. And as the name suggests, dual energy CT, actually it's a misnomer. There are not 2 different energies, rather 2 X-ray spectra. Now coming to the principle. So the principle of attenuation of X-ray depends upon 2 processes in entire radiology, right? First is the photoelectron effect, and the other one is the Compton scatter. What happens in photoelectric effect, that an incident photon, it comes and collides with an electron in an atom, and then it transfers its entire energy to that electron, which is then ejected, and is known as the ejected electron. And this hole, which is created due to its ejection, is then filled by another electron from the outer shell. And during this process, if this process is completed meticulously, then the energy is emitted in the form of characteristic radiation. So this photoelectric effect, it basically depends upon the atomic number and the energy of the incident beam. Sorry for the interruption. And photoelectric effect I had covered. Now coming to the Compton scattering. So what happens during this Compton scattering is that an incident photon that strikes with the outer shell electron, and then that outer shell electron is sent out of its outer shell, and this electron is known as the recoiled electron. And what happens that this recoiled electron, it loses energy with time in the form of heat, and it creates scattered radiation in the area being imaged. Now, continuing with it, the dual energy CT imaging, it is basically based on the differential absorption of energy at different kVp settings. And what is KH? KH is nothing but an increased photoelectric effect and a spike in attenuation at an incident energy level which is just above the K-shell binding energy of the atom. Now this is a table. Here you can see that I have shown you the atomic number and the K edges of different substances which are present there while we are imaging the human body. So you can notice that the substances which are basically, which make the composition of the soft tissue of the body like hydrogen, carbon and nitrogen, they have a very low KH. Most of them have values lying below 0.5, 0.01, 0.28 and 0.4, whereas the KH for calcium is 4, which is quite away from those values. Further, iodine, the value of iodine KH is around 33.2, and this is the whole basic of material characterization based on dual energy CT. So in this graph, you can appreciate that since iodine, which has a KH of around 33.2, it has a peak attenuation at this value, and with increase in energy, its attenuation decreases rapidly. Whereas the calcium, since its KH was around 4, so its peak attenuation is around 4. And with increase in energy, it also, its attenuation also decreases, but at a much slower rate. Whereas the water, if you look at the water, it shows minimal change in attenuation with increase in energy. And if we compare this rate of change in attenuation, you can easily appreciate that the height of the slope of the iodine curve as compared to that of the calcium curve is quite large. So it shows much higher attenuation with increase in energy as compared to the calcium. And this ratio is basically known as the dual energy ratio. So this dual energy ratio is basically a material specific parameter which depends upon the atomic number, not on the material density or concentration. Now, what are the different techniques based on which we can acquire this dual energy CT? So first is dual source dual energy CT, then single source dual energy CT with rapid KVP switching, and the third one is single source dual energy CT with dual detector layers. Now coming to the dual source dual energy CT. So this is the classical video of dual source CT. Here you can appreciate that two X-ray tubes are lying at right angle to each other in the same gantry, which are operating at different KVPs. So these dual source CTs, in the first generation, what they used to do was that one X-ray used to operate at around 140 kVp and the other one at around 80 to 100 kVp. And in this first generation CT, they paired this 100 kVp tube with a larger detector with FOV of about 50 centimeter, whereas that smaller, low energy tube that was paired with a detector of about 26 centimeter. So the basic disadvantage was it has a very small FOV of just 26 centimeter, which hampers the imaging of large habitus patients. So in second generation, what they did was they paired this high energy tube with a detector of 33 centimeter, whereas this low energy tube was coupled with the detector of about 50 centimeter. So this further increased the area for imaging. Now these two separate detector arrays, they lead to the generation of two image data sets. And the one important thing, which is very good thing for dual energy CT, is that the temporal resolution is just 1/4 of the entire rotation time. Why? Because this X-ray tube is giving exposure only, is taking image only for that 1/4 part of that single rotation. So it's just 75 millisecond. And apart from that, in high energy tube, it is paired with a selective photon shield. And that's why its separation is much better, and hence it gives better material characterization of different elements. But again, drawbacks are there. What are these drawbacks? Temporal misregistration. Why? Because although the imaging is done at just a gap of few milliseconds, but these imaging is not simultaneous, and that's why there are chances of temporal misregistration. And again, FOV, although they have increased it in second generation, but again it is just 33 centimeters, so it is difficult to image patients with large body habitus. Now coming to the other variety, the single source dual energy CT, where we are using just single X-ray tube with KVP switching. Here in this video, you can appreciate that the high energy and low energy voltage is switching with time. Okay? So single X-ray tube, it generates high and low energy X-ray spectra by rapid changing of KVP settings in the same rotation. But the tube current, it cannot be changed so rapidly in the X-ray tube. So what has to be done is that the exposure time for both the tubes has to be distributed. How it is distributed, that 65% of the time is being provided for the low energy beam, whereas the 35% of the time is provided for the high energy beam. So advantage here are that it has better temporal resolution. Why? Because the imaging is now being done almost simultaneously. FOV further is increased to about 50 centimeters, so large body habitus patients can easily be accommodated. Easier quantification of material density, but the disadvantage is, since it doesn't have a selective photon sheet, so spectral separation is not that good, and hence less accurate material characterization. Now coming to the third variety, the dual energy CT with single source, single X-ray tube, but the detectors are layered. Layered in the form of, there are two layers. The top layer that absorbs the low energy data, whereas the bottom layer, which is colored with orange, that captures the high energy data. So this combined data is used to reconstruct the two separate image data sets. After this acquisition, what we had to do, we had to process that data in order to form the images. So this images which are required with this dual energy CT has two types of information. One is the morphological information, and the other one is the material specific information. So we have to generate the material specific images, and to obtain that, reconstruction can be done in two ways. First is the processing, which is done after the reconstruction of low and high energy images, which is also known as image domain decomposition. This type of processing is used in dual source dual energy CT and single source energy with dual layer detectors. And after getting this reconstruction, the material specific images, they are obtained by calculating the difference in attenuation of varying materials between the high and low energy image data sets. For abdominal scans, since we had to characterize different materials in a different way, a three material decomposition process is used, where soft tissue, fat and iodine, they are separated on the basis of their attenuation values, and hence they are used to generate virtual non-contrast CT images. After that, a color-coded overlay image, which is usually an iodine overlay image, is generated by assigning a color to the boxes which contains the material and overlapping them on the monochromatic images. The other method is, this processing is done before the images are reconstructed from high and low energy sinograms, and that is basically known as the projection space decomposition. In it, what we do is that the data from both high and low energy images, that is reconstructed and that is projected into the space, calibrated, and then assigned so that the new form of images are created. Now, after data has been processed, now we comes to the image display part. So the image display in dual energy CT, it is basically the material density display, which can either be an iodine density display or a water density display. So this iodine density display, the enhanced organs which contains iodine, they appear bright, whereas unenhanced areas remain black. It has important role in the evaluation of hyperdenses like hemorrhagic and complicated cyst on CECT, and also it reduces the misdiagnosis due to pseudo enhancement. So here this is the image. This image is of CECT phase, right? Here you can appreciate a cyst, a hypodense lesion sitting over there. Now we don't know whether this lesion is enhancing or not. So the advantage of dual energy CT is that a virtual NCCT image can be created. So in this image, you can appreciate that that lesion is already hyperdense on virtual NCCT image, which favors that it is some sort of hyperdense hemorrhagic or complicated cyst. And this is the iodine overlay map. Here you can appreciate that that area is not showing any contrast uptake. It means it is not showing any enhancement, and so it is just a hyperdense hemorrhagic cyst. Now, water density display. So this water density display is equivalent to the virtual unenhanced images, and it obviates the need of additional NCCT image acquisition, and hence it reduces the radiation exposure to the patient. So its utility lies when suppose a calculus is seen within the pelvic cell system on CT urographic phase. Now both the iodine as well as the calculus will be hyperdense, and so we will not be able to differentiate where the calculus is lying and where the contrast is lying. So in such cases, for a virtual NCCT image can be generated, which can show that calculus, which will be hyperdense now, and rest of the part will not be showing any hyperdensity. For example, in this image, you can appreciate this is a water density image. Hyperdense calculus is seen filling the pelvic cell system on right side. And on iodine density display image, that area is not showing iodine mapping. It means iodine is not lying there. So it is nothing but a calculus. Now, the one important thing about these virtual monoenergetic films, which can be created from the raw data, is that lower kVp images, they have more noise, but they have higher contrast, and hence, small enhancing lesions are more conspicuous than routine display at 70 kVp. And the higher kVp images have less contrast, but they have less noise. So the optimum image contrast to noise ratio is achieved at around 70 kVp. Here in this image, you can see a hyper enhancing lesion is lying posteriorly in segment 7. This lesion is very brightly visible on 40 kV image, and whereas in 100 kV image, this lesion is hardly appreciable. So this contrast resolution decreases with the increase in energy. But if you focus at the noise, the image at 40 kV, it is quite noisy, whereas that which was taken on 100 kV, it is not that noisy. So these are the pros and cons of different type of energy images. Now coming to the clinical applications. First of all, the abdominal applications. Firstly, I will cover renal applications. In renal cyst and mass characterization, I have just shown to you. Next comes one of the most important advantage of these dual energy CT, that is renal calculi characterization. So why it is important? It is important because it has direct treatment implications. What are those? For example, this uric acid calculi, they can be treated with medicine only, whereas these cysteine calculi and calcium oxalate monohydrate calculi, they are resistant to ESWL, and so patient has to go for PCNL. So this is the basic requirement while our urologist want to know what is the composition of these calculi. So on single source dual energy CT, these uric acid calculi are depicted on uric acid material density images, whereas the calcium containing calculi, they will be appreciated well on calcium density images. But in dual source dual energy CT, this calculus composition is dependent on the calculation of their dual energy ratios. If we keep the reference range at 1.13, then uric acid calculi, since they are made up of lighter elements, they will lie below the reference line, since their ratio is less than 1.13. Whereas non-uric acid calculi, they will lie above the line. Ratio, if it is ranging between 1.13 to 1.24, they are assigned as the cysteine calculi, whereas if the value is more than 1.24, they are either calcium oxalate or phosphate calculi. Then color-coded images can also be used. Uric acid calculi, they are coded in red, whereas non-uric acid calculi can be coded in blue. So this is the image. Here you can appreciate a calculus is lying on left side, which is color-coded red. Another calculus lying in the same kidney at somewhat inferior pole, this is also coded in red. So what is the composition of this calculi? We have just mentioned it is a uric acid calculi. On is this dual energy ratio map, this calculi is lying below the reference line. The value of both these calculi dual energy ratio is 0.93 and 0.73. I have just mentioned below 1.13, it means they are uric acid calculi. Second scenario, here you can appreciate a calculus lying in the pelvis on left side. This is coded in blue. So this is a non-uric acid calculi. On this dual energy ratio map, it is lying above the reference line, but its value is 1.18. So it is a cysteine calculus. One more, a staghorn calculus lying on the right side, coded in blue. So it's a non-uric acid calculi. On the map, its value is lying about 1.3. So more than 1.24 means calcium oxalate or phosphate type of calculus. Now coming to the adrenal adenomas. So basically attenuation of less than 10 HU on NCCT images, it is virtually diagnostic of adrenal adenomas. So if we get a lesion in adrenal, and so it becomes essential to acquire an NCCT image. But the advantage of dual energy CT is it can be done without taking an additional scan. Virtual NCCT images can be created, and they can be compared with the CCT images for nodule characterization. In this case, you can appreciate a nodule lying on the right side of the adrenal gland. And this is showing enhancement on this iodine overlay map. But virtual NCCT image, it shows HU of just 7.8. So it helps in characterization of it as adrenal adenoma. Now hepatic mass lesion characterization. It can, again, the same advantage that virtual NCCT images can be created, and hypervascular lesions, which are mostly suspicious for HCC, they are most conspicuous in arterial phase, but they are difficult to detect on delayed phase. So this image I had already shown to you. This is the same thing, which gives you the advantage of picking these lesions on low energy images. Now coming to a case scenario, this was a patient who had CA breast and was evaluated to rule out basically for metastatic workup. Here in this image, you can appreciate a hypodense lesion lying in the left lobe of the liver. And now we are not sure whether this lesion is enhancing or not. But on iodine overlay map, you can appreciate that this lesion is showing iodine uptake. So this lesion is definitely suspicious for metastasis, which was later proved also. Now, not only characterization, if the patient has been treated by TACE or tumor ablation has been done, then to rule out recurrence or residual tumor also, dual energy CT is advantageous, because here also the same entity, the characterization is dependent on the pattern of enhancement, whether it is there or not. But the word of caution should be taken when chemoembolization has been done with lipoital, because it contains high concentration of iodine, and so on iodine density display images, it shows the lipoidal accumulation as bright spot or hyper enhancement, and so it should not be misdiagnosed as a recurrent or residual tumor. Here in this case, this is the CCT image. You can see a hyper-attenuating lesion lying on the right side. And this is the virtual NCCT image that too in bone windowing. Here you can appreciate that the part of this lesion is nothing but the stained oil. But on iodine density display image, that part has been subtracted, but part lying medial to it is showing iodine uptake. So we were not able to characterize it only on CCT image, but iodine overlay, it clearly demonstrates that the part of viable tumor is lying over there. Now hepatic steatosis or iron deposition also. So it has been proven that if the attenuation values of the liver at the area of interest are 9 to 13 HU lower than at 80 kVp, 9 to 13 HU lower at 80 kVp as compared to those at 140 kVp, then they are suggestive of fatty infiltration. For example, in this image, the area lying just close to the falciparum ligament is a bit hypoattenuating, and its HU here on 80 kV image is 23.8, and this is the image at 140 kV. So here the attenuation value is 34.2, so the difference here is about 10.4, and so it helps it in defining that this is nothing but the fatty infiltration. Although the iron deposition in liver parenchyma will have some sort of higher attenuation at lower energy values. Now pulmonary applications. So first and foremost important is pulmonary thromboembolism. So CT angiography also, it can detect small clots or partial occlusion in segmental arteries. But if we come to subsegmental arteries, that can be missed if we use simply this CT angiography alone. The advantage of dual energy CT is that smaller clots can be detected on iodine overlay map, which are visible as a perfusion defect. For example, in this image, you can appreciate this area of filling defect in the subsegmental artery of the posterior basal segment. And here, on CACT lung window image, you can appreciate this area of ground glassing, which is nothing but the evolving infarct. And on iodine overlay map, a wedge-shaped area of perfusion defect is clearly visible. So it is basically infarct which is developing secondary to pulmonary thromboembolism. The nodule characterization, again it is dependent upon how much the lesion has enhanced. So it can generate virtual NCCT image, and differentiation of calcium from contrast enhancement is also possible. Here, a lesion is lying over there, which is, hyperdense. We cannot say whether it is enhancing or not, but on iodine overlay image, you can clearly appreciate that there is no area of orange color there. That is, it is not showing any form of iodine uptake, and hence, this is not a suspicious one. So this is nothing but an old healed granuloma. Now coming to the musculoskeletal applications, first and foremost important is application in gout. So it can diagnose gout in an easy, non-invasive and reproducible manner, and trophy volume can be quantitatively measured. And here we keep the reference value at 1.36, and uric acid crystals lie below the line and they are coded in green, whereas the calcium deposits, they lie above the line. For example, in this image, you can appreciate the area of juxta-articular erosions lying in the first metatarsophalangeal joint, which is a classical site for gout. Apart from that, patient was also hypouricemic, so although we don't have any doubt in making the diagnosis of gout. But what's the advantage of dual energy CT? Here, you can appreciate that in X-ray only one area was visible, although the patient has many other asymptomatic areas as well, which are better demonstrated on dual energy CT, and hence accurate volume estimation can be done with the help of dual energy CT. Now one more, metal artifact reduction. So imaging a patient with metallic prosthesis is always a challenge for our technicians and radiologists too, because what happens that here the beam becomes hardened. And so it creates a beam hardening effect. So the advantages of this dual energy CT is that the monoenergic reconstruction films at higher KeV, they are more effective. Here in this image, you can appreciate the difference between the different energy images. The image at the 50 keV is showing maximum beam hardening, and that on 110 keV, that is showing the minimum artifact. So this is how we can, use the data at different energy levels. Now coming to the dual energy applications in vascular, this is one of the most important application. And in aortic stent graft evaluation, its advantages are manifold. First of all, we can create a virtual NCCT image, and that too, at higher KVP image, it will show less stent artifact. So in this image, you can see this is a CECT image. Some sort of hyperdensity is lying outside the stent. We are not sure what it is actually. If we create this virtual NCCT image, that thing is not visible. So that may be some sort of enhancement, but yes, we are not sure. On iodine overlay image, now it can clearly depict a tiny area which is showing contrast uptake. So this is nothing but an endo leak, which is actually demonstrated due to this iodine overlay only. Now coming to the cardiac applications, here this cardiac basically this CT angiography in low to intermediate risk patients, this is considered as the gold standard modality. But with single energy type of things, we can although pick this area of narrowing, but what happens if you are getting calcium? Then it really interferes with the degree of stenosis. The advantage of dual energy CT is it can subtract that area of calcium. So in the first image, a calcified plaque is sitting at the origin of right coronary artery, but on second image, which was taken with dual energy CT, calcium has been subtracted. So it is now giving a better idea of the degree of stenosis, which was later confirmed with the conventional angiography, and that degree of narrowing was really sitting there. But bare depiction of this coronary artery disease, it does not give information about the hemodynamics of the patient. So that is given by myocardial perfusion only, which is currently done either with the help of a MRI or a SPECT. But with the help of dual energy CT, this myocardial perfusion can be assessed. So although it is termed a perfusion, but actually it reflects the myocardial blood pool, and it is a static acquisition, not a perfusion basically. So here in this image also, you can appreciate a fibrocalcific plaque sitting at the origin of RCA, and here it is an iodine overlay map. Here you can appreciate this area of perfusion defect lying in the posterior basal part of the left ventricle. So this area is coinciding with the stenosis, the area which was stenotic, that must have been supplied by this area, and that's why it becomes significant for the patient now. Now the last slide, the applications in neuroimaging, although the applications are manifold, but the main, since time is running short, I would just like to show you how it is useful in differentiating tumoral bleed from non-tumoral bleed, right? So this is one case. Here you can appreciate a hyperdensity, a large area of hyperdensity is visible on a CECT image. So on virtual NCCT image, which can be treated with the help of this dual energy CT, you can appreciate this area is still there, but some sort of mild difference is there in the anterior aspect. CECT image is a bit much more hyperdense as compared to the second image on virtual NCCT. But yes, we are not sure. We are a bit suspicious. What happens on iodine overlay image? Now our doubt has gone. The area which is more frontal, it is showing iodine uptake, and so it definitely gives an idea that some sort of enhancing lesion is sitting over there, which has led to this hemorrhage. So this is basically a tumoral bleed. With this, I would like to end my lecture. Thank you so much.
Thank you, Dr. Neha. Your presentation was very informative and fabulous. Now I would like to invite questions from audience. Any question? Okay, thank you, Dr. Neha.
The next speaker of the day is Dr. Akhilesh Gupta, Secretary, Science and Engineering Research Board, SERB, DST, Government of India. And he will be speaking on TBA. So
Sir, Akhilesh Gupta sir will be joining us shortly.
Okay.
Yes, sir. I am honored to announce that Department of Radiodiagnosis KGMU is going to organize a 2-day conference, that is ISPR, Indian Society of Pediatric Radiology Conference 2024, on 21st and 22nd September. For more information, everybody is requested to kindly inquire at our reception counter, and we expect more and more registrations for this conference. All the paramedical students and radiology residents are informed to give their posters to Dr. Sushil and Dr. Kajal, who are here, or they can contact Shivangi for submission of their e-posters. Again, I announce all the paramedical students and radiology residents who want to give their posters, kindly contact Shivangi.
We would like to welcome our Honorable Vice Chancellor, Professor we would like to welcome our Chief Guest, Dr. Akhilesh Gupta, sir, and our Honorable Vice Chancellor, she'll be joining us shortly, who has graced us with his presence. Thank you so much, sir.
Again, I announce, Department of Radiodiagnosis, KGMU, will be organizing a two-day conference, Indian Society of Pediatric Radiology Conference on 21st and 22nd September 2024. For more information, kindly contact reception counter, and we expect more and more number of registrations from all the audience.
We would like to welcome our Honorable Vice Chancellor, Professor Sonia Nityanand, ma'am, who has graced us with her presence. Thank you so much, ma'am.
Now I request the chairpersons to kindly announce our next speaker.
The next speaker is Dr. Akhilesh Gupta, Secretary, Science and Engineering Research Board, DST, Government of India. I request Dr. Akhilesh Gupta to deliver his talk.
I would like to invite Professor Akhilesh Gupta, sir, as a speaker for our next session.
First of all, thank you very much for inviting me, Professor Sonia ji, the Honorable Vice Chancellor, all the distinguished faculty and professors and also students and all other constituents. In fact, this presentation I thought, let me present something different from what you are being in fact exposed to in this conference. In fact, India has recently launched a National Research Foundation. I hope many of you must have heard. And this is kind of a unique initiative with the vision of, in fact, our Prime Minister to transform the entire research ecosystem of the country. How research is funded, how students are being supported, how individual faculties are supported, and how individual institutions are supported. The total transformations that you must have, you will see in future. Before going for the kind of outline of what this National Research Foundation is, let me present the India's present R&D and academic ecosystem. So let me explain that research ecosystem and academic research ecosystem, they're quite kind of connected, but also quite disconnected. And I'll present what are the disconnections and connections. So let me present the R&D ecosystem that we have in India as part of the government. So we have mission mode programs, and I'm sure all of you must be well aware of these institutions. So we have Department of Space, that is ISRO, Department of Atomic Energy, and Department of Research, Defense and Research Development Organization, DRDO. That's three strategic departments. And what do you mean by strategic? Means they actually work for the national security and the program and project which are of strategic nature. These are mostly internally funded. There's no external funding is given. Mostly internal funding. Then we have mission mode non-strategic body like CSIR. Then we have external support bodies, support which you receive as part of your research program, like for example Department of Science and Technology, Science and Engineering Research Board, DUT, and Earth Sciences and all. So you are more familiar with DSTA and these institutions, you get support from these. And then we have academic research institutions and industrial research ecosystem. We also have research supported by other departments, line ministries, and also the NGOs. India has a very large pool of NGOs. They also do a lot of research. If you put together all this, is a huge research ecosystem that India has. You look at, these are the 600 major labs in the country, research labs spread across the country, supported by 27 ministries in Government of India. There are 50,000 scientists working as part of these labs, nearly 1.2 lakh scientific staff and 1,000 scientific managers. So these are huge kind of spread of ministries and departments. If you see, look at the number of academic, now I am coming to academic ecosystem. We have 1,254 universities, what are called degree awarding institutions. Like one you have, KGMU is one, and 45,000 colleges, degree colleges, nearly 4.31 crore students. This is the second largest in the world after China. India has such a huge student. So in fact, the graduate and undergraduate students are the second largest in the world. And we have nearly 15 lakh teachers in the country. So put together, if you say research and academic put together, we have a huge, kind of ecosystem. In the higher education, that is academic, we have 56 central universities, 464 state universities, private universities, deemed universities, and the total number of universities. Now, I will bring this important issue of funding later on. Well, please remember these figures that state universities, KGMU is one of the state universities in the country, and the private university put together, we have 900 number. It's a huge number. And these are the universities where funding is considered to be inadequate. Compared to central institutions like IITs and all, where the institute, the support is hugely available to them, whereas state universities have less. Now, India has done well in recent years, and we are now third in the world in terms of number of publications. This is a very change that in last 7-8 years we were somewhere in 7th in the around 2016 or so, and now we are third. We also are third in terms of number of PhDs in science and engineering. This is again a very big jump that we had. Of course, let me tell you, there are 25,000 PhDs annually come out from our universities, but we have a problem of quality of PhD. See, if you see India produces 25,000 PhDs, China produces something like 36,000, US produces something like 46,000. The numbers are comparable, but quality has so much of difference. In fact, only 1/3 of the total number of PhD that are come out from India are considered quality, high quality. 2/3 is not good. We also are third in terms of startup and third in terms of unicorn. This is the kind of development that has taken place in the last 10 years or so. We also have done well in terms of quality. We were 13 in 2015, now we are 9th position in terms of quality, citation index and other things. There is a considerable progress made in terms of resident patenting. We were very bad about a decade back, but now we are improving like anything. One area where improvement has taken place is the number of women participation in research. We were pretty bad just a decade back. We were 13th position. Now we are, we are 13%. Now, in fact, it has increased to 18.7% in terms of the. But global average is 30%. So therefore, this is an area where we need a lot of improvement. So there are as many as 70,000 women researcher in the country today compared to nearly 3.2 lakh total, 3.4 lakh total number of researchers. We also made good progress in terms of Global Innovation Index. Every year we are improving our ranking. There are two big problems of India research ecosystem. One is that our total funding for research is only 0.64% of the GDP. If you see the global 10 countries, if you take for doing good in research, their average funding is 2% or more of their GDP. Even China spends a lot of money, it's 3.7% of GDP. US is doing much more. Now, so India has been stagnating around this number, 0.64 I mentioned, as a GDP. The second big issue is the number of researchers in the country. So we have 3.4 lakh researchers in the country, but this number is inadequate in terms of if you compare globally. China has something like 17 lakh researchers. The US has 27 lakh researchers. Number of researchers in India is one of the lowest in terms of per million population. We call full-time equivalent researcher. One of the lowest. So these are two big challenges that India has: less funding, less number of researchers. And by the way, both are interrelated. You have more researchers means more funding required. And if you have less researchers, you need less. So it's all related. I'll just give you this table and you understand the kind of inequality that we have globally. So India R&D expenditure, as I mentioned, only is 0.64% of the GDP. US is 3%, UK is 1.75, China is 2.23, South Korea is 4.64, Japan is 3.0. So all others have around 2 or more percent, where India is. Look at the R&D budget. US has nearly 200 times more funding compared to India. Even China has nearly 120 times more funding. Number of researchers per million population is, India is 262. If you look at South Korea, it is 7,498. This is the kind of, but see the magic. And that's why India is a place where, it's a country of God. The magic is with less manpower and with less funding, we produce third most number of PhDs and third most number of publications. So this is the magic that we have. You can look at this is the number of researchers. So, total funding that India gets annually for research is nearly 1.27 lakh crore. This is the annual funding available for research to different countries. And out of that, the private sector funding is only 40%. Remaining 60% funding is coming from government. Whereas if you look at the global average is that 80% funding comes from the private sector and only 20% comes from the government. one area that I thought I try to mention in the beginning itself, that the kind of fund that we provide, SERD or DST provide to the institution like yours, you see that 65% of the total extramural funding that DST or DVT provide goes to IITs and NITs and ISERs. 65%. Only 11% funding goes to state universities. Now this is the kind of inequality. Now one can say that, okay, we can, I mean, as Secretary SERD, I thought that let me try to bring balance, but the present system of funding is that you fund through the quantitative grant. So proposal quality will determine whether somebody will get funding or not. Now if this is the system, then the inequality will continue to exist, because state universities will not be able to compete with IITs. You know, there are three things that IITs have which state universities will never have, at least not have, will need a lot of work to do. Three things. Number one is they have the best R&D infrastructure. The second is they have best faculty. So faculty come from different parts of the world, they come back to IIT and work. So good infrastructure and good faculty. But third thing is that they have the best of the students. So all these three constitute the research status of an institution. Now, in fact, KGMU is much better. I mean, I have all details of performance, but I look at many of state universities. They do not have adequate infrastructure, neither they have very good faculty, and then so when you don't have good faculty, they don't attract good students. They are all connected. So this is the issue that the National Research Foundation is going to address. So these are major inequalities that exist. As I mentioned that, so you know, R&D infrastructure is very important. Institutions, R&D institutions have good R&D infrastructure, but they don't have students. Universities have more students, but they don't have R&D infrastructure. So it's like it's not matching. And IITs have all. Now this is the three different kinds of institutions that exist in the country. So when the idea of National Research Foundation was conceived, it was with the idea that how the state universities can be adequately supported and augmented to match their performance with IITs and other higher institutions of research. So the National Research Foundation works on the following premises. It will work for profound research. Now look at why I am saying 98% of the SERD funding is for incremental research. I am sure many of you must have got funding amount is 30 lakh, 40 lakh for 3 years. No useful research can be done with 30 lakh funding. You need minimum funding. This is my students, they have worked on the, we worked out what is the optimal level of funding that is required. Too less of funding will not yield anything. Too much funding also will not yield anything. we need an optimal level of funding. The optimal level is not less than 1 crore. That's optimal level. Now that to get, we need, how we can get it? Universities, most of the PIs, I'm sure who have applied to CRD, they will be told, no, CRD funding is not more than 80 lakh. So you apply 1 crore, you will get less than 80 lakh. So the basic structure itself is, it doesn't allow you to go beyond 80 lakh. So in fact, I will tell you a story. I was interacting with TIs. So I asked, what are you doing? They said, we're doing something very wonderful. And I said, what is the funding you need? An interesting answer from a PI is, sir, how much fund you have? I said, what do you mean? He said, sir, we can submit a project for 10 crore, but we can also submit a project for 30 lakh. So actually what happens, the PIs are compromising. They see that there is no funding available more than 80 lakh, so CRD proposal should be less than 80 lakh. As part of the NRF, we are introducing support for profound funding. Profound funding, you must have seen, there are many, Shukla is one scheme and all that, but this is just like a pilot scheme. Now Shukla is going to be, so you can apply for 10 crore, 20 crore kind. We are going to set up center of excellence of large size, even 30 crore, 20 crore, of that size. So unless, medical research cannot be done in 30 lakh. You want one MRI machine, it costs so much. Can't get it in 30 lakh or 40 lakh. So without having infrastructure, your researcher cannot do a quality research. So profound funding, quality versus relevance. See, again here the problem is that PI does work, a researcher does work as per his or her area of interest. What about the national relevance? That has not been told, and so we are giving the national relevance. You need research in quantum technology. We need research in the area of AI and ML. Can you do it? So it's really a kind of national call, or what you call grand challenges. It's really grand challenges. So you bid for grand challenges. Then one very important thing, research has been largely so far for supporting basic research, the foundational research. But now there will be greater emphasis on translational research. How the research can be taken to market level. At least we should have the direction set of going to market. So translational research is also going to be, and all the universities will be encouraged to create collaboration with industry. So you can invite industry, government will give 50%, let industry also partner 50%, create the key program, and then take it. Now this is going to be a new direction. Most of the, as I said, in India, research has been driven by government. And this has been disconnect between the government and private sector. So this is the another area that's going to be. As I already mentioned that we have a big gap area where the university versus national institution is a big area. So how we are going to work? I think I don't have much time to explain, but let me try to give you an example. Suppose I'm just giving say, comparison between you and, say, AIMS. Suppose we give offer, KGMU gives an offer to AIMS professor that you come and work here. All right. Then say, what is the incentivization? They would like to come, because the kind of opportunity they get, the kind of funding they get, the kind of infrastructure they have, they will come here. But if I create a facility equivalent to AIMS here and provide you as much as the other parks and facility here, there will be many who will like to come. Also, as I said, the center of focus should be students and not just faculty, students also. Students, they go by the quality of faculty. They are good faculty, students, they come and work with that. That's a very kind of, so we are planning, this is a new strategy we are developing, where we create a center of excellence, say in a KGMU, on a particular specialized area, bring the best faculty in the country and the world, provide the same facility and perks and salaries as they get, and so this become an incubation for excellence in it. This is a very difficult, I know it's not going to happen in a day, but the idea is to bridge the inequality that we exist today. So that's this thing. Of course, there are many other issues that I'm not going to touch upon. So total 50,000 crore is the funding that we have factored in ANRF. Out of that, 14,000 will be given by central government, and remaining funds are to be generated from industry through philanthropy and also international bodies. We are setting up an innovation fund, separate innovation fund for working with the industry. So these are some of the key features that exist, and so I think I am not elaborating much because of paucity of time. But the transformation is in two ways: creating quality manpower, creating quality faculty, and also creating quality student. One area that is very important that we have, national chairs and all, they are very commonly seen in India, we have. But these chairs are sometimes become a kind of place for the so-called retired senior scientists to come and occupy position in your university, and they hardly have any meaningful contribution. But in fact, with the guidance on the higher authority and the leadership, we have developed a new kind of direction into this thing, where not just from India, but create a chair professors to be occupied by the Nobel laureates or equivalent scientists on the world, with again the same facilities and perks that they get. Of course, we can't expect Nobel laureate to come and work for longer period. But just imagine a Nobel laureate comes here to KGMU and work for even 1 month. How much excitement he will create, how much motivation he can create. So we are in fact planning short-term engagement of people at that level to work here, and they will be given the best of best facilities so they can work and see. So all kind of, I'm not, it's kind of, still we have a, so we are very excited. As I said, I was secretary CRD till 5th of February. I demoted my office, and now NRF has been set up. We are going to select a CEO for the NRF, and very strategically, the age limit for NRF, CEO of NRF has been kept at 70 years. So you can get the best people. So we are going to advertise this position shortly, and so this has already come into force, and I'm sure all of you must be excited about the kind of funding that is going to be available. So this is chaired by Prime Minister himself. So it is a very big initiative. It is the one of its kind institutions chaired by Prime Minister himself. And so there are many challenges to this thing. I think I'm not going to detail that. Thank you very much.
Thank you, sir, for your excellent presentation and insights into the future of science in our country, and the leading information which you gave for translational research and the involvement of the private sector also in the research funding. So thank you, and I hand over the mic to the organizers.
Now we will have felicitation ceremony for the speakers as well as chairpersons.
I respect all the respected chairpersons to please come forward and felicitate the speakers. Professor Gaurav Raj, sir. Dr. Neha Singh, ma'am. And Dr. Akhilesh Gupta, sir.
Now to felicitate the chairpersons, I would request Professor Anit Parihar, sir, to come forward and felicitate Professor Abbas Ali Mehdi, sir. I request Professor Manoj Kumar, sir, to felicitate Professor Anup Kumar Verma, sir. I request Professor Durgesh Dwivedi, sir, to felicitate Professor R.K. Garg, sir.
I would request Honorable VC ma'am, Professor Sonia Nityanand ma'am, to please come and felicitate Professor R.K. Garg, sir. I would request Dr. Durgesh Kumar Dwivedi, sir, to please felicitate Professor Amit Nandan Thar Dwivedi, sir. I would request Dr. Saurabh Kumar, sir, to please come forward and felicitate Professor Shailendra Saxena, sir. I would request Dr. Siddharth Mishra sir to please come forward and felicitate Professor Sandeep Bhattacharya sir.
Thank you to all the chairpersons.
We will shortly begin with the inauguration ceremony of the event.
Once again, a warm welcome to the workshop and symposium in CT and MRI. May this inauguration ceremony be the first step on a transformative and rewarding path.
For this very session, I would like to call upon stage the guests of honor of this inauguration ceremony. We extend a special invitation to our respected Head of Department, Radiodiagnosis, Professor Anit Parihar sir. Honorable Vice Chancellor, Professor Sonia Nityanand ma'am. Honorable Pro VC, Dr. Abjeet Kaur ma'am. Professor Anil Nishchal sir, Dean Faculty of Paramedical Sciences. Mr. Mohan Bhagwat sir, ISRT President. And Professor Durgesh Kumar Dwivedi sir. I would also like to request our chief guest for the event, Dr. Akhilesh Gupta sir, to please join us on stage.
Join us for a symbolic and auspicious moment as we illuminate the path of knowledge and collaboration. We invite everyone to participate in the lamp lighting ceremony. Let the light of wisdom guide us through this enlightening journey together. I request all the DICE members to kindly come forward.
Thank you, everyone. We are honored to invite Professor Anit Parihar sir, Head Department of Radiodiagnosis, to share his valuable remarks at our upcoming event.
Thank you, Dr. Ishta. Our chief guest today, Dr. Akhilesh Gupta, who has been just announced that is former secretary, Science and Engineering Research Board. He is also a policy advisor for the Department of Science and Technology, and we just heard him about his great lecture on how to for research funding. I welcome Professor Sonantan ma'am, Honorable Vice Chancellor, King George's Medical University, and I know how much she has been pressed for time, and she still took a time and has spent some time with us. Honorable Pro Vice Chancellor, Professor Abhijit Kaur ma'am, we welcome you, ma'am. Dr. Anil Nishal sir, KGMU Institute of Paramedical Sciences, he is Dean KGMU Institute of Paramedical Sciences. Mr. Mohan Bhagwat, he is President of ISRT Society, and our Organizing Secretary, Dr. Durgesh. Many dignitaries of the Diet, I will name a few of them, like Honorable Vice Chancellor, Era Medical University, Professor Abbas sir, and our former Pro Vice Chancellor, Professor Vineet Sharma sir, many of the former teacher, Neera Kohli madam, many of the heads of departments of the many faculties, like Professor Avinash, Professor Anil Gupta, Professor Sandeep Tiwari, our teacher association president, Professor K. Singh sir, I can see, and many other dignitaries of the dais, delegates, friends and colleagues. So this is a very unique type of thing which we are doing today. This is a symposium and workshop on new frontiers which are involving CT scan and MRI. So the focus today is on the technique of acquisition of CT scan and MRI images, the principles behind them, the physics behind them, the analysis of the images, the reconstruction of the images. And we have organized also a post-lunch session, both today and tomorrow will be focused on the hands-on workshops. So it is a very unique opportunity for many of the budding technologists and radiologists also. So many of the radiologists are unable to devote much time to understand the principles behind the acquisition of image and the processing of images. So this will be a very good opportunity for you to learn. And once you master the physics and the principle behind that, I hope that you will not be then overwhelmed by and you can exploit fully the capabilities of the technologies. So it will be a great opportunities for you all. And I think the team of Radiodiagnosis and ISRT and Philips will provide a very satisfactory experience to you all. With these words, I will hand over the mic to the organizers. Thank you.
A round of applause as we invite Honorable Vice Chancellor, Professor Sonia Nityanand ma'am, to grace the stage with her presence. Ma'am, please join us in gracing this event.
Thank you. So the chief guest for today, Dr. Akhilesh Gupta, the Pro VC, Dr. Abjit Kaur, the ISRT President, Mr. Mohan Bhagwat, the head of the Department of Radiodiagnosis, Dr. Anit Parihar, our Dean Paramedical Sciences, Professor Anil Nishal, and Dr. Durgesh Dwivedi, and all other esteemed guests in the audience, all the faculty members of the Department of Radiodiagnosis and other faculty members of the King George's Medical University, and all the participants, students and residents. On behalf of the university, a very warm welcome to all of you for this very interesting symposium on new frontiers in CT and MRI. You know, most symposiums and continuing medical educations will be on recent advances, advances which have occurred. But I think this title of New Frontiers awakens a curiosity as to what is in, for what technology is in terms of the CT, MRI, in imaging. I was very lucky that I heard the talk by Dr. Akhilesh Gupta. Normally, you come for inaugurations and then you have to leave because of the loads of work which is waiting. But I'm glad that Dr. Anit, you organized it in a manner that we could get to hear Dr. Akhilesh Gupta. He spoke on a topic which is actually very dear to my heart, which is on promotion of research in universities as a whole, in institutions as a whole in India, but most important, the promotion of translational research. And the launch of the research foundation, which he says was only launched last week, which is very heartening for us to get that news. If you see that medical research in the recent years, I'm just talking of the last few years, has gone forward because of interdisciplinary collaboration. It's the marriage between physics, chemistry, and medicine that has led to the evolution of technologies like CT, MRI, and biomedical imaging, for which we have an institute now in the city, the CBMR, the biomedical resonance imaging. It's actually the fields of physics and to some extent chemistry which have joined hands with medical science to result in this technology. You know, I have passed through an era where there was no CT, no MRI. It will be very difficult for the young faculty and students to understand this. When I was about to finish my medical school, the ultrasound followed by CT came in. So we've seen that era where the diagnosis was just based on ordinary X-rays. And once the CT came and then the MRI, I remember I felt that you're sitting inside the human body. Such is the power of actually delineating the structures, the normal structures, and thereafter the abnormalities in the body. It's really like sitting inside the body. And now there will be new frontiers, new aspects, new applications, new technologies in CT and MRI. Unfortunately, I cannot attend it, but Dr. Anit will update me about all these new, what is going to be new now in CT and MRI. Dr. Akhilesh Gupta himself, I was having a brief chat with him as he sat next to me. He's a physicist. And I'm sure, and he's from Lucknow University, you know, student of Dr. V.D. Gupta, who's a very dear friend of my father, you know. So it brought back old times also. And I'm sure he must be realizing how physics has given a good big thrust to medicine. So it's the era for interdisciplinary research. See, any research in the world ultimately is directed to mankind, is directed to human beings. So this kind of interdisciplinary research has taken medicine forward, and your and the Honorable Prime Minister's vision of launching this research foundation will definitely support research to a huge extent in the country in a different manner. And we too, all those people here should be encouraged after hearing this talk, because I always say that medical research, I feel, is the most important research because it's of direct application to patients, to mankind. And people who are working in radiology, in the imaging field, I'm sure will understand the gaps, the needs, and have a crosstalk with basic scientists so that it can be immersed, it can be clinically immersed. And I think that's the whole goal of this symposium. I wish all the good luck. I would like to thank all the faculty which has participated and is going to participate in this very interesting symposium, and good luck to all the participants. Thank you. Jai Hind.
Thank you so much, ma'am. We extend a cordial invitation to Mr. Mohan Bhagwat sir, ISRT President, to deliver his words of remarks. Your expertise and insights would greatly contribute to the success of the occasion.
First, I would like to thank the organizing committee for giving me a chance to, or the opportunity to use the podium of this reputed institute. I am here on behalf of ISRT, Indian Society of Radiography and Radiotechnologists. With the permission of the people who are on the dais, my seniors, colleagues and students. The profession of radiography start, as you know, from the mysterious rays discovered by Sir Rontgen. Correctly we are saying Rontgen, but no, it's the Rontgen. Accidentally he discovered this rays and gave the name unknown rays, means X-rays, because unknown is symbolized by the word X, so gave the name X-rays. One of his contemporary scientists named Sir Thomas Alva Edison approached him that please come and join my team, and within a couple of months we will be billionaire with your discovery. He was so noble person, he refused to join the team of Sir Thomas Alva Edison, and he never got this discovery patented. He let it open for all, for the humanity. We are from that race. Sir, in the absence of regulatory mechanism, the allied health profession in India were in pathetic condition. In 1943, a committee was set up under the chairmanship of Sir Joseph Bhore. He was Diwan of Madras Presidency and very senior most ICS officer. Nowadays we called IAS officers. And in 1943, before the independence, he gave advice to the government of India that the gap between the doctor and population is very wide and it is very difficult to shrink this gap in short period, so please strengthen your allied health professionals. But due to, you can say, the political willingness were not there, we were making our policies, those were doctor-centric. So the profession called allied health profession could not perform what community need. Finally, three or four visionary radio technologists, those who were sitting in a small room in Trivandrum, decided to set up a forum so the future of allied health professionals can be put in the state where dignity can be achieved. So, in 18th May 1997, the Society of Radiographers formed in Trivandrum, and later with the consultations of all the heads of hospitals, universities and faculties of national repute, on 9th September 2007, it adopted the constitution and the new name, which is now called Indian Society of Radiographer and Radiotechnologists. We approached to government to look after or to consider the upliftment of the allied health professional sector. But political willingness were not there. But one forum were there to fight with the government. We paid 21 visits to health minister, health secretaries and other various offices. Finally, government agreed to start initiative. Our demand was to bring this sector under either council or board or commission. When government formed a committee, they invited suggestions. I am glad that ISRT has given 119 suggestions, from which 102 suggestions were accepted as it is. That was a great achievement for us. We explained to the government that in the absence of the governing body, many ill-equipped institutes or roadside business issuing diploma, degrees, master degrees, and this ill-trained workforce destroying the mathematics of supply and demand. Supply is supply is huge while demand is less. So most of the people, they are spending the golden period of their life, 3 years or 4 years for studying radiography, and then they are leaving because they are not looking. Their future is bright in this field. But now, government has accepted our recommendations. From the 1st of July, the commission will start functioning. I would like to tell my students here that after the commission, there will be sealing on the seats, there will be exit exam. People, those are coming from the roadside business, they have to pass an exam that is called exit exam. So condition will not change. Radiographer and radiotech, who is the radiographer? Radiographer, I would like to add something here, sorry for 2 minutes. In my country, there was no radiographer. They were named darkroom assistant, X-ray assistant, no X-ray technician, no radiographer. Why? Because in the Second World War, when Japan came to Burma, near to India, to protect the India, American government sent their troops here. And they start one hospital called Diamond Crescent Hospital, which is nowadays known as Safdarjung Hospital. Earlier it was named Diamond Crescent Hospital, then they changed to the American Hospital, then nowadays it is Safdarjung Hospital. There, from Allied Health Force to the doctor, all were Americans. After the independence, only the manual staff or the sweepers or the attendants, those who are working there, they were promoted. For example, those who are working in the darkroom, he was promoted as a darkroom assistant. The person who was assisting in the radiography room, he was promoted as a X-ray assistant, like that. But now, similarity is there. Only one title will be given to you, that is called radiotechnologist. Sir, radiographer is the eyes and ear to the radiologist. Because radiologists seldom interact with the patient, only for the special investigation or interventional procedures, they are interacting with the patient. But radiographer is the highly specialized person who is having the penetrating eyes, which is looking inside the patient body without actual patient is there. Yeah. Due to scarcity of time, I am thankful again for the organizing committee for inviting ISIRT here, and hope all you will be benefited from this scientific program. Your knowledge will be enriched. Thank you very much.
Thank you, sir. Now I request Professor Anil Nishchal, sir, Dean Faculty of Paramedical Sciences, KGMU, to enlighten us with his wise words.
Chief guest of today's function, Dr. Akhilesh Gupta ji, Honorable Vice Chancellor Madam, Professor Sonia Nityanan Ma'am, Pro Vice Chancellor Madam, Professor Abjit, Mohan Bhagwat Saab, President ISRT, Dr. Anit Parihar, Dr. Durgesh, and many other honorable dignitaries sitting in the audience. I can see my seniors, ex-heads, so it is an honor to address all of you, and the esteemed and learned faculty and resource persons who have come for this conference from KGMU and other institutes, delegates and dear students. I shall begin by thanking Dr. Anit Parihar and Dr. Manoj Kumar for planning a very good conference. This is in a long time that a conference has been planned with an idea of catering to training, continued education of allied health professionals. For radiologists, there are many conferences, but being Dean Paramedical, I am really thankful to Dr. Anit and Dr. Manoj and their team for planning such a conference and an activity in which everybody gets to learn, and the paramedical students of our faculty are getting this kind of an exposure. I went through the scientific program, and it is a real academic feast, I must say that, and it caters to different levels. It goes from the very basics to the higher levels. So everybody has something to learn from the conference. And then I also noticed that they have planned hand-on workshops. They have also planned some very interesting things like quiz, and then model competitions and poster competitions, which would enhance learning and make it more interesting. So all kudos to you, and I'll urge my students in the Department of Radiodiagnosis. Actually, 1/4 of the students of paramedical sciences are posted with Radiodiagnosis department because they run 3 different courses in MRI, in CT, and in X-ray. So I would urge all my students to attend the sessions, listen carefully, learn, and ask questions if you feel like. Enjoy the academic feast. I wish you all the best.
Thank you so much, sir. I am pleased to invite Honorable Pro VC Ma'am, Dr. Abjeet Kaur Ma'am, to please join us on stage. Let's welcome Ma'am with a round of applause.
Good afternoon, and my salutes actually to all the dignitaries here. I am actually in awe of this meeting for the simple reason that after having a word with Dr. Gupta, I realized that we have the material and we have actually found friends who can help us streamline our material. वो जो हमारा हर टाइम की प्रॉब्लम होती है ना, डेटा एनालाइज कैसे होगा, लिखेंगे कब, कैसे स्टैट्स लगेंगी. Here we have an organization headed by Dr. Gupta under the tutelage of the Honorable Prime Minister. They're actually willing to give it to us on a plate. I have, as an ophthalmologist, witnessed the marriage of science, basic sciences and clinical sciences so closely that during residency we used to actually tie a metal ring on the eye of a patient who had a foreign body. Look at the amount of trauma, look at the amount of time that was wasted, and after all that, how inaccurate our assessment could be. And now Dr. Gupta tells me that there is something which is called quantum physics which is going to be coming, and that is going to reduce our imaging time to 20 minutes. Unbelievable. I think it is time for us as clinicians now to actually pull up our socks and get on to this bandwagon, because if we don't jump in, others will jump in before us. In the position that I hold, I honestly would want the young faculty, the residents, the technicians of our institute, everybody has ideas. To just put your pen to paper and something will come out. I wish this Congress a great time, great learning, great deliberations. Best wishes to all. Thank you.
Thank you, ma'am. We extend a heartfelt invitation to our chief guest, Dr. Akhilesh Gupta, sir, to enlighten us with his words.
The Honorable Vice Chancellor of KGMU, Dr. Sonia Nityanand, the Vice Chancellor, Dr. Ravijit Kaur, all the distinguished guests on the dais and off the dais, the constituent student. Well, I have spoken about the research, so I will not speak on research now. I'll talk about something else. You know, I don't know how many people know in this hall that government of India in last 10 years launched nearly 3 dozen national missions. It's a record of all time. 3 dozen national missions. And out of that, nearly half of them were on technology. So, technology-driven missions, there were several missions, but 2 missions which were close to Kian heart, and then I had the kind of honor of leading these 2 missions. The one mission was the mission on cyber physical system, and the National Quantum Mission, which was launched recently, and so many of you know the quantum mission that was launched. Now this quantum technology is going to change again, they bring transformation in the way medical sciences are done. You see, it will impact many other sciences, but the medical sciences is going to be impacted very, very majorly through quantum. There are 2 areas that the medical science need intervention. One, whatever your CT scan or the CAT scan, all that. I am not expert in this area, but as a physicist I understand. What are the challenges that you have? You have 2 types of challenges. One challenge is the accuracy of sensor and the speed with which you process the image. So imaging have these big challenges. The quantum technology is going to solve these 2 areas. One, that the accuracy of sensors or imaging is going to increase like anything. Multi times increase in the accuracy and the speed also. Today, I think you know more than me, I think this is like, I'm talking in front of all of you who are experts. So like, you have this, say CT scan. CT scan has, you get the information on shape and size of the tumor, but the resolution is low. And you need high resolution, so sensor still not accurate to give you a ring. Then you have CAT scan, there also you trace the tumor by detecting metabolic activities, but that requires radioactive tracers to inject and get the result. MRI is high resolution, but it's time taking, and accuracy also is not very high. Now the quantum technology is going to bring 2 things. and in a kind of transformative changes. And this is going to happen. India has already launched this quantum mission with a total budget of 6,000 crore. And the Department of Science and Technology is the lead organization implementing this mission. It's going to bring speed and quality. So there's a new technology that we call it magnetic resonance fingerprinting, MRI, magnetic resonance fingerprinting. That will make these changes, so it will become like, you know, how you do it in MRI. So you would get the dark and the light spots, and radiologists, they had to interpret, this thing, because you are detecting, the MRI is for the entire tissue. The MRF is going to be at the level of single molecule, not for the entire tissue, or the group of molecules, insected molecules, tumor connected with the tumor. And that will bring all the change. So you can have the accuracy will be very high, but more importantly, so it can differentiate between the tissue type of different kinds. But more importantly, the speed. The speed will be, because of the quantum computing, these will be driven by through a quantum computing system, which will be several hundred times faster than the present computing. And therefore the accuracy will and the speed both will go high. And therefore the entire medical diagnostics will get a transformation because of this. So this technology is being developed in India, and already there are many institutions that have already started working. And this is the area of research for the KGMU also, for the radiologists to get the quantum technology. So I wanted to mention that there is a national call for quantum technology already on, and those who are working in this area, if they have any interest, can apply for the call. The last date of the call is 20th March. So it is there still, and you can collaborate with other institutions, the IITs, the universities, can join hands and come for this. So this is the area of research, new, upcoming, emerging research area that is going to be, come to India in a big way. The other area there is going to be, going to emerge is the artificial intelligence and the ML and the related technologies that are going to come. See, doctors have been traditionally working with their conventional system, but now time has come that the medical professionals, they need to switch over to these disruptive technologies. So there are going to be new algorithms. I hope many of you may be working on these algorithms. But these software technology development in the area of AI, ML, are going to be. In fact, there is a technology that as part of our national mission we had developed in IIT Delhi, is a cobotics. And cobotics and medical cobotics are becoming very popular, that you can experiment on robots before experimenting on actual patient. In actual patient time, actual patient case, you get very little time. While most of these patients, they come in the emergency, and they risky to do any experiment on the live patient. But you can do those experiments on the robots, through a covatic system. So all this, I think, as I said, there is a need for transitioning the conventional system to advanced disruptive technology system. And the source of opportunities are available. The government has brought in so many new kind of technologies into this thing. And I'm sure many of you would like to get the advantage of that thing. I would end by saying what Professor Javadit Kaur mentioned, that there is one gray area that medical professionals, especially the OPD, the doctors face, that they don't have enough time to collect the data, real-time data of their patient, because the OPDs are full of patients and there is no time available for doctors to sit and collect the data. And so the DST has been in fact supporting such kind of intervention, where the product staff and the research staff can be provided to the doctors. They can sit in the OPD with doctors, help doctors collecting data, and also do research later on. As part of the NRF also, there is a kind of provision to do this thing. I think that is another area, gray area for medical professionals. We do so much. In fact, India is very rich in terms of the diseases and patients, but somehow our data collection has been very poor, and not because of the fault of doctors, but because of the system that did not exist, and mostly the doctors remain so occupied with the patients because their duties are such they do not have enough time to collect data. I think it is the research agencies are supposed to provide that support to them. Once again, I thank the Vice Chancellor and the institution for inviting me, and it is really very excellent experience for me. I'm not from your profession, but I enjoyed my interaction and my talk with talking to you. Thank you very much.
Thank you so much, sir. In extending our heartfelt appreciation, we would like to express deep gratitude to our esteemed guests. For that, I would like to invite Honorable VC Ma'am to felicitate Dr. Akhilesh Gupta, sir, our chief guest of the event.
Sir,
I would request Professor Anit Parihar, sir, to felicitate Honorable Vice Chancellor Professor Sonia Nityanand, ma'am. Thank you, everyone.
Please join us in inviting Professor Durgesh Kumar Dwivedi, sir, on the stage for his vote of thanks.
Can I have my slides, please? So thank you so much. Wait, वहीं से करेगा. Just quickly, okay. So, all right, leave it. So first of all, I would like to thank Professor Akhilesh Gupta sir for such an enlightening talk, and he elaborated very nicely the nitty-gritties of research gaps, funding mechanism, and everything. He also talked about the initiative he has been started with the government of India. The reason I have called him, the main reason, well, he is, of course, is a physicist, but he is the policy advisor in so many things, quantum mission and all. And somehow, many of my friends who are in AIMS and outside also are like other in IITs, because IITs are going to have their own medical school. So somehow, with the help of Honorable VC ma'am, who herself is a very leading researcher also, so this is the right time to initiate, and something like we would request like to have a center of excellence and something like that, and so that because ma'am has already built a great facility, the stem cell world-class facility for that. So that's the reason. That's the main reason. Because sir is also policy head in several other things. So I'm special, very kind of thankful to you for gracing the occasion, sir. I am also thankful to extend my heartfelt thanks to Professor Sonia Nityan ma'am for our Honorable Vice Chancellor madam for her invaluable support and commitment for the research, and of course she is very busy, but she attended the talk also. So I'm highly thankful to you ma'am also. I know you are very busy. Thank you so much, and we would like to more support for the research and other things for the ISRT also. Special thanks to Professor Abhijit Kaur ma'am, Professor she is also heading the Department of Ophthalmology, for her busy time and taking some time to spend and kind of giving us her valuable insights. Special thanks to Professor Mohan Bhagwat sir also, who is currently ISRT president, and who has also kind of explained all the issues the society is facing. My word goes to Professor Anil Mishra sir also, who is Dean Paramedical. So thank you so much sir for attending the inauguration session. And this conference could not be possible without the support of our head of department, Professor Anit Parihar. So give him a big round of applause also. And so I'm highly thankful to him also. And of course, this conference cannot be possible without the speakers and delegates. So I'm thankful to all the speakers, especially coming from BHU, AIMS, Delhi, and southern part of India also. So thank you so much. I'm also thanking all the heads. So many heads are sitting here from SGPGI, Gaurav sir, SGPGI, Gambhir sir, Professor Archana Gupta ma'am, and so many heads, Professor Anil Gupta sir, Professor Avinash Agrawal, Professor Dividi sir, and Professor Neeraj Sinha is also amongst us, who is from CBMR. So thank you so much sir. Our ex-head, Professor Meera Kohli ma'am, Professor Garg sir, thank you so much for your time, and KK Singh sir, and so many other. Sorry for, because we are running out of time. And this conference could not be possible without having a good team. So I want to congratulate my team also. And of course there was some issue, but we were able to perform it. And this is also the time to thank the sponsors also. A special thanks to our Philips team for sponsoring this, and also the media person who has come, print media, electronic media. So thank you all for coming and covering the occasion. I'm also thanking our Akhilesh Gupta sir, all the speakers. There is one I wanted to play one small thank you note by Professor Vikas Gulani, who is chair of radiology. That's why I brought my laptop here.
So he is in a workshop, he is organizing an accessible MRI workshop, but somehow this is not able to connect with the slides over there. So he is organizing a great workshop. 50 speakers from US and Europe has come. So I was there for like a half day yesterday. And so he also thanked us. He wanted to attend in person also, but somehow he could not come. So with that, I thank all the participants also, delegates. Please enjoy. And this is the time when you interact also and learn so many things. So with that, I thank you all. Thank you.
Thank you so much, sir. We would like to invite all of you to please stand up at your places as we pay tribute to our homeland with the singing of our national anthem.
Thank you, everyone. Indulge in a delightful lunch experience. Head to the adjoining room for lunch and enjoy some networking opportunities. We will resume our scientific sessions promptly at 2 p.m. Thank you.
hello, check, hello, check, hello.
नहीं कैमरा नहीं निकालूंगा।
निकल गए क्या तुम? अच्छा तो अभी हो यहाँ पे? तो हम इसमें हॉल में बैठे? हाँ कॉन्फ्रेंस हॉल। आओ आओ।
Vice Chancellor, Madam Professor Abjeet, Mohan Bhagwat Saab, President, ISRT, Dr. Anil Parihar, Dr. Durgesh, and many other honorable dignitaries sitting in the audience. I can see my seniors, ex-heads. So it is an honor to address all of you. And the esteemed and learned faculty and resource persons who have come for this conference from KGMU and other institutes, delegates and dear students. I shall begin by thanking Dr. Anil Parihar and Dr. Manoj Kumar for planning a very good conference. This is in a long time that a conference has been planned with an idea of catering to training, continued education of allied health professionals. For radiologists, there are many conferences, but
I request all of you to please gather in the auditorium. We are about to start. And I request everyone in the auditorium to please be settled. Good afternoon, everyone. This is Shakib and Ananya, junior residents from Department of Radiodiagnosis, King George Medical University, Lucknow, and we'll be taking up with the further proceedings for this session.
Welcome back, everyone. We hope you had a delightful lunch and a chance to recharge your batteries. Before we delve into the afternoon session, let's take a moment to recap some of the highlights from this morning's session, where we explored the world of CT, shedding some light on recent advances like dual energy CT, photon counting CT, as well as got some insight into the challenges faced by our technologists.
And moving on, we'll be exploring yet another upcoming modality, that is PET CT and its various applications in the following section. And as we move forward, our afternoon sessions will also promise to be equally captivating, featuring an array of exceptional speakers. But before we proceed, we encourage all of you to actively participate in these discussions and ask questions as well as share your own experiences. Without further ado, I would like to invite upon the chairpersons for this event. Our first chairperson is Professor Neera Kohli ma'am, former head of Department of Radiodiagnosis, King George Medical University, and current professor, Department of Radiodiagnosis at HIMSS. Ma'am, please. Please give a huge round of applause. Next, I would like to call upon Professor S. Gambhir sir, Professor and Head, Department of Nuclear Medicine, SGPGIMS. Please give a huge round of applause.
Next, I request Professor Avinash Agarwal, Professor and Head, Department of Critical Care Medicine, KGMU, Lucknow, to come upon the stage.
Sir will be joining us shortly.
Sir is not here. He'll be joining us shortly. Next, I would like to invite Professor Anil Gupta sir, Professor and Head, Department of Physical Medicine and Rehabilitation, KGMU, Lucknow. Okay. He'll also be joining us shortly.
So currently I would like to ask our respected chairpersons to please carry on the proceedings and invite our first speaker. Ma'am and sir, please.
Hello. Good afternoon. So, welcome after the lunch break and very exciting morning session on CT and new technologies related to CT. In this session, we have two talks. One is on PET CT. For that, I invite Dr. Nishikant A. Damle, Dr. Damle is additional professor of nuclear medicine at AIIMS, New Delhi. Dr. Damle has had a very illustrious career till now, and he's been part of our nuclear medicine fraternity and has held many posts, and he's a very avid researcher and member of Indian Thyroid Society. A lot of work on thyroid comes out of AIIMS, which is diagnostic as well as therapeutic. As you know, nuclear medicine is therapeutic also, what we call the theranostics. So Dr. Damle is very active in this field, and he has a lot of publication, projects. He is guide of MD, and they have MSc nuclear medicine course, so he runs that too. And they have what the first DM in nuclear medicine course at AIIMS, and where the focus is on the therapy. So I invite and welcome Dr. Nishikant Damle to join us and give us a exciting talk, so everybody is awake and listening to you. Dr. Damle, please.
Thank you, Professor Gambhir sir, for the kind introduction. My dear friend Dr. Durgesh Dwivedi, he has given me a task that looks like a Duckworth lace in the cricket match. So he said that please explain the basics as well as the clinical applications in 25 minutes. That is next to impossible, but I'll try my best. This lecture is basically tailored for our technologists, radiographers, and the junior residents. Feel free to ask me questions at the end of this lecture. So, when we talk about PET-CT, are we looking at a modality which is a one-stop shop answer to all our clinical queries? Let's find out. What's PET-CT? PET-CT is a hybrid imaging technique which consists of emission tomography and transmission tomography. So, emission tomography is PET, transmission tomography is CT. It provides functional as well as metabolic information along with anatomic localization and characterization. So, that's PET-CT for you. Gamma camera is the old workhorse of nuclear medicine. This was invented by Hall Anger, and the fusion technology that has come up with gamma cameras is called as a SPECT-CT, that is a single photon emission computed tomography. The PET-CT relies on the principle of positron emission. It actually ends up yielding 2 photons, so it's a kind of dual photon emission computed tomography. It's a relatively recent technology. Let's see the history of PET-CT in brief. So we saw in the morning sessions that the first CT scanner, was around about 1972. It came up. The first PET scanner was developed by Michael Phelps as early as 1976. But the commercial introduction was attempted only in 1981, and the first scanner was introduced for clinical use as late as 1998. Now in 2001, FDA approval was granted for PET-CT, and the first PET-CT was done at the University of Pittsburgh by David Townsend. This is how a PET-CT machine looks. So you have a PET gantry and you have a CT gantry, right? So we do a CT, whole body CT first, followed by a emission tomography or a PET scan. These are the commonly used radioisotopes, right? One has to know the difference between a radioisotope and a radiotracer. So if you can see, this fluorine 18 that is used is the isotope, and when it is stacked to 2-deoxyglucose, we get what we call as fluorodeoxyglucose or FDG. So similarly, we have a host of PET-based isotopes like carbon-11, N13 nitrogen, O15 oxygen, and something else that you might also have heard about is gallium-68. So people must have heard about DOTANOC, DOTATOC scans, right? So that they are done using this gallium-68. Moving on, what is coincidence detection, or what is the funda of PET basically? So when we have a positron emitting isotope, let's say fluorine 18, what happens is, let's say I have tagged it to glucose. Now this fluorodeoxyglucose basically is going to be taken up by the highly metabolically active tumor cells. There it is that F18 is going to release a positron, okay? Now just like we used to watch in our childhood, in Ramayana, Mahabharata, you know, we used to watch those scenes where two arrows would be shot from opposite sides and they will end up annihilating each other, and then there will be some light. So this is exactly what happens here. This is the annihilation reaction. The positron gets emitted, it annihilates with the free electrons in the body, and two photons are emitted anti-parallelly and are detected by the detectors within a coincidence timing window, which registers it as an event emanating from this point. So this is the funda of annihilation. Now PET-CT, the workhorse is glucose utilization demonstrated by fluorodeoxyglucose PET scan. And so this is the structure of glucose, and this is 2-deoxy, 2-fluoroglucose. So a slight chemical alteration, and we got FDG, which has been recently labeled as a molecule of the 20th century. Now this glucose goes inside the cell and gets trapped as glucose 6-phosphate. The enzymes, you know, in the glycolytic pathway recognize this pseudo-glucose and they don't let it proceed further. So once inside a tumor cell, the glucose gets trapped as glucose 6-phosphate. It can't come out. So from here, that fluorine 18 is going to emit the positrons from within the cell. This is the normal biodistribution of FDG. You can see physiological high uptake in the brain, excreted activity in the bladder. You can see the kidneys, you can see the bone marrow, you can see the liver and spleen. So this is a FDG normal biodistribution. So what are the current clinical questions to PET-CT? Does it have a role in the diagnosis of a primary tumor, in the early detection, in differentiating malignant versus benign? Does it have a role in staging? Does it have a role in monitoring response to treatment? And importantly, does it have a role in detecting recurrent or metastatic disease? The answer is yes. Now, this is an example that I would like to show you. This was a benign pancreatic lesion showing no FDG uptake. Conversely, you see another lesion in the pancreas with intense FDG uptake. This was a malignant lesion. This was a patient who had a carcinoma with unknown primary with brain metastasis. You can see this lesion here. And on the PET-CT, we found a lesion in the lung, which was proven to be an adenocarcinoma. This is a patient who presented to us with pyrexia of unknown origin. And when we did PET scan, the whole body PET scan, you can see the image is self-explanatory. Multiple lesions in the bone marrow, multiple lymph nodes. Now this patient actually turned up to have a Hodgkin's lymphoma. This was a patient who presented with recurrent falls, and it was probably thought due to some cerebellar dysfunction. Paraneoplastic etiology was suspected. Here you can see there is increased uptake in the cerebellar hemispheres, reflecting cerebellitis. And when we did the whole body imaging, we found a lung primary. Again, another example. This is a 5-year-old boy, right, who presented with bilateral cervical lymphadenopathy. This is the image. You can see bulky disease on both sides. What did the biopsy show? LCH, right? Again, this patient presented with what we call as HLH or hemophagocytic lymphohistiocytosis, and the clinician was clueless as to why it is occurring. And in the PET-CT, what we found was hepatosplenomegaly, bone marrow hypermetabolism, and lymph nodes, right? So biopsy actually revealed lymphoma as the trigger for HLH. This was a patient who presented again with pyrexia of unknown origin, and the source was not known. The PET-CT, however, showed diffuse enlargement of bilateral adrenals with intense uptake, and the diagnosis that was finally established after a CT-guided biopsy was histoplasmosis. So you see, it is very useful in forming a diagnosis. Many a times our clinicians are lost for a cause for the symptoms of the patient, and this is exactly where PET-CT helps. Then in baseline staging, it has a role. You can see here, this was a patient with RCC, and he underwent a PET scan for staging, and multiple lung nodules were seen, so directly upstairs to stage 4. This was again another patient who came, for a preoperative workup and complaining of shoulder pain. So, again a large lytic lesion was seen here, and this was a metastatic lesion from an RCC. Another example, a patient with adrenocortical carcinoma having functional symptoms too, and the whole body PET scan reveals the entire extent of metastatic disease in the same setting. You can see lung metastasis also. What about recurrent disease? If biochemical or tumor markers are raised, can we find out disease on PET scan? Yes. So let me give you an example of tennis syndrome. This is thyroglobulin elevation with negative iodine scan. This is typically seen in the thyroid cancer patients after some years of radioiodine therapy, when the tumor stops concentrating the radioiodine. So this was a patient with the tennis syndrome. The ideal modality for evaluation here is a PET scan, And what did we find? We found bone metastasis in this patient, which can be clearly seen. These were the lesions that were documented on the PET CT. So another example, again, this is an RCC, and with suspected recurrence, a patient again complained of abdominal pain, and if you can see here, there is a recurrence here, there is an IVC thrombus also, and there is a contralateral adrenal involvement. One more example of the same. Sometimes you can find a lot of new sites of disease. So this was a patient with carcinoma right breast post-surgery and chemotherapy, and look at what the PET scan shows. The image itself is self-explanatory. You see extensive involvement of the bone and liver. Assessment of response to therapy also is a good indication. So you can see on the left-hand side there is a lung nodule in the first PET scan, this one, and it has disappeared on the follow-up PET scan. Now, in different malignancies, it's impossible in this short time to survey the whole spectrum of roles. But briefly, in head and neck malignancies, many a times it helps us in differentiating relapse from treatment side effects and has a high diagnostic performance in recurrent disease detection. So this is an example of a patient who had a recurrent disease. Again, on the three-dimensional MIP image which is seen, you can find the lesions very clearly. They stare at you in the neck, right? If I move ahead to lung cancer, yes, the first role that was established was for the evaluation of a solitary pulmonary nodule, also used for preoperative staging of lung cancer, but in a country like India, there is some reduced specificity in interpretation of mediastinal lymph nodes, because that's a ubiquitous finding in our country. In the Western literature, however, that's not so. So this was a patient, with an aggressive lung malignancy, as you can see in the lower right side. An incidental detection of involvement of spinal cord was seen. I pointed it out with the arrow. So this was an additional lesion seen. Again, if you see this, a patient with a small cell lung cancer, and you can see that in the initial study, there was a lung lesion. In the follow-up study, however, we found a lesion in the brain, a metastatic lesion in the brain. So many a times patients do get upstaged following a PET scan. In breast carcinoma, yes, its uptake is higher in triple negative and HER2 positive malignant lesions. So many a times it can lead to upstaging or downstaging. Literature reports about 20% change in patient management. This is just an example. This is a patient with CA breast, and you can look at the liver. The liver is staring at you. It is studded with metastases which are highly FDG avid. This is a very poor prognosis. This is just another example showing the same. Now in gastroesophageal malignancies, we have a role in detection of M1 disease rather than locoregional lymphadenopathy and detection of primary. Nevertheless, here you can see there is a primary and there is a gastrohepatic lymph node which is clearly seen. One caveat one must remember is that mucinous and signet cell carcinomas of the GIT show very poor uptake of FDG, so it's not the ideal modality there. In lymphoma, similar indications exist, but one upcoming indication is in post-transplant lymphoproliferative disorder, and then before bone marrow transplantation in case of low-grade lymphoma suspicious for high-grade transformation. So these three are the ones which are slightly out of the box. PTLD is a common setting that we see in institutes. Before bone marrow transplantation, they need a negative PET CT before they go ahead. And if you are suspecting high-grade transformation, again FDG PET CT is a good modality. This is just an example, showing a lymphoma with extensive nodal and bone marrow involvement. In multiple myeloma, again, not so much in primary diagnosis, but in detection of residual disease, there is an important role. And as a surveillance modality also it is used these days. So I'll just give you an example. So on the left-hand panel, you can see before treatment scan where there was no uptake in the bone, and after treatment, the disease actually progressed. So you can see avidity in the humerus as well as the femur. In gynecologic malignancies, it has no role in the primary diagnosis, but it is usually employed to rule out distant metastatic disease and has a proven role where there is elevation of tumor markers after primary treatment. Also, radiotherapists many times ask us to point out the highest lymph node that is seen so that they can plan the radiotherapy accordingly, right? And this is just an example showing the same. This is an endometrial carcinoma with very high avidity, but here you see that there is a left-sided lymph node also in the obturator region. Now, some off-label indications are also there for our imaging modality. So this is a case of tumor-induced osteomalacia, where you can actually see in panel D, you don't see anything here, but panel E, this is an image from a DOTA-NOC PET scan, and it localized the culprit tumor very easily. It was removed by the ENT surgeons, and the patient was fine. What about non-oncological applications of PET-CT? Are there any? Yes. Infections. I showed you an example of histoplasmosis. This is another example in neurology. Now, if you look at this patient was having forgetfulness, and the neurologist was suspicious for Alzheimer's disease. Borderline mental status examination, MRI did not reveal anything. And here if you see, there is a very typical pattern that we call as the TP pattern of Alzheimer's disease, or the temporoparietal pattern. So you can see hypometabolism in bilateral parietal cortices as well as bilateral temporal cortices. So this image was classical for Alzheimer's disease. Another example of neurological disorders, this is dementia with Lewy bodies with bilateral temporal and parietal hypometabolism, and there is some asymmetrically reduced uptake in the left visual cortex also, which is evident here. So this was dementia with Lewy bodies. What about frontotemporal dementias? Many times they present with a lot of behavioral changes, and the family and clinicians are both worried as to what is the diagnosis. So you can see here, this is a very clear, this I have taken from literature. So you can see clear hypometabolism in the frontals and the temporal lobes. So this is a typical frontotemporal dementia. Now I move on to the other tracer that is these days in discussion, that is the DOTA-NOC, DOTA-TOC, or the DOTA-TATE PET-CT. Now this OC is basically octreotide, right? And DOTA is the chelating agent. It's just like a father crossing a road with two kids, one on right hand, one on left hand. So when I say gallium-68 DOTA-NOC, DOTA is the father, gallium-68 is the kid on the left, octreotide is the kid on the right. So DOTA is required to keep these two things together, right? So the affinity for somatostatin receptors in the body is variable, and I have shown it. DOTA-TATE is more specific, DOTA-NOC is more sensitive. This is normal biodistribution of DOTA-NOC. You can see uptake in the pituitary, then the hottest organ is the spleen, followed by the kidneys, followed by the adrenals, followed by the liver, and excreted activity seen in the bladder. It is used for all these indications, FUOs, paragangliomas, neuroendocrine tumors, MTCs, and some odd endocrine syndromes also. Like Gambhir sir mentioned in his introduction, we do a lot of radionuclide therapy. So we have something called as PRRT, or peptide receptor radionuclide therapy. I'll show you what it is. Many a times to confirm the neuroendocrine nature of a lesion, DOTA-NOC is required. Diagnosis of primary site, again another important indication, and to assess multifocality and response assessment. So this is how a DOTA-NOC scan looks, and you can see the liver is studded with lesions, and there is a pancreatic primary that is very evident. Now this is a pheochromocytoma. You can see there is a lesion which is, quite large lesion, which is showing uptake which is almost equal to the liver. On the MIP image it's not evident, but in the sections it is very evident. So this was a pheochromocytoma. Now this is a patient with MEN2A, or multiple endocrine neoplasia 2A, and in the same setting you are seeing a thyroidal lesion, you are seeing a parathyroid lesion, and you are seeing bilateral adrenal lesions. So it's a one-stop shop imaging modality revealing all three sites of disease in the same scan. This was a patient who had a suspected pancreatic NET, and when we did a DOTA-NOC, incidentally we found bilateral glomus jugular. Look at the skull of the patient. You see two foci on either side. These are bilateral glomus jugular. Now, sometimes you can find multiple paragangliomas in the same patient. You can count the number of paragangliomas here. 2 in the neck, 1 in the mediastinum, and 3 in the abdomen. Right? I move ahead. Sometimes we give therapies with MIBG as well as PRRT. If I have to take a decision as to which therapy is better for this patient, then I do both the scans and I see the uptake. On the left hand panel you can see there is a presacral recurrent pheochromocytoma, but it is hardly concentrating MIBG. On the right side panel you can see it is concentrating the lutetium, it is concentrating the gallium DOTA-NOC very well. So if it's concentrating gallium DOTA-NOC, then my preference for therapy will be lutetium based PRRT with DOTA-TATE. Now this is just an example. You can see the left hand images, a patient with a metastatic neuroendocrine tumor, and after we gave PRRT, you see that there's a very good partial response that we see. The disease has decreased by at least 70 to 80%. A similar case I am showing here, just to reinforce the message that the lesions do respond very well to PRRT.
and Dotonok can be used for imaging the same. Now this was a solitary liver metastatic lesion, it disappeared after PRRT, the patient is free of disease. Other PET scans in use, you must all have heard about fluorocholine PET-CT, F-DOPA PET-CT, Exendin and PSM. I'm just going to touch upon them. Now see, this was a MEB scan that we had done for a patient, okay. The MEB scan is done for parathyroid adenomas. Now can you see in the upper left panel, you see two foci, one is clear and the other is suspicious. In the delayed image you see one clear focus and two doubtful foci, or maybe two clear foci and one doubtful focus. So I don't know whether I'm looking at one adenoma or two or three, but when we did a choline PET scan, look at what the result is. Three clear foci. I think everybody from the last row also will be able to appreciate. You can see three foci in the neck. All three were adenomas and were successfully treated by the surgeon. This is the beauty of choline PET imaging. Again, a very small ectopic adenoma here in the mediastinum. I pointed it out with my arrow. This patient had a calcium of 11.4 and a PTH of 136 with a negative MEB scan, and choline showed the way. Right? Moving on to hyperinsulinism or hyperinsulinemic hypoglycemia, we have Dotonok PET as well as a DOPA PET. Right? This is dihydroxyphenylalanine. Right? We tag this DOPA with the F18, and I have just pointed out the neuroendocrine tumor in both the scans. On the Dotonok also you are seeing it, and on the DOPA also you are seeing it. So this is the DOPA PET-CT. Right? Okay, again another example, but in a kid. In kids, we have a condition called as congenital hyperinsulinism, which many a times could be because of a focal lesion, and F-DOPA is a good modality for localizing the same. Now, there is another scan which is used these days, which is called as a gallium-68 Exendin-4 PET scan. Now, Exendin is actually a GLP-1 targeting agent. So, for patients with insulinomas or culprit lesions causing hypoglycemia, Exendin scans or Exendin PET scans are the best modality right now. Now, this is again an example of an Exendin PET scan. It is showing multifocal disease in the pancreas. So again, my message is for FDG as well as Dotonok as well as many of the PET tracers, you will find multifocality is a very important finding that we see on many PET scans. What about prostate cancer? Now, general funda to remember is that FDG PET scans are not to be recommended unless and until they are negative on the PSMA PET-CTs and there is suspicion of recurrent aggressive disease, only then it should be done. Then what should we do? We should do PSMA PET scans. PSMA is prostate specific membrane antigen, right? So these PSMA PET scans basically are highly useful. This is a image of a PSMA PET scan which I have shown, and with the yellow arrows I have highlighted the lesions. Okay, so you have a primary prostatic lesion that is infiltrating into the bladder. In the panel D, you can see it infiltrating into the rectum, and it is also involving bilateral external iliac nodes. Now again, this is a 59-year-old male who underwent a PSMA PET scan. His serum PSA was 837, so obviously we are looking at metastatic disease. But in a single modality, we were able to show the primary lesion, its extent, the lymph nodal involvement, as well as the extensive bone metastasis. Now this patient can also be taken up after conventional chemotherapy lines have been exhausted for a therapy which we call as lutetium-177 PSMA therapy. And this therapy has been shown to not only prolong the progression-free survival, but also result in a significant quality of life improvement in these patients. Just some techniques in PET-CT I wanted to highlight. A non-contrast and a contrast enhanced image. Sometimes lesions which are not very apparent to us on non-contrast images do get seen easily on contrast images. This is very typical for those malignancies which have low FDG avidity. If there is low FDG avidity, using the standard non-contrast CT that we do, it's sometimes difficult to see lesions. So contrast CT is useful in those cases. PET-CT enterography, yes, another technique, very efficaciously used for finding small lesions in the small and large bowel. And this is another technique called as a post-Lasix view. Suppose, let us say there is a lesion in the bladder, and the bladder itself has a lot of FDG because the kidneys are excreting it. So typical sun and star effect, what we say, din mein tare nahi dikhte. We don't see the stars when the sun is there. So what do? You wait for the sun to go down, then you see the stars. So how do we achieve this? So in the first upper panel, you can see there's a lot of excreted activity in the bladder, and there's a lesion just posterior, just along the 5 o'clock to 6 o'clock position in the posterior and right lateral wall of the urinary bladder. In the early image, you are not able to see the bladder lesion at all. Can you see it? Nowhere in the upper panel can you see that lesion. So what did we do? We injected Lasix, encouraged the patient to void frequently. After the bladder became cooled, that is most of the radioactivity was cleared from the bladder. Now the bladder is looking dark and the tumor is showing FDG uptake and is visible. This is called the post-Lasix view. Now, just a brief comment about dose reduction in PET-CT. Everybody is concerned about the ill effects of radiation. So how do we go about reducing these doses? So we need to understand what are the normal doses received in a standard FDG PET scan done with 10 millicuries. So literature reports anywhere between 15 to 25 millisieverts. The standard teaching at our time was 22 millisieverts with 7 millisieverts from a 10 millicurie FDG dose and 15 millisieverts from the whole body CT. So what can we do, to reduce this? So these are the methods which are related to PET to reduce. So you can optimize the injected dose of FDG. The dose required is 150 to 220 microcuries per kilogram according to both European and US guidelines. So you calculate the exact dose and don't give a random 10 millicurie dose to every patient. You calculate it. Second, you ask them to stay hydrated during the scan and void frequently so that excreted activity will get out of the body fast. These days, most of us use 3D PET emission acquisition modes using time of flight information for image reconstruction. So that helps us in achieving better counts for forming an image in PET scan, right? Take home message, right? So take home message from this brief lecture is PET-CT is sometimes a one-stop shop imaging and sometimes the last resort. Sometimes it comes after a lot of imaging has been done in the radiology department, then it comes to me for a PET-CT. Sometimes we are able to provide an answer, sometimes we are not able to provide an answer. In some malignancies, like in NETs I showed you, it can be a one-stop shop imaging modality. In the evaluation of PUO also, it can be a one-stop shop modality, and there are more indications. The second take-home message is that the PET-CT addresses clinical queries in a variety of oncologic and non-oncologic indications. So give up this misconception that PET-CT matlab oncology. PET-CT is a lot of non-oncology as well. And the last message is that newer PET tracers are emerging and heavily contributing to precision medicine. Beauty of nuclear medicine, I will wind up my lecture with this, is that every month the nuclear medicine community is coming up with a new radio tracer with different biodistribution, different tracer kinetics, and different applications. So I hope all of you enjoyed this lecture and understood most of it. If there are any questions, I'll be happy to answer the same.
Questions to Dr. Damle? Very lucid, it seems, everything is. So he made it very lucid. We've been talking about the CT doses in the morning and various CT technology. He did touch upon at the end how to reduce, because the issue is we are giving isotope and we are doing CT also. So as he said, CT, of course, children or otherwise, we did discuss in morning, image gently, image wisely. So how to reduce? So all those principles are applicable here too. So you modulate your dose, you modulate your voltage of the tube, and if you need, you do contrast studies, or we don't do contrast. That's the CT part of it. So there is a lot of, and we usually don't do triple phase and all, which can be done. A lot of places it's said as one stop shop, because what patient takes 2 dates from you when he comes for your triple phase CT for abdomen, and later you plan to send at the second look, or if you are predetermined, yes, this patient would require a PET also, then you can set it as one. So that same your CT can be done on the PET CT machine and all. So save the patient the visit and a properly holistically planned study where both are done. And then of course there are a lot of application, and Dr. Damle mentioned new agents coming every day, but he summed it up very well. And of course he didn't touch mostly on theranostic, which is a very big topic on its own. Carcinoma thyroid, the age-old therapy is still iodine, and now we are seeing more and more of iodine resistant tumor. Tennis, he mentioned about the tennis. So that's where the PET is finding role, and there are more and more takers, and now the KGMC, I think in this very building basement, you have your new PET CT section. So with a center like KGMC with so many departments, so this technology would definitely grow here. And I think with that, we would like to thank Dr. Damle, and Dr. Pratik has a question. Sorry.
A very good presentation, Gagar mein Sagar, I will say. This is really heartening to see that you have highlighted non-oncologic situation where PET can be used, PET CT can be used. But tell me one thing, how many percentage you see oncologic and non-oncologic, number one query, at your hospital, at AIIMS, Delhi? And secondly, how physicians, are they so much sensitive enough now that they refer patients of, say, POV, pyrexia of unknown origin you said, as well as say some shoulder pain or something. How frequently they really refer patients for PET CT?
Okay, so to provide a real world view of the same, at my department at AIIMS, we do an average of 45 to 50 PET scans a day. 15 of them are PO. And probably I'm saying this with some bias because at AIIMS we have a dedicated DM infectious disease program also. So most of the physicians there are sensitized to the use of FDG PET scans very effectively. The figures may not be the same in private centers though, where still oncological indications would occupy around 80 to 90% of your work. But again in oncology, the kind of tracers that we are coming up with, you see, in fact Dotanok is also used in oncology only, but it's a different tracer entirely, but it's not available everywhere. So you have newer tracers which have applications in both ends of the spectra, in the benign end of the spectra also and in the malignant end of the spectra. If there are no further questions, I thank the chairpersons and conclude my lecture.
Somebody wants to ask?
Yes. Yes.
If you can just enlighten us, like, because we have just started like other guys.
Okay, so there are actually quite a few. The recent kid on the block, I would say, is something what we call as FAPI, or it's a fibroblast activation protein inhibitor. So FAPI is a tracer basically that works on the principle of targeting the tumor associated fibroblasts. Now every tumor consists of the tumor cells and the tumor stroma surrounding it, wherein lie the fibroblasts. So gallium-68 as labeled FAPI PET scans are the hot topic right now. In our department also we are doing research on that, and it is something that can be again labeled with lutetium, and therapy also has been offered to patients based on the results of the FAPI PET. Other than that, for infection imaging we are doing a scan which is called as a NOTA ubiquicidin scan. This ubiquicidin is a bacterial / fungal cell membrane targeting cationic compound, and it has revealed good results in bacterial and fungal infections. The third one which we used to do, but subsequently our cyclotron went down, so we are not doing it right now, but we have worked heavily on tau PET scans, for in neurology for Alzheimer's disease and all. Other than that, we have off and on, worked with some other compounds like the CXCR4 or Pentixa4 PET scans, which are sometimes used in hematolymphoid malignancies, and something called as the RGD PET scans also. And I think other than that, in SGPG, I think they have also used copper 64 sometimes, so maybe Professor Gambhir can share his views on that. So there are quite a lot of compounds that we are using now in India also. Yeah.
Thank you, Dr. Damle, for this excellent talk. So I think it will give food for thought to the team here, radiology and nuclear medicine groups, because KGMU, I believe, is uniquely placed to tap these technologies and make your own algorithm. You have a lot of infections here, resistant infections or infections. You are talking of non-malignancies. Malignancies are of course there, but here you would have fungal, so many things. So that is one group where you can really, if you go with the standard thought in mind, then where you are still struggling, then you can evolve your own algorithm with even routine agents like FDG and FAPI is now becoming easily available. We also do it. We are finding it excellent in various application, non-oncological. So we are exploring more FAPI for non-oncological. Most of the people are doing for oncological. So it does better than FDG, in where FDG is leaving you in tight situation, not giving you answer. The FAPI is coming to your help in autoimmune disease, follow-up of autoimmune disease, new immunotherapies you are giving, response to new therapies, where your mass size will not go down. So if you are doing your standard PET CT or MRI, the tumor mass would be same. So the therapy is costly, toxic. So after 2-3 cycles, the physician really wants to know, should I go ahead with the therapy? Is it working or not? Now that has become a very big area, huge area. So there the functional imaging is little bit ahead as of data which is available right now. You can do with FAPI, you can do with FTG, and it gives you that the tumor is still functional. Or the mass is there and tumor is become silent, it's no longer. So it's been effective. Otherwise you will keep on doing. So spending, and in such big hospital, the time, the appointment is a huge queue. So if you focus on how to shorten your queue, which two techniques to combine to shorten your appointment list. So your thought process has to be targeted, and you can weave in a lot of these techniques to the help of the patient. Thank you.
Thank you, sir.
Nishikant.
Thank you, sir. Before proceeding with the next speaker, I would request Professor Avinash Agarwal, sir, Professor and Head, Department of Critical Care Medicine, KGMU, Lucknow, to come upon the stage and take his seat as the chairperson for this session.
I now invite Dr. Rohit Agarwal to come on stage. Dr. Rohit Agarwal is an alumnus of KGMC. And I tell you, he has a heart of gold. I recall, we were about to face an inspection for recognition of the degree, and we were short of one assistant professor. And we requested him that why don't you join for a short while. And he did, although he was really selling like a hot cake outside of KGMU, but he joined us, bailed us out, and today the degree is recognized because of Dr. Rohit Agarwal. So I always remember it, Rohit. So now coming to his current status. He is an Associate Director of Radiology and Imaging in Medanta. He is an interventional radiologist with a big experience. You just ask him and he will do it, vascular, non-vascular, stroke management, image-guided biopsies, ablation of cancers, chemoembolization, neurovascular interventions, carotid artery stenting. He has an additional interest in emergency bleed of GI bleed, arterial, variceal bleed, where endoscopic treatment fails, hemopsis, bronchial artery embolization, and bleeds post-road traffic accidents. So he is absolutely brilliant. Today, however, he shall be talking to us about contrast reaction management and physiology of the contrast media. So it's over to you, Rohit. Welcome.
Thank you, ma'am, for such a kind introduction. I don't think I deserve that, but thank you so much. And I'll be talking about contrast reactions and management. Can I have my slide on screen? Thank you. So this is something like, as a radiologist, all of us should know what are contrast, what is the reactions, and what is the management. So in an ideal world, I would like my contrast to be like distilled water, non-toxic, can be consumed, and as much as you consume, it is better for your health. But the world is not so ideal, so is our contrast. But still, we would like to, compromise on some risk which probably are necessary when we manufacture these contrast. And in ideally, the contrast agent should be injected and eliminated from the body without any additional effects on the patients, like all other pharmaceuticals. However, these agents are not completely devoid of risk. Preparation of prompt treatment of contrast media reactions must include preparation of the entire spectrum of potential adverse events, and including the pre-arranged response planning with availability of appropriately trained personnels, equipments, and medications. So, do we need to give contrast to each and every patient which we are facing? No. We need to when we are doing any procedure for that matter, we need to see what are the risks, what is the benefit, and the benefit should definitely outweigh the risk. And if there is any other potential imaging alternative that would provide the same or better diagnostic information, for example, MRI having a better temporal resolution, we need to have a confirmed valid clinical indication before giving these agents. The consent is very important. We need to probably mention some of these reactions inside a consent form. We need to communicate with the patients who are undergoing these procedures, and screening for the predisposing factors leading to adverse reactions. For example, history is very, very important. History of previous contrast reaction, history of allergy to sulfur drugs, or a seafood allergy. Iodinated contrast agents can be broadly classified based on their osmolarities, ionicities, and number of benzene rings. When we talk about osmolarity, they can be high, low, or isoosmolar. Based on the ionicities, they can be ionic or non-ionic. Based on the number of benzene rings, they can be monomer or dimers. And when we take the history, we must, try to take this history very, very carefully, like any history of previous contrast reaction, any history of severe allergies and reaction to sulfur drugs, generally seafood allergy, history of asthma, bronchospasm, or atopy, history of cardiac or renal diseases. And we must be very careful when we are giving these contrast in patients aged more than 60 years, as these are the patients which are at very, very high risk for contrast induced or contrast associated acute kidney injuries, and in young children, toddler age groups, like the one which are less than 5 years of age, where the volume of contrast media is very important. When we come to the etiology of the contrast reactions, basically these are the few things which are responsible for different type of contrast reaction. First is physical properties of the contrast media, then comes the iodine concentration of the contrast media, total dose or volume of the contrast being used, and rate of speed of injection. In physical properties, we need to know whether the contrast media is ionic, non-ionic, what is the number and size of the iodine molecules used, and number and size of the molecules of any chemical additive which is being used in these contrast media. When we talk about ionic contrast media, for every 3 iodine molecules, there is 1 cation and 1 anion, and the ratio is 3:2. The problem with ions is that ion can disrupt the electrical charges associated with the brain as well as heart, and may lead to a lot of physiological reactions. In non-ionic contrast media, the ratio can be 3:2 or 6:2. When we talk about iodinated contrast media, here basically what happens is the compound, the iodinated contrast media, is generally combined with sodium or meglumine to form a contrast media. The ionic monomers, examples are urographene, gastrographene, angiographin. These are the ones which are generally used for our oral studies, and now we don't use them as IV molecules or intraarterial injections, but probably in the earlier years they were being used as an intravenous agents as well. When we talk about ionic dimers, herein there is 2 benzene rings which are combined, and for every 6 molecules of iodine there is 1 cation and 1 anion. The non-ionic ones are monomers and dimers. The non-ionic monomer is Omnipac iohexol, which is very commonly used in almost all the departments of radiology, and non-ionic dimer is Visipac. This is the least toxic one, iodexanol, which is generally used in patients with renal compromised, having some renal compromise. It has been noted that higher the iodine concentration, the more is the likelihood of an adverse reaction, and these are generally associated with the allergic reactions. The volume of contrast media injected, the amount of volume which we need to inject for a different study, will depend on the iodine concentration of the contrast media. As we increase the iodine concentration, the radiopacity of the contrast media increases, and the amount of contrast, the volume of contrast media to be required for a investigation will be less. The type of contrast media, ionic or non-ionic, the body weight of the patient, and anatomical structures or regions to be imaged. For example, when we talk about CCT head, the volume may be around 40 ml, but when we talk about the angiography, we would need a good 80 ml or 100 ml of volume of contrast to be used. The rate of injection of contrast media and age of the patient. When we increase the injected volume, the possibility of adverse reactions also increases. When we talk about rate of injection, it is important because contrast medias are generally viscous. So in angiographies, we normally see, even in our CT scan room, that there is this angiographic injector, and there is this warmer attached with this angiographic injector. What happens is, as we bring these contrast media to the room temperature or the body temperature, the viscosity of these contrast media would reduce, and there is less likelihood and there will be less likelihood of extravasation of the contrast from the local site. Now coming to contrast media related reactions. Contrast media related reactions can be briefly classified into acute contrast reactions, delayed reactions, and contrast induced nephropathy. When we talk about acute contrast reactions, they can be mild, moderate, or severe, and also there are 2 types of acute reactions. One is allergic type or anaphylactoid type, and the other are physiological ones. The management of these reactions are different, and it is important to recognize what type of reaction is the patient having. Patient who is experiencing allergic-like reactions may require future pre-medications prior to usage of iodinated contrast media, while patient who experience physiological reactions would not require any pre-medication for future study. So when we talk about allergic type reactions, these typically occurs within 1 hour, and they are generally unpredictable, but are clinically most important and involves the release of histamine and other biological mediators. When we talk about the physiological reactions are related to the specific molecular attributes of these compounds that leads to direct chemotoxicity, osmotoxicity, molecular binding to certain activators, and physiological reactions are frequently dose and concentration dependent. For example, maybe with a 10 ml contrast, patient might have an anaphylactoid reaction, but for a physiological reaction, he needs to have at least 100 ml, 120 ml of contrast. So these are very much volume dependent. Hence, they can be reduced by using low osmolar contrast media instead of high osmolar contrast media and volume. So when we talk about the degree and severity of these reactions, they can be the physiological reactions can be mild, moderate, and severe. The mild physiological, sorry for these, I am not carrying my laptop here, and these were generally the highlighted points. These are not cut. So when we talk about the mild physiological reactions, they constitutes of flushing, warmth, chills, sneezing, rhinorrhea, nasal congestion. In cardiovascular, they might present as mild hypertension, mild nausea, vomiting. When we talk about central nervous system presentation of physiological reaction, patient might complain of some anxiety, syncope, vasovagal reaction, dizziness, or headache. For mild reactions, generally no treatment is needed, only observation is needed. When we talk about moderate events, the patient might complain of chest pain, some ECG changes and hypertensive urgencies along with nausea, vomiting, vasovagal reaction requiring treatment. The severe is hypertensive crisis along with arrhythmias and ECG changes, and the most serious ones being unresponsiveness and unconsciousness of the patient. When we talk about these anaphylactic reactions of the patients, they constitute about, they range from limited urticaria to severe laryngoedema, facial spasm, along with laryngeal spasm leading to urgent intubation. The good point is the frequency of these acute adverse events is very, very low. For example, for low osmolar contrast agents, the frequency of acute adverse events ranges from 0.2% to 0.7%, and for severe acute reactions, it ranges to 0.04%. Fatal reactions are very, very rare with an incidence of 1 in 1,70,000 injections. For all the anaphylactoid reactions or allergic type reactions, the pre-medications is necessary. So there are two protocols of pre-medication. One is 12 or 13 hour oral pre-medications in a patient which are on outpatient basis or an emergency patient where the delaying of the investigation will not cause any harm to the patient. And the other is accelerated IV pre-medication. Accelerated IV pre-medication is indicated in patient where delaying an investigation might harm the patient. So everything boils down to risk versus benefit ratio. When we talk about the oral pre-medication, then it is either prednisone based or methylprednisolone based. When we talk about prednisone, we can give 50 mg of prednisone by mouth at 13 hours, 7 hours and 1 hour before the contrast medium and administration, plus 50 mg diphenhydramine intravenously or IM or by orally 1 hour before the contrast medium administration. For with methylprednisolone, the dose is quite simple. We need to give it 32 mg 12 hours before the procedure and another dose of 32 mg 2 hours before the procedure, and diphenhydramine remains the same. Like we need to administer 50 mg of diphenhydramine 1 hour before the procedure. For IV pre-medication, it is IV injections of steroid plus antihistaminic, that is diphenhydramine. It is very well mentioned in almost all the textbooks, the dosage, and like at our place we have this screenshot which is being pasted in all the CT scan machines and the fluoro rooms. For accelerated IV medication, we give methylprednisolone, Solumedrol, 40 mg IV, and it is generally repeated every 4 hours till the procedure is being done, and diphenhydramine is given 1 hour before the procedure, 50 mg. We can also use dexamethasone, 7.5 mg IV, and it is also repeated 4 to 5 hours after the first dose till the procedure is completed, plus diphenhydramine 50 mg IV 1 hour before the contrast media injection. Other than that, we can also use but again there are few reactions which will happen even after these pre-medications, and these are known as breakthrough reactions. And for these pre-medication strategies do not work, and we should be probably know them that okay, even if we have given these pre-medication and the patient is showing some signs of anaphylactic reactions, then call for help should not be delayed, and if we have any kind of code blue or any kind of code from which we can probably accelerate the series, and we can call for some doctors or anesthetists or critical care people who can help us out, is always beneficial. So how do we evaluate these patients? One thing which is necessary is for all the patient undergoing iodinated contrast media injection, the IV excess should not be taken out just after the procedure. He should stay in the hospital premises for at least 1 hour, and the IV excess should be maintained for all these patients. We need to evaluate the patient, how the patient is looking. Can the patient speak? Is there any signs of laryngeal edema, such as the change in patient's voice? Is the patient breathing? What is the pulse strength? What is the rate? And what is the patient's blood pressure? and we need to have this ABCD of critical care in place. We need to look at the airway, breathing, circulation, and while the other person should start calling for help. Disability and exposure. For mild contrast reactions, mild acute reactions, generally these patients does not require any treatment, only observing these patients for 20-30 minutes or 1 hour is sufficient. Or best of all, what we can do is we can inject Benadryl, that is diphenhydramine orally, or Allegra, fexofenadine orally, and most of the times it will work. And for moderate acute reactions, we have hives, urticaria, diffuse erythema, bronchospasm, facial and laryngeal edemas. So when we talk about these reactions, the treatment is simple. We need to administer antihistaminics, that is diphenhydramine, and if there is severe reaction, then we need to give epinephrine. The dose of epinephrine is IV 1 ml of 0.1 milligram per ml, or we can have a preloaded injections of epinephrine, which comes in the name of EpiPen, which has 0.3 ml of 1 milligram per ml. And when we talk about bronchospasm and facial edema, laryngeal edema, in both these cases the IV access should be maintained. Oxygen should be delivered by bag and mask ventilation. Pulse oximeter and vital should be monitored. And call for help is necessary, as these patients might land into severe anaphylactic reactions. When we talk about hypotension, then the most important point is to know whether the hypertension is with tachycardia or with bradycardia. As if it is with the tachycardia, then it is an anaphylactic reaction and we need to administer epinephrine. However, if the hypertension is with bradycardia, then atropine is the drug which we need to administer. When we talk about hypertensive crisis is again a physiological type of reaction. We need to give labetalol, IV labetalol, and it can be repeated. A total, for example, a 40 milligram 10 minutes later can be administered, then 80 milligram 10 minutes after that, if the BP is not coming to normal. When we talk about pulmonary edema, then again IV access is must. The management, the top 3-4 points are similar for all these complications, right? But for pulmonary edema, we need to elevate the bed and give the diuretics, Lasix 20 to 40 milligram administered slowly, 20 to 40 milligram administered slowly over 2 minutes, and call for help. For seizures, it is lorazepam, but for all these things, the best is to have these primary things in place, that is IV access, vital monitoring, O2, and call for help. When we talk about these delayed reactions, mostly the delayed reactions are not of that concern, but educating the patient is very, very important, that they can have these reactions up till 1 week after the contrast administration, and in case of severe delayed reaction, they need to visit the hospital or show the local acute polyarthropathy. Contrast-induced nephropathy, so the term which is associated is now contrast-associated acute kidney injury, and within contrast-associated acute kidney injury comes the contrast-induced acute kidney injury. The definition is, if there is absolute serum creatinine increase in 0.3 milligram per deciliter, or a percentage increase in serum creatinine of more than 50%, or decrease in urine output to less than 0.5 ml per kg per hour for at least 6 hours. The physiology is important when we talk about this contrast-induced nephropathy, because almost all the iodinated contrast media are mainly excreted by the kidney. Therefore, kidney function test is very, very important, and what has been shown is, like if there is eGFR of more than 30 ml per minute per body square foot area ratio, then the risk of contrast-induced nephropathy is very, very low. However, in cases where this finding is below 30 ml, the risk of contrast-induced acute kidney injury is high, and we should not just, especially in old age, we should not simply rely on the serum creatinine. If we can take a little more pain and see what's the eGFR, then that can be very, very helpful for the patients. I'll just skip all this. The clinical picture is, in serum creatinine usually begins to rise within 24 hours of the intravascular iodinated contrast medium administration and peaks within 4 days and often returns to baseline within 7 to 10 days. So what are the risk reduction strategies? So mainly it is hydration. If we can, if there's a patient who is at high risk of contrast-induced nephropathy, then we can hydrate the patient starting 1 hour prior to the exam for next 3 to 12 hours. Typically with normal saline, 0.9% is preferred. Oral pharmacological agents have not shown any benefit in helping to resolve these contrast-induced nephropathy. To name a few, they are sodium bicarbonate, N-acetylcysteine, diuretics, theophylline, nandrolone, phenol-dopam, but they have not shown any strong supporting data till now. NSF is typically seen with gadolinium chelates. These are seen in end-stage renal disease patients or severe acute kidney injury patients. It usually occurs months after the administration of GBCA, and average time being 2 to 10 weeks, and it can be life-threatening. It starts from the skin and can involve the systemic visceral organs as well. Thank you.
Thank you very much, Dr. Rohit. Wonderful presentation by Dr. Rohit Agarwal. Any questions from the audience? There are no questions. Thank you very much, Rohit, for your presentation.
Thank you so much, sir. There is a small announcement. Outside, the poster judging competition is being held. The judges are there. The presenters are requested to please go to the poster presentation site. And in the meanwhile, we come to conclusion of this awesome session, wherein we had insights into PET-CT as well as the contrast media reaction. And I would now like to call upon all the chairpersons in the center of the stage in order to felicitate the speakers. I would request Professor Neera Kohli ma'am, Professor S. Gambhir sir, and Professor Avinash Agarwal sir to please come upon.
I request Professor Nishikant sir to please come up on the stage. Please welcome him with a huge round of applause. Now I would like to invite Dr. Rohit Agarwal sir to please come up on the stage, and please everyone welcome him with a huge round of applause.
I would request the chairpersons to please stay for a while. We would also like to take the moment to thank the chairpersons for their invaluable contribution, for steering these discussions and ensuring the smooth flow of this session. And to honor that, I would like to request upon Professor Anit Parihar sir, Head of Department of Radiodiagnosis, to please come upon the stage to felicitate Professor Neera Kohli ma'am. Please give a huge round of applause. I would also like to call upon Dr. Durgeshma Dwivedi sir to please come upon the stage to felicitate Professor S. Gambhir sir. Please give a huge round of applause.
Now I would request Professor Anit Parihar sir to please felicitate Professor Avinash Agarwal sir. Please give a huge round of applause.
Thank you so much sir, thank you so much ma'am. So the poster viewing session is being organized right now outside the auditorium. Those who are interested can take a moment and go for that. Meanwhile, in the auditorium, we will be organizing the paramedical quiz competition, which is much awaited, and we will be announcing the rules for this quiz. Please listen carefully. So the rules are as follows. What we will have is a QR code will be displayed on the screen, and all the participants have to scan that QR code. So a QR code, could we please have that QR code on the screen, please? उनको बुला सकते बुला सकते So we'll just take a moment while the participants of poster are also coming back to the auditorium. All the paramedical students are requested to take their respective seats. So this first round of quiz will be for all the CT scan students. The CT paramedical students, this first round is for them, and the time limit is 10 minutes. So a QR code is being displayed on the screen, and all the participants are requested to scan this QR code and be directed to the Google form. There will be 2 rounds. First round is for all the CT paramedical students, and the second is for the MRI paramedical students. So this code that is being displayed is for all the CT ones. This will be, this round will be, the duration will be approximately 10 minutes. So you have 10 minutes, and the number of questions are 15. So you have to answer 15 questions in the next 10 minutes, and you don't need, you have to be quick, because not only the number of correct questions are being considered, the time taken for the response generation is also being considered. So in case of a tie, the person who is submitting the response earlier will be declared the winner. At the end of 10 minutes, this Google form will be automatically submitted, and there will be no negative marking for any wrong answer. So there is no negative marking, and do not use any unfair means.
As we continue our journey through this enlightening quiz, please join us in welcoming our respected Dr. Saurabh Kumar sir, who will be leading us through this exciting quiz session.
Thank you, Sakib and Ananya. I think both of you did my work. And so let's begin with this exciting session of this CME. So all ready? If everyone is all ready, should we start?
कहाँ से करना है? Already loaded है? हमें बस click करना है, the question will come ना? कहाँ question कुछ कहाँ है?
So the quiz is over now, and I hope you all enjoyed it. The questions were probably not very tough, and it's were in the that curriculum part only. So now we are going to start the second round for the MRI technicians group. And so we will display the QR code here, and all the MRI students will have to scan the QR code, and the total allotted time would be of 10 minutes, and so please don't take too much of time, otherwise your form will be automatically being considered as selected. So please do scan the QR code. QR code display करो. आ गया? thank you so much for participating in the quiz session. So, but the quiz session has not ended. But and the results and the prize distribution result will be declared tomorrow with the exciting prize distribution. Hope let's see tomorrow who was the winner. Until then, you guys could have a coffee and tea all waiting outside. So thank you for participating in the quiz.
Thank you so much, sir. So the poster viewing session is being conducted outside the auditorium. We'll be waiting for the poster presentation to complete, then we'll be proceeding with the hands-on.
हटवा देना है।
ये भी सर?
हाँ ये
ये भी?
ये रहने दो ना, ये हटवा देना।
back everyone. We are excited to announce a hands-on session that promises to elevate your radiology skills to new heights. Get ready to roll up your sleeves and dive into the captivating world of diagnostic imaging like never before. It is with great honor that we extend a heartfelt invitation to our esteemed chairpersons to join us on stage. Professor Manoj Kumar Sir, Professor, Department of Radiodiagnosis, KGMU, Lucknow. Please welcome him with a huge round of applause. Dr. Nitin Arun Dikshit Sir, Assistant Professor, Department of Radiodiagnosis, KGMU, Lucknow. Mr. Chandrapal Singh, Senior X-ray Technician, Department of Radiodiagnosis, KGMU, Lucknow. Mr. Vinod Singh, Technical Officer, Department of Radiodiagnosis, KGMU, Lucknow. Dr. Siddharth Mishra Sir, Assistant Professor, Department of Radiodiagnosis, KGMU. Mr. Vivek Kumar Rai, Senior Technologist, Department of Radiodiagnosis, KGMU. Before proceeding with our hands-on session, we have amongst us representatives from we have a small announcement. Please don't bring glasses inside the hall. Now, before proceeding into our hands-on session, we have amongst us representatives from Philips Healthcare. First, we have Mr. Mohammad Adnan, who will be giving a short presentation about CT coronary angiography. Please welcome him with a huge round of applause.
Close all this. All right, take on, sir. Close नहीं हो रहा है.
there's a slight change in program. First, we have Mr. Prashant to speak a few words about spectral CT.
Yeah, hi. Good afternoon, everyone, and thank you for giving us an opportunity to showcase our one of the premium model that we have is the spectral CT. So it's a 5/12 slices CT scanner. As the word says, it's an every patient for every scan. So basically, the motto of this product is that whatever scanning you do, it is going to give you both the results. It is going to give you the conventional as well as the spectral results. This is the only CT which is available within the industry which gives you both conventional and dual result at the same time, simultaneously without any dose penalty. So we are going to cover up on entire things. Let me just show you the next page. The reason why do spectral has sort of advantages over a conventional CT. Like first is basically it's help you out to do, get the characterizing incidental findings, which are very much possible that you can miss it on the conventional CT. At the same time, what it's going to help you out is it's help you out to get a more lesion detection, sizing, and the characterization of a material, which you cannot do it on the conventional CT, right? And at the same time, missed delays and diagnosis contribute to patient deaths. There are researches which happens that claims that there are many instances which happen that because of the wrong diagnosis, the patient comes after a 3-month or a 6-month, and at that time the patient is already been on a very dangerous stage. So I think our motto is to give you a result where you don't misinterpret, you will get the right diagnosis at the first place. So that's the thing which we want to do it with the spectral CT. Then even the patient who comes with the GFR less than 30, the patient with the renal problems will definitely going to have a problem when you give them a contrast. So with the spectral CT, what we do that within the limit, 20 ml or 10 ml of contrast, you can scan a patient. In a very minimal dose, a dose of a contrast, you can scan the patient. Poor CTAs, it's not intentionally, but sometimes it's happened that the patient come, you scan it with some contrast, and the optimal dose which is required is not given to the patient. In that scenario, what happened that the result which should be come up to your workstation, or the result should come up to your workstation, are not so optimal. So in that scenario, we have certain parameters where you can tweak the images, you can improve the opacity of a contrast, and you can view the images very clearly. And at the same time, the limited low contrast resolution, I was checking up the presentation in the morning where doctor was talking about the LCR parameters. Definitely, the spectral CT gives you more and better clarity. And that too, it's improved on LCR parameters. And image artifacts. Yes, there are algorithms which are available with the conventional CT, but with the spectral, we gives you a result which you cannot match with any other CT. So spectral gives you a much more better clarity, that too in a very low dose. So I will just want to introduce my product to you with its spectral CT 7500. It is our premium model which comes with this rotation speed of 0.27 second. It means you can do all your abdomens, cardiac scanning with the temporal resolution of 135 millisecond. It's so fast. And then we have a coverage of around 8 centimeter, which is good enough to do your cap imaging within 2 seconds. And head scan and trauma, and for traumatic patients, it's a wonderful system. Then new tables, we have, we earlier used to have a model called Icon, which was a base model, and now we have come up with the CT 750. So what we have changed, we have come up with a table which is very fast. It can go up to a speed of 600 mm per second, which that is why we are saying that you can do a cap imaging within 2 seconds. 80 centimeter bore, so whether it's a pediatric patient, adult patient, or a bariatric patient, you can scan it without having any challenges. It's also help you out with the AI technology which is inbuilt in the system. We do cardiac analysis with the help of our cardiac AI tool, which is inbuilt part of our system. And then we have an eye patient, which basically means throughout the Philips portfolio we have kept a very common platform, which is eye patient, which generally helps the technician to have a common platform, whether it's CT, MR, whatever modality it is. So it's more convenient and more easy for technologists, radiographer to learn the things, right? It's more convenient in our case. 100 kV spectral protocol, so I'm not talking about the kV, normal kV, it's not a normal kV like a conventional. Here we are talking about the 100 kV spectral. Spectral means for a pediatric we have come up with a different protocol which is 100 kV. That will ensure that your pediatric patient will going to have a less dose. And at the same time it's a 120 kilowatt system. Regardless whatever patient size will come, you can scan it with the ease, and that too with the good image quality. So one thing I just want to put up in this in forum, that we have a retrospective spectral result. So I know today in the morning session doctors were talking about spectral CT and its advantage. Yes, there are advantages, but there are certain limitations as well. Like for example, there are technologies like KV switching and the dual source CT which are available in the market, but the challenges is that the technologist or the radiographer need to decide it in the front whether he want to go with the conventional imaging or he want to go with the dual source or the dual energy result or a spectral result. But in case of Philips, we do every scan with the spectral and conventional both. So your technologist no need to decide anything. Whatever result, whatever case he will do, he gonna have both the result, conventional as well as the spectral. So this is the beauty of our product. Then there is one more perception that on the workstation, like we have a console and then we give a workstation to all the institute. Then apart from that, there are now you are seeing that the more of the cases are happening on the PECs. Doctor radiologists prefer to have images on wrist and PECs. So our system definitely help you out to view the images on the PECs, and it is compatible with all the PECs vendors throughout. This you are not going to find out in any competition. They're going to have a challenges throwing their data, dual energy data, which is basically, it's a big data which comes up with the dual energy. So you cannot be able to do it, you will not be able to process it on the PECs. But in case of Philips, you don't have any such issues. Detector based spectral, like the one which we are talking KV and the dual source CT, these are all the tube based dual energy results. Whereas in Philips, like a photon counting, we also have a detector based spectral results. So it gives you more ease, and at the same time it gives you better result than any other technology which is available right now. Fast table I already cover up, that we can do a cap imaging within 2 seconds, which itself claim that the table which we have, it's too fast. Then workflow boost, we have so many features. It's very easy and convenient for a radiographer to use a machine, because instead we have done so many research where it's an improvisation in the console, that within the few strokes you can you complete your entire examination. So this is how we have bring up more innovations in the system. Spectral cardiac, it's help you out to remove the mid-RC artifacts which generally happen. Everybody knows that's the most challenging part of a cardiac CT. So we have a spectral cardiac which is based out of artificial intelligence that's help you out to give a good cardiac imaging, that to the mid-RC. And spectral, we can do a spectral imaging with 100 kV, 120 and the 140 kV. So almost we have 110 of installation. Peer publication also we have 115, and then research, if I say research paper, we have 25 papers which itself claim that this technology is not new. It's been established from last many years, and that too, if you see within this presentation, you can identify that in India also you are seeing a sport, right? It basically in AIIMS New Delhi, we have installed our Icon City, which is based out of spectral technology last year. So they are doing pretty good job. Dr. Pratik is also here, he knows. So it's doing a pretty good job on the spectral city. It is one of the best system which is installed within the institute. Then 8 billion patients are already scanned on the system, and 300 plus number of clinical publications are there, which include both our previous generation system Icon City and the new one which we are showing it to you right now. So little bit of physics. X-ray spectrums perform actually as per the KV. It has different numbers of photons which are coming up. Like for example, if we talk about a 80 kVp, the number of X-ray produced will be different, and in case of 140 kVp, the X-ray produced will be different. So basically, this is why we can say that this basically makes a little combination of different results. Conventional CT is basically, if we talk about a reporting, then what happens that majorly what happens that everything, either we claim it that it's a dense or a less dense than a water. So why we say that? Because denser means that it's a positive CT and less dense means it's a negative CT. So majorly what we place, it's around the water. So whatever we say in the conventional CT, it is by a single material and it is based out of water only. So more than water, it will be claimed as a denser, positive part. But in spectral, what we can do, we can give you a quantification with the color coding. So it's going to help you out to quantify the materials properly, and we have certain software called Z Effector. I think some of the doctors in the morning, they have shown some images also. So it's help you out to do a material characterization more properly than a conventional CT, which basically deals in gray and white, right? These are the two main parameters, which is photoelectric and the quantum scanning. I will not talk much about it because it's already been covered in the morning, but just want to convey you one more thing. The photoelectric and quantum scattering, it's happened in almost in all the CT scanners, but in conventional CT what happens, that the conventional CT gives you a result of both the photoelectric and the quantum together. So you're not able to differentiate the different energy levels. Whereas in case of Philips, in spectral CT, we gives you a lower energy result separately and the higher energy result separately. So you can utilize both these effects prominently and you will get a good image quality. So photoelectric effect dominates generally in the higher atomic numbers, and quantum scatters generally dominate on the lower atomic numbers. So for example, water will, in that scenario, the quantum scatters will be more, and in case of iodine, the quantum scatters will be less and the photoelectric will be more. So these generally performs differently as per the material density, and that is why we use it to identify the material, and we generally characterize it as the basis of the result we get. 3 technology, which we are talking since morning, not me, all the doctors are talking since morning about this dual energy, which is dual layer, dual detector is basically Philips patented technology, which we claim that it's always spectral. Then KVB switching is a GE Revolution product they have, and then dual source CT is Siemens. These are the different technology which are established, well established in market, and they are continuing with numbers of installation. So while detection-based technique achieve it in one scan, spectral can also do a result like we don't need to scan a patient twice. The whole scenario of this presentation is to give you, for this particular slide is, that we do not need to scan a patient twice in the Philips. We can do it with the help of a single scanning. So it will going to give a less dose to the patient. At the same time, it is going to give you a better result. So it's a detector-based spectral solution where you can simultaneously capture a high and a low energy. KVP switching is basically you switch between two KVP, which is higher KVP and lower KVP, which varies from 80 KVP to 140 KVP. And then dual source basically have a temporal offset of 90 degree where the 2 tubes and detectors are placed on 90 degree offset. So generally, these are the 3 technologies which are predominantly working on the dual energies results. So with us, actually the main criteria, I will say the benefits are the FOV utilization. So we don't have any limitation of FOV. You can scan up to 50 centimeter, both on conventional and the dual energy results. So you don't need to compromise. I knew there are technology in the market where the FOV refrains up to 33 centimeter. But in case of Philips, you don't need to worry about it. You're going to have a 50 centimeter FOV. Temporal offset, as because our detectors are not aligned into 90 degree offset, so you don't need to worry about temporal offset. We are acquiring images simultaneously at the same time space. So it's going to give you an accurate result every time. Temporal resolution also defined, like we can do a cardiac spectral as well. A conventional cardiac, everybody is doing it. But in case of Philips, we can also do a temporal resolution. We provide a temporal resolution in spectral as well. So we don't compromise on the rotation speed. In case of Philips, you are going to get a 0.27 second rotation. Unlike KV switching, where the rotation speed becomes 0.5 second. So you cannot do a cardiac on such scanning. So dose efficiency also improves up. I mean, you don't need to scan a patient twice. This is basically the science behind this spectral CT. We generally give a yttrium detector based low energy detector on the upper layer. The upper layer absorbs only the lower energies, which is basically lower KEV energies. And the gauge, which is basically being defined for the higher energy detector, can only absorb the higher energy levels. So basically they have different alignment, and even if you look at this detector technology, right, we have aligned it in that way that the photodiode, generally if you see in the conventional CT, the photodiodes comes after your scintillators. But in case of Philips, we have photodiode just in the right side. So if you see yttrium based, whenever the photons will come, it will go to the photodiode simultaneously, and in GAUSS also it will go simultaneously to the photodiodes. So here you can see it, that if the lower energy comes, the yttrium will absorb it and go to the photodiode, and GAUSS, in case of GAUSS also, it will go directly to the photodiodes. So you are going to get a simultaneous result at the same time. These are the different parameters which we have in the spectral CT. So I will covering up in the next slide. So we have a mono E. Mono E basically helps you out to give you a attenuation, as in single monochromatic energy is being used. For example, it is work like a conventional CT sort of thing. So you can change your kVp as per your requirement. Like for example, you have done a case on 120 kVp and you want to see the result, that what will happen if I scan that patient on the lower KEVP. So basically you can change it and you can slide it down as per your requirement, and you can remove it. A lower KEV will going to help you out in boosting up the iodine uptake. Whereas in case of you go on the higher KEVP, it's going to remove the artifact from the images. Virtual non-contrast means you do a case with the contrast, and if you want to remove the contrast iodine from the images, you can do it with the help of the virtual non-contrast. You can get a good conventional imaging without any contrast. Then iodine no water means that it's going to enhance the iodine contrast, and also it improves the calcium, also will going to improve it, and it's going to be, look more brighter in case of iodine no water. Iodine density, it's going to help you out to remove a calcium from the images, so you are going to get only the iodine and the normal images, so where you can visualize and identify the uptake of iodine. So it's going to help you out when you do a tumor assessment. And at the same time, we give a Z-factor. Z-factor works on atomic numbers. So based on the atomic numbers of a material, it's generally give a color coding. So calcium is going to have a different color coding. Your water will going to have a different color coding. So based on that, we give a Z-effective images. Calcium suppression is also possible now. So what basically do with the calcium suppression, if you use this technology, you're going to suppress the calcium attenuation from the images. So you are going to get only the HUs which are without a calcium HU value. So it's going to remove all the calcium from the images. Electron density gives you a number of electrons within the voxel, and it is generally helps a lot in nuclear medicine. So here you can see, I just want to show you one images with the help of spectral. You can see most of the time it happened that because of the beam artifact, we pretend that it is a beam artifact, right? Instead of presuming it that it's a perfusion deficit. So this has happened but if you have a spectral CT, you can you will have a better diagnosis. You can claim it that it's not basically a beam artifact, beam hardening artifact. It's basically a spectral. It's a perfusion deficit. So it makes your invisible images more visible. One more cases where you can see a pancreatic tail where there was a tumor. On the left side, if you see, the images seems very, gray. You will not be able to identify. It's need expert eyes to see such minute details. But if you have a spectral CT, you will be able to identify it very correctly and with an assessment of iodine density, you can also measure the iodine volume. At the same time, you can identify it clearly that it's a tumor. Even there was a research which happened which says that the sensitivity of cancer detection goes from 77% to 89% if you use a spectral CT. I just want to show you one more case which is very good. I mean, if you look at these images, you will find out there is no lesion in this. And what happened then after a 3 month, the same patient scanned for the same problem. And here you can see I have highlighted it that there is a lesion which is predominantly visible now. So what will happen if you have a spectral CT 3 months back? You will be able to do it a monoenergetic change, and then you will be able to increase the iodine uptake, and you will be able to identify it then and there that there is a lesion, and you can diagnose it pretty well. So there was no chance of missing up the lesions in such scenarios. One more case from bone marrow edema. With the help of spectral CT, you can remove the calcium from the images. And if I compare it with the MR, which is a gold standard for edema, it generally says the same thing. So we can correlate. You don't need to send your patient, again and again to other modalities, and you can, get a good, defined images and concrete results with the spectral CT. This is also precise cardiac help you out, like what I said earlier, that it's help you out to remove the mid-RC artifacts. So if you have a spectral CT with a precise cardiac, you're going to have a good image quality. So one more research I want to show you, that it's low noise virtual monoenergetic images. If you see, there are 3 technologies. One is basically our dual layer detector, which is the first column. If you see, it's a dual layer detector. Then we have DBST means a detector based single source CT. Then we have a KVCT, then we have a dual source CT. So if you see, the number of the noise level in detector based CT is minimum as compared to KVCT and the dual source CT. So these are the research which has happened. It's not a Philips research, it is done by a third party which generally claims that the Philips is going to have a less noise. And even once you have a less noise, it's basically means that you're going to have a better CNR as well. So if you see the first images, it's a detector based CT. At the 40 kV also we have a better CNR as compared to both the results which are there. I mean DSCT, which is a dual source CT, and the KVCT. So these are the results at 10 milligray, 20 milligray, 30 milligray. You can see that the results what we have, you're going to have a better iodine perfusion as well. So, and why we are doing it? Because we are acquiring images simultaneously at the same time space. So we don't have any lag, we don't have any temporal lag. Whatever result is coming up, you're going to have a crisp and clear images. And that is why we say that we have anti-correlated images which generally remove all the noise from the images, and you're going to have a better image quality. So covering up, CT 7500 versus a dual source. So what we have, we can do a dual energy mode on all the patient regardless of whether you need it or you don't need it, because most of the findings in dual energies are incidental findings. You never know when you need it most. So in case of CT 7500, every case is a spectral result. FOV utilization, we don't have a limitation like a 35 centimeter, we can go up to 50 centimeter. Detector coverage also, we can cover up to 8 centimeter. Like in dual source, it is 5.76 centimeters. So we have a better, coverage in terms of detector coverage. And dose modulation, we don't overlap any data. We have a dose modulation which is available for both conventional and a dual energy. Obese patient also, you can do it very well with our system because it's a 120 kilowatt system. Temporal resolution, when we say reduce dual energy mode, we don't have any such compromise like the dual source is having, because we can do cardiac and other stuff. It support 100 kV spectral result as well. And also the pitch, we don't compromise on the pitch, speed, detector coverage, FOV. So this is what the crux is. And fast KV, if I say, unlike a fast KV switching, we don't generally have a limitation of the coverage. We generally don't have a limitation on rotation speed. We also don't have a temporal coherence of, like KV switching, they have a coherence of around 2.25 millisecond, whereas Philips, it's 0. So we don't have any temporal lag as such. Dose modulation, like in KV switching, you cannot use a dual dose modulation while you do a spectral results, whereas in Philips, you can use a dual modulation. So these are the results, which is there. Thank you so much for your time. Thank you so much. Yeah. Any question if you have related to the spectral city? Yeah, please, sir.
You have taken 100 and 140 kV.
Yeah.
Other vendors, they use 80 and 100 kV.
Yes.
So obviously their spectrum are far larger. So how do you match with that?
Sir, actually, the technology is totally different. So what they do, they have a different technology sources. Like what they do a energy separation on the basis of kV, which is kilo electron volt, right? It's kilowatt. 80 kV and 140 kV. Whereas in Philips, what we do, sir, we don't use our energy separation on the basis of kV. We generally use a single scanning on the single KVP, which is basically 120, either 120, 140 or 100 KVP, and then we generally separate those energy on the basis of KEV, which is basically energy of photons, not on KVP, because we are not changing it on the basis of KV, which is potential difference between a voltage, right? So this is how you can make a difference in the image quality, and we don't need to penalize a patient, because most of the time what happens when you do a patient scanning on two different KV modes, 80 KVP and 140 kV, then there are a lot of noise which produces within the image quality. Right, because 80 KVP will always have a larger number of noise as compared to 140. When you merge both the data, you're going to have a challenges in monoenergetic images. Whereas in case of Philips, we are segmentizing and we are changing up a result on the basis of KEP, which is kilo electron volt. So it is definitely going to have a less dose, and that too we use a different algorithm altogether. We use a model-based iterative technique to reduce down the dose to the patient, and at the same time the material or the energy separation is far better than the competition, if I say. So at the control room, you will choose only a 1 kV parameter, which is 1 kVp, 120, 140 or 100 kVp, and basis on 100 kVp, once the photons will touch the detector, we will separate it on the basis of KEV, which is kilo electron volt. Yeah. Yeah. No, you don't need to select it, because detector has those technology itself that the material is totally different. So material, the upper layer that I shown you, sir, the yttrium detector will only observe the lower KEVP, and the higher one will only absorb the higher KEV. So it's generally the material decomposition is aligned in that way that you don't need to worry about any, a lower and the higher KEV. Yes. So that is why it was too costly, sir. I remember the time when we were not even participating in the tenders, but now yes, the companies also come up with different concept. City 7500, we are using the same technology without even compromising on the image quality. And yes, competition also has a certain product which if they quote, then we can participate with them. So that's the scenario.
So I have a question regarding CT coronary angiography here. On the
sorry.
So with this model, your CT 7500 spectral CT. So what are the breath hold times for the patient who is undergoing coronary CT, and or we have moved to free breath holding or free breath era? Okay. So and another question is, what is the scan time for the cardiac CT? And what is the heart rate limitation for this model of your CT?
So if I have to answer your first question, sir, which says that can you go with the free breathing? Yes, we can do with the free breathing, but the thing is, it's a 2-beat scanner which we have right now. So 2-beat scanner can, perform your cases within a few seconds. Any cardiac cases can be done. And the second question which you said related to whether it is going to have challenges on the cardiac CT, no, there is no challenges, sir, as such.
2 heartbeat means about 1.6 seconds.
Yes.
So this is the scan time for your cardiac CT you are saying.
So 2 beats, when we say it's basically a 0.2 second is required to do a one scanning. And then if I have to cover up the entire, because we do a coverage of around 8 centimeter within one go. So if you have to scan a cardiac, you require a 12 centimeter coverage. So we can do it within less than a 2 beats.
Okay.
Yeah, so that gonna give you a good image quality in terms of cardiac. Yeah.
So, the other question that I asked, what is the limitations for about the heart rate? So, the scanner which right now we have, it has about 60 to 70 for optimal scanning.
Okay.
So, is there any heart rate limit for optimal scanning for coronary CT angiography?
Sir, I will not say a limitation, but yes, we do have a result with us where we have a scan a patient of 120 BPM as well. My application team is also here, they can confirm you that can be done, but there are there are certain parameters changes which is required, and at the same time, it's looking at the condition. I remember that we have done a case with the 120 BPM as well, without any further challenges. And it is more than also, we can manage it. With the help of our algorithm, what we have a beat-to-beat algorithms, which generally help you out to get a precise result of a cardiac. At the same time, we have an adaptive beat algorithm. So these are the two things which we use it in the cardiac, and then you can have a better image quality, and you can manage a higher heart rate as well. Even with the 128 CT, we remember that in the Gangaram, we have done a cases of 120 BPM, sir. So there is no such limitation as in, if I say, in terms of CT scanning a higher heart rate. So
we can also do with these scanners also, but the problem is with the image quality or motion artifacts. So can we post-process these motion artifacts?
Yes.
Or motion artifacts will not come with this scanner?
So now coming up with the artificial intelligence, which I even introduce, show it in the presentation, sir, with the precise cardiac. It's basically been aligned or developed in that, keeping in mind the scenario that the RCA majorly have a challenges, right? So it is going to ensure that you're going to have a better image quality in all that scanning what you do for the cardiac.
Thank you, Mr. Prashant, for your nice talk on spectral CT.
Thank you so much.
Now our second talk from Philips is by Mr. Mohammad Adnan on cardiac CT. And tomorrow afternoon there's an announcement. We'll be organizing the radiology resident quiz. A maximum of 8 teams with maximum of 4 participants per team will participate on first come first serve basis. Kindly give your names tomorrow by 11 AM. Residents from all institutes who have registered are requested to be present for this clinico-radiological feast. Over to Mohammad Adnan.
Yeah. Good evening, everyone. I hope after a tea break we are little freshen up. So this is not about any marketing and all. This is to be an educational topic. I request all the technologies to be more concentrated on this. Okay. So first we have to understand what is the role of CT in the cardiac imaging. Why we are doing the cardiac imaging, especially in the CT. So the first come first is the coronary artery diseases. So as we see nowadays, the more thing is like the number of deaths in around the world is due to the cardiac cases. Some if you see in the US and all, it's like very huge in numbers. So in India also it has been more increasingly now. And the second thing would be to differentiate between the non-calcified and the calcified plaque. So here, if you want like non-calcified plaque and the calcified plaque, so the thing is, we have the two things. One is the calcium scoring and one is the coronary artery analysis. Okay. So when we have a soft plaque, which is not able to differentiate without any contrast media, so there we go for the soft plaque, we go for a coronary analysis. Similarly, for the calcified plaque or a hard plaque, we go for a calcium scoring level. And the third thing could be to assess the amount of stenosis. What is the stenosis percentage? What is the narrowing within the distal artery or the proximal arteries? And to do all these things, there are two things majorly to be concerned. One, what is the heart rate and how to lower down, and what are the technologies nowadays so that it can be compromised. So there are beta blockers which are used to lower the heart rate, and the second thing is a vasodilator to clearly appreciate the coronary arteries. And moving to just a basic anatomy, I hope everyone is or aware of this, but anyhow just recollect on this. So what was like for the RCA, in right side what we have and the left side what we have. Moreover, it is unlike the normal CT planes. Cardiac has a three special axes known as a short axis, horizontal and the vertical axis. So all these three things have some significance, where if you go for a short axis, it is purely to assess the myocardium, and we go for a 2-chamber and for a 4 chambers. Okay. Moreover, what is the main thing? Main thing is the patient preparation. Okay. Once the patient is well prepared, 50% of the cardiac scanning is good. So first thing first come, instruct the patient to not take any caffeine or not to smoke. The second thing, inform the patient what we are going to do. Okay. For example, we are giving contrast, so your patient has to hold the breath. So all that instruction to be given to the patient and get a informed written consent. Okay. Third thing is make the patient comfort in terms of like even the bladder filled. If the bladder is filled, even patient get some of our motions there. So it is very required to evacuate the patient or instruct the patient to be deurinate. Moreover, the breathing patterns. Please assess the breathing pattern. Whenever you place the ECG leads, assess the breathing pattern. Moreover, when the patient is holding the breath and it is releasing, how come the ECG is traveling? Whether it is going beyond the limit, above the limit, any fluctuation happening or not. Okay. The next thing is, normally what we do for general cases, we are positioning the patient according to our mid-sagittal line. But in terms of cardiac imaging, place the patient in terms of cardiac. For example, it is little bit oblique, so place the position the patient in terms of cardiac is in the isocenter, so that it helps in a great imaging. And second thing, when you place the ECG leads, as you can see this image, the second image, the ECG are properly placed. It is not entangled anywhere. And in third image, if you see, it is entangled. Moreover, this orange color indicates we have a proper ECG signal. In the third image, you can see we have an irregular in the ECG signal. So even placing of the ECG wire makes a very impact on the ECG signals, so that it helps in our reconstruction. So proper the ECG, proper the result. Next, what are some of the techniques to be acquired? First thing comes first is the patient approach. Most preferably go for a right arm with the antecubital vein, and 18 gauge is very much recommended. Second thing, a dual head syringe. Here, what is the significance of saline? So what will happen when you give the contrast and with the saline, it helps in a great enhancement in the image quality. Moreover, in the next slide I have one beautiful image. What is the significance of saline when you give saline or when you don't give salines? And how should we decide the dose, the contrast dose for the patient? It depends on this. Contrast dose is equal to scan time
plus 6 seconds into flow rate plus 40 to 50 ml saline. This is the very standard contrast dose management. So if you want, you can just take a picture of this equation. Okay. What is the significance of saline now? As you can see, there are the first image, you can see the right side and the left side. To assess the RC very clearly, okay, in the right side, in the first monophasic image, it means we have just given only the contrast. Saline has not been given. In that image, we can see a lot of artifacts which we are not able to appreciate the RCA. When in the second image, with the help of saline, what happens? We can easily able to appreciate the RCA. And this, the third image is a dual flow. It depends on the pathology and with the radiologist confirmation whether they want a dual flow study or not. Some case in form of like a right ventricular diseases, it is very recommended. Then, what is the like the bolus tracking or the pre-monitoring technique where we have to keep the locator and tracker? The first is the make sure you are keeping the descending artery where when you have a right and left trachea bifurcation level, which we call as a carina level, just 2 centimeter below the carina level. So that is the most preferably one. So what will happen when you keep here, your distal arteries will get more opacified so that you can get a better image quality without any interference. Next, a very basic ECG, we all should be remembered the PQRS interval. Sorry, the QRS interval. The R to R tagging is where all the vendors and even in the technology we can easily able to retrospect and prospect the gatings level. Okay. These are the three major things what we encounter. The first one, the upside image is a normal coronary sinus image, and the second image it is a atrial fibrillation. Sorry, premature atrial beat. And the third image is a ventricular premature beat. So these are the some APB and VPB where we usually encounter after the scanning. And I will, in the upcoming slide, I will show you how can we assess this and how can we eliminate these points so that to get a better image qualities. Okay. So when we talk about the acquisition part, there are when we talk about the acquisition part, there are two approaches. One we call as a So when we talk about the acquisition part, there are two approaches. One is the retrospective gating and the prospective gating. Okay. With the help of radiologist, we are able to acquire that. It is all depend on the clinical confidence, whether we want to do the functional analysis or we want to do the normal coronary assessment. Fine. So as you can see in the retrospective gating, what exactly happens, we are acquiring the entire heartbeat. It means we are acquiring the systolic as well as the diastolic. So we are acquiring the both the phases. So that what we'll get the functional value as well as the coronary values also. Similar to that, in the prospective, also known as step and shoot, okay, we are only concentrating either in the systolic or in the diastolic. So this is all depends on the radiologist confirmation which technique we should approach. And these two technique has, because if I say about the retrospective, it has a lot of patient radiation. We are radiating patient entire the cycle. When I speak about the step and shoot, that is the prospective gating, the radiation dose, we are limiting our radiation doses. Yes. As you can see in the image, only the yellow segment here, we are only exposing either a systolic beat or the diastolic beat. Okay. So in the systolic beat, there is no X-ray acquisition. There are no X-ray in the systolic phase. Only in the diastolic phase, the X-ray tube switch on only in the diastolic phases. So it means we are reducing the patient dose to the, for example, 50% we are reducing the patient dose. But what if the patient heart rates goes beyond that? That's a challenge. Then is where the retrospective gating help us. That's what, it is all depend on the radiologist and the clinician which technique we should approach. Similar to that, for example, I said here in the step and shoot we are acquiring only one phase. For example, a diastolic 75%. What if I want little bit extra? For example, five phases extra or 5 phases below that, plus or minus. So as you can see in the image, the dark blue line is what my major thing is, the major acquisition. And the green, light green line, we call as a phase tolerance. It means if I'm acquiring a 75% plus or minus, so this we call as a phase tolerance. It means plus or minus 5 I'm able to acquire the images. Second thing, this is on the terms of retrospective gating. Retrospective gating, I said, we are acquiring the systolic beat as well as the diastolic beat. So what will happen? The X-ray is completely on. If the X-ray is completely on, it means I'm giving a high radiation to the patient. So how can I minimize that? So in that also we have to assess whether we are requiring only on the coronary phase to assess the coronaries, or I want the functional thing also. For example, if I want only to assess the coronaries things, so I can majorly give the 100% radiation to the diastolic phase. And in the systolic beat, I can reduce the radiation. As you can see in the image, 100% dose and 20% dose. It means in the functional phase, I'm reducing my dose. That means I'm not much concentrated on that. I just want the image whether it is a suboptimal or not. Okay. And how can I do that? So here we have two things, the coronary and the functional. So here I can predefine that. For example, I want a 45 phase, 75 phase. Whether I want a 45 phase or a 75 phase, that will be my coronary phase. Other than that, I will use as a functional phase. So that what will happen, I'm giving only a 20% radiation dose to the patient. Okay. Moreover, whenever you do a scan, make sure in the protocol these two are always marked. Handle irregularities online and automatic pitch and rotation time based on heart rate. So this will help you do a better imaging. I'll come on the irregularities. Okay. So once the scan is completed, you can see the ECG strip here. The ECG strips. There is one option, you can just right click on the ECG strip, you will get all these parameters. The major parameter is run irregularities auto detection. It means you can just click on the irregularity detection, system will automatically give you the premature beat, whether it is an atrial premature or a ventricular premature beat, so that it will be helpful for you to get a better imaging. We can easily accept that or reject that. Okay. This is what actually in the day-to-day practice we are doing. And moreover, what makes a very good imaging is our high rotation time. A 0.35 what we have in a performance segment machine, it's a higher of 0.35 second. And a software technology called a Cobra, where we get a true 3D acquisition. As you can able to appreciate in the images, this image it has a lot of step artifact, but in the third image, it shows a very beautiful image without any step artifact. The second technology what we are using is a adaptive multi-cycle reconstruction. It means like whenever I want to acquire images, I need at least 180 degree. Fair enough? What I am doing in the cardiac is, I am splitting this 180 into a 4 segment, so that my temporal resolution is bare minimum. I can able to acquire a good coronary imaging. And moreover, what we have, whatever we do, there is some inherent motion in the RCA, which causes a very blurred image in the RCA. So for that, there is an AI algorithm, what we call as a precise cardiac. So what it basically does, with the help of this algorithm, it automatically corrects. It means it's a motion correction. It is not only for the RCA, it is all for the all arteries, but majorly the motion correction happens in the RCA. So this is all my the brief introduction. So I hope you take some points on that. Thank you.
Any questions?
I want to ask, if you go for triple vessel study like pulmonary, coronary and aortic vessel in a single study.
Yes, yes.
What will be the protocol for that study, and
Yes,
what is
if
the
you-
limitations for that?
Yes, you are talking about the triple rule-out study, where you want to go for the pulmonary, cardiac, as well as the aortic assessment, the full aorta. Yes. For there is a dedicated protocol called the CT gated helical. So if you approach that study in a single run with a low threshold, you can able to approach all the three, the pulmonary, the coronary, and the aortic assessment. So there is a dedicated protocol for that, called as a CTA gated helical. So that is a very preferable one. Thank you.
Now we would like to invite all the chairpersons to please come on the stage and felicitate the speakers. I would request Mr. Prashant and Mr. Mohammad Adnan to please come on stage.
Please give a huge round of applause.
Now I would request Professor Prateek Kumar sir and Professor Anit Parihar sir to please come on stage and felicitate our chairpersons. Professor Manoj Kumar, sir. Dr. Nitin Arun Dixit, sir. Dr. Siddharth Mishra, sir.
I request the residents to please come forward so that we can have a quick hands-on session. All the way, all the way. So, I request first 10 residents to be please forward. You can have a seat. There is one seat.
काम तो कर रहे हैं
इधर एक चाय डाल के बैठा देना फिर लोगों को.
यहीं पे सिस्टम के सामने.
Yes, I'll be doing system so that you all can see in a single view. Just leave this seat. I'll approach this. Even take all the seats. ये वो सब ले लीजिए. सब आपका है. इधर बैठ जाइए, उधर बैठ जाइए, सब ले लीजिए. हाँ. हाँ, हाँ. तो अगर मैं ठीक है ठीक है ठीक है ठीक है चलेगा चलेगा कोई नहीं उधर देख के चला लेता हूँ फिर मैं. This one?
No, that's not working. This one you can.
Excuse me, you can use this one. Sorry.
Tell them that.
Better I'll take the system so that they can't use. नहीं इसमें मत बैठिए अभी ये ऑन नहीं हो रहा है.
No, this is the server.
सर्वर है. So I will demonstrate in the display so that you can follow on that. And if you have any queries, please raise your hand so that I can able to.
Tell them
Password.
Philips@123 capital P.
Oh, password is a Philips @123. The P will be capital. P capital Philips @123.
Don't change the username.
The username will be the admin.
No. Don't change the username. Keep the username as it is.
Okay, fine.
Just keep the username as it is. Enter password capital PHILIPS @123. If anybody is facing issues, just raise your hands. We'll be assisting you. Thank you.
Once everything is logged in, please let me know so that we can proceed. Done? Done? Yes. So please follow my the cursor. Click on the local and go to the KGMU folder. Okay. In that you have a 3 studies. So first we'll follow with the calcium scoring. Yes, the first thing is a calcium scoring. Yes. Click on this study and click on this down top menu. Go for the. No, I'm following. No. Uspe. Yeah, there is a small arrow mark just after the 3D modeling. Okay. Then click on the calcium scoring. Once you have clicked, let the system just take couple of seconds. Yes. Now just check. So once you open the cases, what you have, all the calcium, the bone is also calcium. So even there is a calcium in the coronary arteries, so it will appear in a pinkish image. Okay. For example, just scroll the images. You can appreciate there is a calcification in the. Yes. So yeah, for that you have a, on the right side, left side you have a highlight option here. Click on the highlight. Yes. Click on the highlight. You will able to appreciate the automatic coloring of the images. नहीं इस पे मत जाइए. मैंने बोला 3D मॉडलिंग के बाजू में जाना है. इसको क्लोज करके बाहर जाइए. क्लोज कीजिए इसको. छोटा एरो मार्क है ना, एरो मार्क. उसमें कोरोनरी कैल्शियम स्कोरिंग लास्ट और हाँ डन. So then scroll the images. Okay. On the left hand side you will have the series here. For example, the left main, LAD, LCX, RCA, so everything. If you see any calcium on the left side, it means the left main. Click on the left main, then click on one seed. Click on one seed. Below that. Then scroll the images click on the left main artery. Just click on this. So once you click, system will automatically calculate the calcium. Okay, this is for the left main. Once left main is done, scroll the images. Okay. Scroll the images and you can see there is one more calcium here, but it is on the LAD. So what you have to do, click on the LAD. On the left hand side you will have a series of arteries. So click on the LAD, then click on the LAD calcium. Right? Similarly, just scroll the images. Yes. Do you have one more calcium here, which is on the LCX? So click on the LCX, then click on the LCX calcified artery. Right? Single click is enough. हाँ. बस एक सिंगल क्लिक करना है, उसमें जाकर क्लिक कर दो. हाँ. ठीक है? You will get the scoring down. Right? Left main, LAD, LCX. Just scroll the images and once again check whether you are missing anything or not. Is there anything in the right side? Nothing left, right? Yes. So our four major arteries, which is our left main, LAD, LCX and RCA, though there is no calcification in the RCA, so the final scoring is 178.28. Okay, so this is the final cutoff. Depend on this, you have to decide whether we should proceed with the coronary assessment. It means we have to give the contrast or not, it is required or not. Right? So this is all about the calcium scoring. If everyone is done, then we will proceed with another application. Yes. Okay. So what we have done is now, it depends on the Augustin score. Okay. Similarly, we have two scorings. One is the Augustin score and one is the mass score. So Augustin score is basically used in the Middle Eastern country and in the Indian. Okay. The mass score is usually done for the European countries. Okay. So what I will do, I will change this Augustin score into the mass score. Before that, just check me. In the Augustin score, you have to do one thing. In the downside, you have something called the Miasa. Yes, Miasa percentile. In that, just click on the patient information. Yes, in the patient information, you can define what is the ethnicity and the race. So depend on this. So Miasa report, it basically takes two things. One is the gender, one is the age. So depend on the gender and age, this will give you the exactly scoring of the calcium. This is very important. Save. Just click on that. Patient information. Click anything. Hispanic, yeah. Click save. One second. Click, go back. No. Click on that. Click Hispanic and click here, male or female. Click save. The age is missing. No issue. It means this is a demo data, so the age is not defined there. No issue. Just click OK. So once after defining that Miasa report, down you will have a percentile. So Miasa report for this age is so percentage. So that is what you have to report in the patient report. Right? This is the final report. So everyone is clear with that, then we will proceed with the some other applications. If anyone have doubt, please raise your hand so that I can able to check on that. Done? All done? Fair enough. Yes. So now I'm closing. If you want to save this, what you can do, just click on the table. Okay, click on the table, and on the left hand side, just below the info, you are having something called save selected image. Okay, or you can select the save all tables. You can click anyone. And where you have to save, you can give your name. Please write your names there. And save in the KGMU folder, please save that. Done? So you have written your name there, I hope so. Done. Okay. Now exit this. Don't save, just exit. Now we'll have a very deep section in the coronary analysis. Okay. Click on the CCA, the third one, the third patient list, CCA, and click on the calcium, the small arrow mark just next to the calcium scoring. Okay. Now click on the COMP cardiac, comprehensive cardiac. Once you have clicked, just wait for 30 seconds. System will automatically segment all the coronaries with all the 4 chambers. Done. So once you have opened, on the left hand side you can see there are 2 things here. Cardiac CT viewer and another one is the comprehensive cardiac. So first click on the cardiac CT. Okay. So if you click on the cardiac CT, it is like just a viewing. But in my previous presentation, I said we have a special 3 axes. See, this is the very normal axis. Normal image, even if you go for the liver imaging, we'll see the normal axial, sag and coronal. That is the anatomical planes. Okay. For cardiac, there are 3 dedicated special planes. For that, what you have to do, on the left hand side, just below the 2D image, what is the 2D written, there is a small arrow mark, just next to the sagittal one, the sagittal icon. Click on this. Below 2D, we have a 3 orientations, axial, sag and coronal. Next to that, there is a small arrow mark. Click on the arrow mark. You will have a 3 cardiac axis. One is the short axis, right? This is the short axis. Second is the horizontal axis, the 4 chamber view. Then you have a vertical axis, the 2 chamber view, right? So whenever you go for a cardiac reporting, this 3 axis is very much helpful. Fair enough? Yes. In the short axis, there is, okay, 1 second. Yeah. In the short axis, there is a view called C view, okay, where you can easily appreciate the coronary artery in a single picture. For that, what you can do, just click on the thickness on the right hand side, click on the thickness, and just change the thickness to about 20 mm. Enter. Then below that you will have a MIP option here. If it is AIP or average, click into MIP. 20 or you can click 50 also. So what exactly this help is, you can see this RCA, this is complete RCA, and it appears as a C view. It very helps in defining the calcium. This exactly defines my proximal segment, my mid segment and the distal segment. So in a single view, I'm able to appreciate all 3 segments, right? If you have any stenosis, I can able to appreciate, okay, mid has a stenosis or distal has a stenosis, right? Okay. So first part we have covered here. The second part is our COMP cardiac, So you can just next to the cardiac CT viewer, click on the comprehensive cardiac. As you can see, you are getting a automated segmentation of the coronaries and automated segmentation of the chambers, right? If you feel, just scroll the images and check whether all the arteries are marked properly. It means all are in a filled with colors or not. If it is not filled, please let me know. Just scroll the images. Moreover, if you want to do like more precisely, on the right hand, so left hand side, you have something called coronaries, all, none and coronaries. So just click on the coronaries. Now you can only appreciate the coronaries, aorta and tricusp followed with the coronaries, right? आपने close कर दिया है, इसको close कीजिए, एक बार exit कीजिए, नहीं एक मिनट, इधर click कीजिए, right click, launch comprehensive cardiac, 2 मिनट. Everyone on the track? Okay. So if you check here on the left hand side top, you have 4 workflow. The first thing is the segmentation. What system has automatically done. If the artery is not marked, then we will click on this add coronaries. So as of now, everything is marked now. So then we'll follow with the second thing called coronary extraction. So in the coronary extraction, voluntarily I have, see this all question mark on the vessel list, I have voluntarily switched off so that you can mark the coronaries now. So click on 1 coronaries, for example, click on LED and confirm whether this is LED or not. If you are sure this is LED, on the downside in the green color, there is something called confirm vessel. Okay, just click on that confirm vessel. On the left hand side, in the vessel list, you have multiple vessel list. LAD, LCX, RCA, D1, D2. Click one by one and make sure that is RCA or not, LCX or not. And if you want, you can just scroll the images. Just scroll the images so that you can easily appreciate whether that is LCX or not, RCA or not, D1, D2, everything is automatically marked. You just need to confirm that. I'll just allow 30 seconds, please confirm that. Direct display. Click on the patient list, whether LAD, LCX, RCA जो भी है उसको click कीजिए and you have something called the confirm vessel. ठीक है, image पे scroll the image, बस एक single click करके उसको rotate कीजिए image को, ठीक है, then confirm vessel, उसको confirm vessel click कीजिए. It means you have confirmed the vessel. Yes. All done? 30 seconds over. ठीक ओके सर, नो इशू. ठीक है सर, नो इशू. अगर कुछ है तो प्लीज बताइए एक बार, मैं क्लैरिफाई कर देता हूं. हाँ, एलईडी हो गया तो आरसीए कीजिए, फिर आरसीए D1, D2. एक्चुअली दिस विल हैपन ऑटोमेटिकली, ये सब ऑटोमेटिक होता है. इसको मैंने ऑफ कर रखा है मैनुअली ताकि यू हैव टू असेस दैट. डन? ठीक है. ठीक है. So if second step is done, then we here we have some special views. Okay, if you just check this 3D image, the VR image, click on this heart option. Okay, you will have multiple presets. अच्छा, ठीक है, हार्ट पे क्लिक कीजिए, उसके बाद आपको बहुत सारा प्रीसेट मिलेगा इसमें. तो पहले यू कैन क्लिक ऑन द ट्री व्यू, उस पर क्लिक कीजिए, तो आपको क्या होगा इसमें, ऑल द 4 चैम्बर्स हैज बीन एक्सक्लूडेड. ठीक है, देन क्लिक ऑन द ट्री, फिर ट्री पे क्लिक कीजिए. अगर थोड़ा और नीचे आएंगे आपको मिलेगा ग्लोब व्यू. जस्ट क्लिक ऑन द ग्लोब. ठीक है, एंड यू कैन, आप इसको देख सकते हैं. दिस इज अ पेटेंट व्यू एक्चुअली फ्रॉम फिलिप्स. ओके,
नीचे की तरफ जो ये आ रहा है,
हाँ,
ऐसा लग रहा है जैसे वहाँ पे, हाँ वैसे हाइपोप्लास्टिक है. इसको अगर सही करना हो तो कैसे?
हाँ, उसको क्या करेंगे आप, ये वेजल है ना SW करके, इसको क्लिक करके जस्ट इंक्रीज द थिकनेस, फॉर एग्जांपल 3 mm. ठीक है, चेंज हो गया जो ना हाइपोप्लास्टिक. हाँ, अब 2D में करते हैं उसको. ठीक है, अगर ग्लोब हो गया आपका, देन क्लिक ऑन द ग्लोब. उसके बिल्कुल नीचे यू हैव अ 2D इमेज. जस्ट क्लिक 2D. So the benefit of this 2D image is like, in a single picture you are getting all the coronaries. So एक ही इमेज में you get the RCA उसका branches, then left उसका branches. Fair enough?
इसमें कभी-कभी ऐसा होता है कि कोई आर्टरी कहीं पे जैसे ओरिजिन पे दिखता है, यहाँ पे
हाँ, वो दिखती है, उसके लिए थिकनेस बढ़ा दीजिए आप.
नहीं आता है, उसको 10 mm तक हम करके देंगे.
अच्छा, नहीं आ रहा है,
हाँ सर,
मुझे बता देना फिर एक बार चेक कर. डन.
नहीं, हम लोग बस 12 में.
ठीक है, ओके. देन उसके बाद हम जाएंगे थर्ड स्टेप, कोरोनरी एनालिसिस. ठीक है, क्लिक ऑन द कोरोनरी एनालिसिस. इफ यू हैव मार्क्ड, एक मिनट, अब एक एरर मैसेज आएगा आपको. इट मीन्स वेदर यू हैव मार्क्ड ऑल द आर्टरीज आर नॉट. मतलब आपने प्रॉपरली LED, LCX, RCA सब मार्क किया नहीं किया. अगर किया है तो दिस एरर मैसेज विल नॉट कम. इसलिए मैं आपको बोला लाइक यू हैव टू मार्क एवरीथिंग. ओके, नो इशू. अगर अब आपने मार्क नहीं किया तो कोई नहीं, बस इसको एस कर दीजिए या नो कर दीजिए, कोई ना. क्लिक नो. तो इट मीन्स बस जो आपने मार्क किया है विल एनालाइज दैट ओनली. ठीक है, हाँ, डन हो गया आपका. हाँ. अगेन इन द लेफ्ट हैंड साइड देयर इज समथिंग कॉल्ड प्लाक एनालिसिस. ठीक है, नाउ दिस इज अ वेरी नॉर्मल कोरोनरी, सो देयर इज नो एनी सॉफ्ट प्लाक और हार्ड प्लाक, नथिंग इज डिफाइंड हियर. ठीक है, अगर होता तो वी कैन इजीली अप्रिशिएट. अभी हम क्या कर सकते हैं, विल डायरेक्टली गो फॉर द कोरोनरी असेसमेंट. ठीक है, कितना स्टेनोसिस परसेंटेज है नहीं है देखने के लिए. उसके लिए अगेन क्लिक ऑन द शेवरॉन बटन, क्लिक ऑन द कोरोनरी एनालिसिस. ठीक है, वंस यू क्लिक ऑन द कोरोनरी एनालिसिस, आपके पास क्या होगा नीचे इधर, you'll have a 3 lines. The central line is your reference, sorry, lesion line. ठीक है, अगर आप स्टेनोसिस आपको दिख रहा है कुछ, तो what you will do, you have to keep that reference, sorry, lesion point on that desired level. For example, ये मेरा स्टेनोसिस दिख रहा है इधर, just for example, अभी ये नॉर्मल केस है ये. अगर कुछ इधर स्टेनोसिस है या कुछ नारंग दिख रहा है, तो जो सेंटर पॉइंट है ना उसको जाके इधर रख दीजिए. वो बस इसको ऊपर नीचे मूव कीजिए. ठीक है, मूव करने के बाद फॉर एग्जाम्पल अभी इसमें कुछ नहीं है, 1 सेकेंड. हाँ, ठीक है, उसके बाद क्या कीजिए, देयर इज समथिंग कॉल्ड सेफ फाइंडिंग्स. अभी हम सिस्टम को मैनुअली बोल रहे हैं लाइक दिस इज आवर पैथोलॉजी, दिस इज आवर पैथोलॉजिकल इमेज। तो मैं इसको क्या कर रहा हूँ, मैं इसको फाइंडिंग दे रहा हूँ, सेफ फाइंडिंग करके। सेफ फाइंडिंग क्लिक कर दीजिए, ठीक है। इट मीन्स हमने इसको स्टेनोसिस फाइंड किया है वो। हियर द ब्यूटी इज इन द प्रीवियस वर्जन, in the latest update, what you will get here is a exactly stenosis percentage, the grading, मतलब वो severe है, moderate है, low है, जो भी है you will get here। अभी minimal दिख रहा है ना, you can see that like 1 to 2% is minimal stenosis grading। तो it means बस आप safe finding क्लिक करने से आपको मिल गया कितना परसेंटेज ऑफ stenosis है, और it will define whether वो low है, intermediate है और risk level पे करके। इसके बाद there is one more thing called CAD-RAT, very special feature। On the left hand side there is something called summary, हाँ finding summaries, उस पर क्लिक कीजिए। Yes, now you can see the very beautiful schematic image, ठीक है। It means जिधर आपने उसको मार्क किया एज अ फाइंडिंग, सो इन स्कीमेटिक डायग्राम, अगर आपने कभी रिपोर्ट नहीं दिया, अगर इसको दे देंगे तो इट इज मोर देन सफिशिएंट, बट एनी हाउ यू हैव टू गिव द रिपोर्ट, ठीक है। यू हैव द वेरी स्कीमेटिक डायग्राम एंड इट विल डिफाइन, इट मीन्स द फाइंडिंग वन विच इज F1 इन एलएडी स्टेनोसिस परसेंटेज, नहीं 15 में है, 15 में है। सो दिस इज द लेटेस्ट वर्जन, ठीक है। व्हाट इज द परसेंटेज ऑफ स्टेनोसिस, कितना परसेंटेज है और उसका डायमीटर कितना है, फिर वो क्या है, वो मतलब रिस्क लेवल पे है या मॉडरेट लेवल पे, देन कौन सा सेगमेंट। इफ यू टेक ओनली द आरसी और एलएडी, एवरी आर्टरी हैज 3 सेगमेंट, द प्रॉक्सिमल वन, मिड लेवल एंड द डिस्टल वन। सो इट इज ऑल्सो डिफाइनिंग कि कौन सा सेगमेंट पे है वो, मिड सेगमेंट पे या लोअर सेगमेंट पे, ठीक है। Then you can save the changes, and if you want you can do like every this thing, क्या क्या लिखा उसमें, नॉन डायग्नोस्टिक स्टेंट, अगर स्टेंट है तो यू कैन क्लिक ऑन द स्टेंट, ग्राफ्टिंग है तो यू कैन क्लिक ऑन द ग्राफ्टिंग, सो एवरीथिंग कैन बी रिटन हियर। इफ एवरीथिंग वंस डन, क्लिक ऑन द सेव इमेजेस। So once everything is done, click on this automatic suggestion. Click on this automatic suggestion, then click approve. So it means depend on your this modifications, system has given the report. Fair enough? इतना काफी है, इतना काफी है। नेक्स्ट बात कर लेंगे फिर। ओके, एवरीथिंग इज डन, देन यू कैन क्लिक ऑन द सेव इमेज। पैथोलॉजी नहीं, स्टेंटिंग इमेज है ये, स्टेनोसिस इमेज एक दूसरा है, उसको चलाऊं फिर, नेक्स्ट बैच चलाते हैं उसको, ठीक है। हाँ ठीक है, उनको चला देंगे फिर दूसरा वाला, ठीक हो। सो द फर्स्ट स्टेप, सेकेंड स्टेप एंड थर्ड स्टेप completed. I hope you had some insight on this. So by this we'll end the first session. We'll go for the second session now. And second session we'll have a stenosis grading also with the calcium and everything. No, the second session. Sorry, second group. नहीं करना है तो कर सकते हैं, कोई नहीं। हाँ अगर वैसा ले रहे हैं तो उसको मॉडिफाई कर दीजिए आप। हाँ उसको कर सकते हैं, रिमूव कर सकते हैं उसको। हाँ
मल्टीपल प्लेट्स हैं
तो उसको मल्टीपल को हम एक ही क्लिक करके मल्टीपल क्लिक कर सकते हैं।
मल्टीपल करेंगे और मैक्सिमम थिकनेस वाले को आप फोकस करना पड़ेगा।
नेक्स्ट के दूसरा वही है, आप इस पर एक बार ट्राई कीजिए, फिर मुझे बता दें। बैठिए ना, बैठिए आप भी, क्यों डन। there are seats vacant still, so people can join. There are 3 seats vacant now. 8 or 9 members at a time. आप बैठिए इधर.
New manual feature added. AI नहीं है. AI is just reporting form. AI is AV में अभी तेरे पास आ रहा है.
AV है.
Schedule reporting automated है.
उसके लिए हेलिकल डेटा चाहिए, एक्चुअल डेटा नहीं चाहिए.
है ना इसको लेबोरेटरी.
नहीं है, हेलिकल डेटा नहीं है इसमें. ओके. नहीं है.
तो मेरे सामने बोल रहा है. अब तो मेरे से ऐसे बंगे बन देना.
ठीक है.
I think all set.
सर आप भी बढ़िया बता. ये तो सॉफ्टवेयर डालना पड़ेगा क्या? ये है नहीं क्या इनके पास?
Version 11, 7 है.
12.
So this is more advanced on AI, sir.
Just advanced AI फीचर के अलावा सब कर सकते हैं ना.
सब कर सकते हैं. So you finish it in 5-10 minutes.
लास्ट वाला नहीं है. रिपोर्टिंग फॉर्मेट.
हाँ फिक्स.
Switch on the mic.
No, it's on already.
12 से 15 बेच रहा है तो कुछ तो करेंगे.
So all set. We'll start with the calcium scoring. I hope last system is very much busy with 8 to 9 people in a different sector. अगर आप चेयर के पीछे खड़ेंगे तो it will be enough. Yeah, हाँ. ठीक है. Exit. Do everything exit. Okay. नहीं. जो भी आपको दिख रहा है प्लीज क्लिक ऑन द एग्जिट. नीचे है ना, एग्जिट कीजिए उसको सब. नहीं, इसको नहीं, बस इमेज दिख रहा है तो. हाँ ठीक. हाँ तो नाउ क्लिक ऑन दैट. फर्स्ट क्या है आपका कार्डियक कैल्शियम ब्लू में ना, उसको क्लिक कीजिए आप. क्लिक करके लॉग आउट हो गया.
क्या हो गया?
लॉग इन नहीं हो रहा है. हाँ फिलिप्स पी कैपिटल फिलिप्स @123 @123 एंटर.
Your account logged out.
चलिए तो कांड हो गया. अब
क्या हो गया?
ये आईटी भी कुबला है ना. So you can click on this cardiac calcium जो first लिखा है उस पे click on that. ठीक है. उसके बाद on the left hand side COMP cardiac है ना, उसके बाजू में एक छोटा सा एरो मार्क है, उसको क्लिक कीजिए. COMP cardiac है ना, उसके बाजू में छोटा सा एरो मार्क, उस पर क्लिक करके then you have application called calcium scoring. एक आइकॉन है कैल्शियम स्कोरिंग. click on the calcium scoring. எது click பண்ணீங்க?
No, I didn't click anything. I kept ready for you. Stop.
ठीक है? Scroll the images and please check कि calcium किधर है.
अपने आप कैल्शियम मार्क कर देगा हाँ सारा हाँ सो मतलब हाउ एक्यूरेट इट कुड बी मे बी कुछ प्रॉब्लम है तो कैसे पता चलेगा
नहीं सर प्रॉब्लम है तो मार्क ही नहीं करेगा आपको इसमें पर अगर प्रॉब्लम है तो क्या होगा जो फुल है ना डेंसिटी उसका उस पर हाफ डेंसिटी दिखाएगा आपको ऑटोमेटिक 3D मार्क नहीं करेगा उसमें
जहाँ जहाँ कैल्शियम डिपॉजिट है
वहाँ आपको ऐसे वाला कलर दे देगा वो पहले तो आपको क्या करेगा ये कलर दे देगा
बोन को भी चूज कर लेगा
वही सर बोन सब कुछ चूज कर लेगा कैल्शियम जिधर भी आप चूज कर लेगा अभी फॉर एग्जांपल सो यू कैन जस्ट स्क्रॉल द इमेजेस अभी देखिए इधर आपका कुछ कैल्शियम है ठीक है तो ये क्या कर रहा है आपको ऑटोमेटिकली कलर दिखा रहा है इसमें इस पे वी हैव टू डिसाइड वेदर दिस इज एक्चुअल कैल्शियम और नॉट ये आपको 70% दे दिया ये कैल्शियम है करके इस पे वी हैव टू डिसाइड हियर
तो अगर इसको हटाना है तो क्लिक करना होगा
इसको बस क्लिक कर देते हैं इसको या उसको ये है ना सर इधर क्लिक कर दीजिए वो हट जाएगा वाइट हो जाएगा वो या नहीं तो उसको मार्क ही मत कीजिए आप देखिए फॉर एग्जांपल RCA फॉर एग्जांपल ये मेरा RCA है तो उसको मैं क्लिक करूंगा ये तो ये RC बन जाएगा वो तो इट इज डिपेंड ऑन द क्या यूजर टू डिफाइन और नॉट डन हो गया ऑलरेडी मार्क्ड है हाँ तो आप उसको रीडिफाइन कीजिए रीसेट ऑल कीजिए और है ना अगर ऑलरेडी मार्क्ड है उसमें तो नीचे आपको मिलेगा रीसेट ऑल नहीं जाएगा रीसेट कैसे जाता है ना नीचे से अगर कुछ है तो प्लीज बताइए नहीं आ रहा है ना कोई ना अगर रीसेट करने से आपको नहीं हो रहा है वो तो व्हाट यू हैव टू डू अगेन क्लिक ऑन द एलईडी पे क्लिक कीजिए उसके नीचे आपको मिलेगा डिलीट सीड ठीक है उसको क्लिक करके उस पर डिलीट कर दीजिए बस ये डिलीट हो गया है फिर उसको पर रीमार्क कर सकते हैं दूसरा फिर आपको मार्क करना है तो क्लिक ऑन द एलईडी और LCX जो भी आर्टरी है उसके नीचे आपको मिलेगा 1 क्लिक सीड Sir, it is just to assess whether we can proceed with the further assessment of it. Regarding the analysis, coronary analysis. For example, if I have a clear, like for example, I don't have any calcium block. Calcium block is a heart block. तो heart block है नहीं सिर्फ बोल सकते हैं के लिए we do for the calcium scoring. अगर calcium इतनी ज़्यादा कितनी ज़्यादा क्या वो डिसाइड करेगा और ज़्यादा it is depend on the radiologist. For example, उसका cut off है depend on the institution. 50% हाँ नहीं सर इसमें आप क्या करेंगे एक स्कोरिंग है अगर आप इसमें देखिए स्कोरिंग में तो कितना स्कोरिंग है जैसे आप आज से सब टोटल आ जाता है कि वो देखा था मैंने लास्ट एग्जाम्पल उसके नीचे वो कॉन्ट्रास्ट देके कर सकते हैं 400 के ऊपर देन इट इज अलार्मिंग सिग्नल मतलब कॉन्ट्रास्ट देंगे तो भी कोई फायदा नहीं है देन आप टू स्टॉप गो फॉर सम इंटरवेंशन सो कैल्शियम स्कोरिंग इज अ वेरी बेस नेम टू डिफरेंशिएट
सपोज ये ऐसे देख के हमें पता नहीं चलता है कि वो कितना स्टोनोसिस हो रहा है
सर लेकिन आपको स्कोरिंग कैसे मेजर करेंगे हाँ देख के भी कर सकते हैं
yes all done so if calcium score is done we'll proceed with some coronary analysis सबको हो गया ना कैल्शियम स्कोर कुछ है दिक्कत इसमें बता देना एक बार हाँ बोलिए
ठीक है, हो गया सब? हाँ, अगर फॉर एग्जांपल राइट साइड देखिए आप, राइट साइड कोरोनरी में कुछ कैल्शियम है या नहीं है? नहीं दिख रहा है, मतलब हो गया आपका। पिंक कलर फर्स्ट। अगर राइट साइड में आपका कुछ कैल्शियम है तो यू विल गेट इन अ पिंक कलर, ठीक है? नहीं है, इसका मतलब आपका राइट साइड क्लियर है, नो प्रॉब्लम। लेफ्ट साइड आपने देखा एलईडी पे एक है, एलसीएक्स पे एक है, राइट? उसके बाद यू कैन सी द टोटल कोरोनरीज, कितना आ रहा है इसका टोटल स्कोर? 166.19. So this is your scoring value. So depend on this you have to decide, मतलब the clinician will decide to further proceed or not. तो जैसे आपका कैल्शियम स्कोरिंग स्कैन होता है, ये प्रोसेस कीजिए, तुरंत करने के बाद सेंड कीजिए डॉक्टर्स को, ठीक है? उसके बाद वो बताएंगे आपको, मतलब कॉन्ट्रास्ट देना है नहीं देना है, उसके बाद क्या करना है करके, ठीक? ठीक है, ये हो गया तो बस इसको सेव करके एग्जिट कर दीजिए। उससे पहले एक काम करना है आपको, जो रिपोर्ट के नीचे आपको मिले ना पेशेंट इंफॉर्मेशन, पेशेंट इंफॉर्मेशन क्लिक कीजिए। हाँ हाँ बिल्कुल, क्लिक करके द फर्स्ट थिंग रेस एथनिसिटी में कोई एक क्लिक कर लीजिए, अदर्स के अलावा। व्हाइट हो गया, हिस्पैनिक हो गया, चाइनीज, जो भी है वो। नेक्स्ट जेंडर, मेल फीमेल जो भी हो, देन सेव, go back. Which one? So on the right hand side down you will have a patient information here. Click on the patient information, define all this, race, ethnicity, gender, जो भी है इसको क्लिक कर लीजिए, then save. हाँ, हाँ 1993 करेक्ट। आउटसाइड द सपोर्टेड रेंज, तो उसको चेंज के लिए 28 है ना ये? हाँ, तो 45 to 84 लीजिए इसको। 44 बोले तो एक आ गया उसमें आपको, ठीक है? डन। नाउ यू कैन क्लिक, टेबल पे क्लिक कीजिए, इधर टेबल पे क्लिक करके राइट क्लिक सेव, या नहीं तो की इमेज सेव कर लीजिए उसको। राइट क्लिक की इमेज, या नहीं तो लेफ्ट हैंड साइड में सेव टेबल, हाँ सेव ऑल टेबल। डाइकॉम पे क्लिक ना, सेव टेबल करेंगे तो नहीं आएगा, उसको क्लोज कीजिए, वो कैंसिल करके सेव टेबल, ऊपर ऊपर सेव सेलेक्टेड इमेज है ना? हाँ हाँ, नहीं selected image, हाँ ठीक है, उसको कैंसिल, क्लिक हियर, सेव सेलेक्टेड इमेज, क्लिक, टेबल पे क्लिक कीजिए, की इमेज, वो नीचे सेव हो गया आपका इमेज। डन, ठीक है? ठीक है, इफ दिस इज डन देन विल मूव फॉर द कोरोनरी एनालिसिस। हाँ उसको लगा, इसको एग्जिट कीजिए नीचे से, एग्जिट एग्जिट नीचे से एग्जिट कीजिए उसको, ठीक है? उसके बाद नीचे आपको लिखा है ना कार्डियक अक्लूडेड पीएल करके, ठीक? उसको क्लिक करके अगेन ये जो कैल्शियम स्कोरिंग लिखा है ना, उसके बाजू में एक छोटा सा एरो मार्क है, ओके। ये कैल्शियम स्कोर के बाजू जो एरो मार्क है उसको क्लिक करके क्लिक ऑन द COMP कार्डियक, आ रहा है? नहीं, अगर हैंग हो रहा है तो बस दो मिनट ये डेंटल प्लानिंग हो गया ना, क्लोज कीजिए। नहीं, मास्क और इंडिया के लिए एलिजिबल नहीं है। आपका जो बॉडी वेट है, आपका जो जेंडर है, वो सब डिफाइन करके यू हैव टू गो फॉर अगस्टन स्कोर में। इंडिया के लिए अगस्टन स्कोर। ये है ना COMP कार्डियक, COMP कार्डियक है ना, उस पर क्लिक कीजिए। अगर कैल्शियम स्कोर हो गया तो फर्दर प्रोसीड। कैंसिल, नीचे नीचे एग्जिट है ना आपका,
एग्जिट
नहीं 1 मिनट, हाँ उसको एग्जिट कीजिए।
उधर भी देखना
कहाँ कहाँ देखूँ मैं, 1 मिनट। ठीक है, ओपन हो गया। COMP कार्डियक, स्टिल प्रोसेस हो रहा है। ठीक है, अगर COMP कार्डियक ओपन कर दिया आपने तो ऑन द लेफ्ट हैंड साइड यू हैव 2 ऑप्शंस, कार्डियक CT व्यूअर एंड COMP कार्डियक। लेफ्ट हैंड साइड में ऊपर, बिल्कुल ऊपर, लेफ्ट हैंड साइड में बिल्कुल ऊपर, ऊपर और ऊपर COMP कार्डियक। उससे पहले होगा आपका कार्डियक CT करके। आपने ओपन नहीं किया उसको फिर, हाँ कार्डियक CT व्यूअर आपने ओपन नहीं किया ना उसको ओपन करना है फिर। ठीक है, तो लेफ्ट हैंड साइड में ऊपर आपको मिलेगा कार्डियक CT व्यूअर और COMP कार्डियक। ठीक है, हाँ तो वो क्लिक करने के बाद 2D स्लैब वॉल्यूम एंडो 4 ऑप्शन दिख रहा है उसमें आपको। उसमें क्या कीजिए आप, 2D के नीचे जो 3 दिख रहा है, एक्सियल, सैच, कोरोनल, स्मॉल स्मॉल जो छोटा छोटा इमेज है, उसके बिल्कुल बाजू में एक छोटा सा एरो मार्क है वो, हाँ वो एरो मार्क क्लिक करेंगे, यू विल गेट अ कार्डियक एक्सिस। इन द कार्डियक एक्सिस यू विल हैव अ फर्स्ट SHV करके, S बोलो तो शॉर्ट एक्सिस, क्लिक 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 कीजिए कोई ना, हाँ S शॉर्ट एक्सिस, H हॉरिजॉन्टल, V वर्टिकल, तो आपको तीनों एक्सिस मिल जाएंगे उसमें। डन, एक बार तीनों चेक कर लीजिए आप। हो गया आपका, हो गया, ठीक है। हाँ तो फिर क्या कीजिए आप, इस पे आ जाइए आप शॉर्ट एक्सिस पे। शॉर्ट एक्सिस पे आने के बाद राइट हैंड साइड में थिकनेस लिखा है, थिकनेस 0.70 करके, हाँ उसको क्लिक कर ले। यू कैन राइट सम अराउंड 50 mm, 50 0.70 है ना, उस पर क्लिक करके राइट एज 50 mm। हाँ शॉर्ट एक्सिस पे जाके थिकनेस 50 mm, एंटर। 50, हाँ शॉर्ट एक्सिस पे करना है आपको, ठीक है। इस पे यू हैव टू जस्ट स्क्रॉल द इमेज को स्क्रॉल कीजिए। RCA जो स्टार्ट होता है ना, RCA, बस उसको देखिए आप, स्क्रॉल कीजिए, नॉर्मल स्क्रॉल क्लिक करके बस स्क्रॉल, हाँ ठीक है। सो इसका यूज क्या, अभी हमने 50 कर दिया है इसको, या अगर आपको 50 नहीं है तो 30 कर लीजिए इसको, जो भी आपको ठीक लगे थिकनेस। तो इसका बेसिकली इसका सिग्निफिकेंस क्या है, तो व्हाट द सिग्निफिकेंस इज, इन अ सिंगल इमेज यू विल गेट अ कंप्लीट RCA, ठीक है। एक मिनट, ये आगा RCA, इसको थोड़ा और स्क्रॉल करके देखिए, मतलब 30 पे आपको पूरा आ रहा है, ठीक है, ये अच्छा आ रहा है ना। सो थिकनेस को 30 कीजिए एंड प्रिसाइसली आपको उसको RCA लगाइए, आप एक क्लीन वेरी पिक्चर RCA मिलेगा उसमें। एक मिनट 30 कर लिया आपने, इसको 50 रख लीजिए, या 30 भी रख लीजिए, कोई दिक्कत नहीं। स्क्रॉल करके थोड़ा स्क्रॉल कीजिए आप, ये शॉर्ट एक्सिस है ना, ये शॉर्ट एक्सिस यहाँ है ना, ये दूसरा एक्सिस है ये, हाँ, तो शॉर्ट एक्सिस में रख के दिख रहा है आपको ये? तो आपको आरसीए क्या है ना, आपको सी स्ट्रक्चर में दिखेगा आपको। आ रहा है? अगर 30 बने तो 40 कर लीजिए, आपको जो भी ठीक लगे। तो जब भी आप फिल्म देते हैं ना, तो ये एक भी दो दीजिए, ठीक है? तो यू कैन इजिली सी द मिड लेवल, प्रॉक्सिमल लेवल, डिस्टल, सब तीनों दिख जाएगा इसमें आराम से। ठीक, ओके। ठीक है, अगर ये हो गया तो उसके बाद एक ऑप्शन है वॉल्यूम करके, वॉल्यूम ऊपर से थर्ड ऑप्शन वॉल्यूम, आप ही क्लिक कीजिए एक बार। अगर आरसीए का हो गया तो कम ऑन वॉल्यूम क्लिक करके नीचे आपको मिलेगा वीआर, वीआर क्लिक करके उसमें नीचे क्या दिख रहा है आपको, पीआर वीआर, उसको क्लिक कीजिए। सो दिस इज योर 3D रीमॉडलिंग जैसा दिखेगा आपको, 3D मॉडलिंग। पीआर वीआर दिखेगा, वॉल्यूम पे वीआर क्लिक कीजिए, उसमें पीआर वीआर, ठीक। वही ये ऑप्शन सिर्फ 15 में है तभी तो दिखा रहे हम ठीक है, तभी तो दिखा रहे। तो ये इमेज कैसा लग रहा है आपको? ये वीआर क्लिक करके पीआर वीआर, नहीं, उस पर क्लिक कीजिए, वॉल्यूम क्लिक कीजिए, वॉल्यूम ऊपर से थर्ड ऑप्शन वॉल्यूम, वॉल्यूम क्लिक कीजिए, उसमें आपको नीचे मिलेगा वीआर, वीआर क्लिक कीजिए उसमें, हाँ उसमें पीआर वीआर, ठीक है। तो दिस इज लाइक अ 3D इमेज, वेरी ट्रू 3D इमेज, काइनेमैटिक रेंडरिंग जो भी आप बोल सकते हैं उसको।
ये 15 में आप लोगों ने ये जोड़ दिया है, 12 की जगह 15 बेचेंगे,
अब तो वही बेचना पड़ेगा हमें डन, ठीक है। अगर ये हो गया तो उसके बाद में है COMP कार्डियक, ठीक है। उसके बाद आप आ जाइए COMP कार्डियक, लेफ्ट हैंड साइड में ऊपर है ना COMP कार्डियक, हाँ उसको क्लिक कीजिए। हाँ इसमें ऑन द लेफ्ट हैंड साइड डाउन आपको मिलेगा ऑल, नन एंड कोरोनरीज, तो क्लिक ऑन द कोरोनरीज, उस पर क्लिक कीजिए, हाँ ठीक है। तो आपको चेंबर सब हट गया ना, हाँ नीचे नीचे थोड़ा नीचे आया और नीचे कोरोनरीज, हाँ तो यू विल गेट ओनली द कोरोनरीज। अब इसमें आप देखिए whether the coronaries is marked properly or not, सब हाईलाइटेड है नहीं है। So this is auto segmentation, but again we have to check. ठीक है, बस एक बार चेक कर लीजिए, अगर सब सही है then we'll move further forward. अगर कुछ आर्टरी प्रॉपर्ली मार्क्ड नहीं है तो क्या करेंगे हम? उसके नीचे आपको मिला है आर्ट कोरोनरीज, आर्ट कोरोनरीज, आर्ट कोरोनरीज। अगर कुछ आर्टरी प्रॉपर्ली मार्क्ड नहीं है तो क्लिक ऑन आर्ट कोरोनरीज, उसको क्लोज कर लीजिए, हो गया है अभी। हाँ अभी जाइए उसमें, हो गया आपका, हो गया, तो फिर एग्जिट कर दीजिए उसको। ठीक है, इसमें आप क्लिक कीजिए कोरोनरीज, लेफ्ट हैंड साइड में थोड़ा नीचे आएगा ऑल नन ऐसा लिखा होगा, हाँ उसमें थर्ड ऑप्शन कोरोनरीज, डन, क्लिक। ठीक, okay. So first step segmentation happened. To the second step, दो फर्स्ट लिखा ना राइट हैंड लेफ्ट हैंड साइड में फर्स्ट ऑप्शन वन सेगमेंटेशन करके, लेफ्ट हैंड साइड में वन सेगमेंटेशन, उसको क्लिक, लेफ्ट हैंड साइड, हाँ ऊपर थोड़ा ऊपर, लेफ्ट हैंड साइड में वन सेगमेंटेशन लिखा है, उसको क्लिक करेंगे आपको मिलेगा कोरोनरी एक्सट्रैक्शन, कोरोनरी एक्सट्रैक्शन। ठीक है, कोरोनरी एक्सट्रैक्शन में आपको सब 8 ही क्वेरी पे मिलेगा, क्वेरी एलईडी, क्वेरी एलसीएक्स। तो ये आपके लिए क्विज है, आप उसको डिफाइन कीजिए कौन सा एलसीएक्स है कौन सा एलईडी है करके। हो गया आपका आर्टरी, एलईडी एलसीएक्स सब मार्क कर दिया आपने, उस पे लिखा ना क्वेरी एलईडी करके, मतलब क्वेरी मतलब अभी आपने उसको कंफर्म नहीं किया आर्टरी को, कंफर्म करने के लिए आपको मिलेगा ग्रीन कलर पे कंफर्म लेबल, हाँ बिल्कुल वही सही, उसको क्लिक करेंगे तो क्वेरी हट जाएगा आपका। लेफ्ट हैंड साइड में क्वेरी एलईडी लिखा है, हाँ उसको क्या कीजिए आप कंफर्म कीजिए उसको, नीचे नीचे उधर उधर लिखा है ना कंफर्म वेजल, हाँ बिल्कुल हो गया आपका। तो ऐसे आप क्लिक कीजिए, एलसीएक्स पे क्लिक कीजिए, एलईडी हो गया तो एलसीएक्स क्लिक कंफर्म, आरसीए क्लिक कंफर्म, कंफर्म हो सकता है इधर नीचे कंफर्म वेजल, ठीक है। एक 2-3 आरटी आप कंफर्म कर दीजिए, एलईडी कंफर्म, आरसीए कंफर्म, बस एक बार चेक करके कंफर्म करना है उसको। हो गया, उसके बाद राइट हैंड साइड में ना आपको नीचे ऑप्शन मिलेगा, सॉरी सेंटर लाइन दिख रहा है आपको, शो सेंटर लाइन करके, उसको अनक्लिक कीजिए, क्लिक्ड है वो, उसको अनक्लिक कीजिए। अनक्लिक करने के बाद Alt+M उसको क्लिक कीजिए, Alt+M, Alt+M, M फॉर मैंगो, मैंगलोर, yes बैंगलोर जो भी लिख लीजिए, Alt+M, ठीक है। आपको एक छोटा सा बॉक्स मिलेगा, उसमें आ रहा है बॉक्स, Alt+M, यहां क्लिक कीजिए उसको, हाँ Alt+M, ALTM, ठीक है। हाँ तो आप क्या कीजिए, बॉक्स के ऊपर कर्सर रख के राइट क्लिक, ये वाला इधर, हाँ वो बॉक्स में जाके कर्सर रखिए, कर्सर रखने के बाद राइट क्लिक, और आपको उसमें नीचे मिलेगा, नीचे क्या क्या ऑप्शन है, एक मिनट, नीचे आपको उसमें मिलेगा फैक्ट्री डिफाइंड, उस पे जाके सिर्फ माउस रखिए, उसमें आपको मिलेगा एक सीवियर कैल्शियम, ठीक है। अब तो अलग ही जा रहे हैं आप, सीवियर कैल्शियम, उसको क्लिक कीजिए, उस पे नहीं करना आपको, इस पे क्लिक करके करना है, हाँ उस पे क्लिक करके Alt M कीजिए, 1 second, what happened? हो गया, तो राइट क्लिक, फैक्ट्री डिफाइंड, उस पर आप करेंगे आप सीवियर कैल्शियम। तो अभी आपको इमेज कैसे दिख रहा है बताइए मुझे। तो आर्टरी, तो जो भी कैल्शियम का जो ब्लूमिंग है ना, दैट विल रिड्यूस। एलईडी क्लिक कीजिए आप। कौन सा इमेज ओपन किया आपने? दूसरा इमेज ओपन किया है, ठीक है कोई ना, इसको थोड़ा क्लिक करके बड़ा कीजिए उसको, साइड से ऊपर, ये ना इधर, इसको क्या करना है बस, हाँ ये नहीं है, दूसरा ओपन है ना, वो जो ओपन किया वो ओपन है, ये तो अपने नॉर्मल ओपन किया है। फिर इसको करेंगे राइट क्लिक, फैक्ट्री डिफाइंड और सीवियर कैल्शियम। तो अभी आप चेक कीजिए, वैसे ही आपको आ रहा है। तो आपको क्या डिफरेंस दिख रहा है उसमें? उसको जिधर भी आपका कैल्शियम है ना, उस पर जाके रखिए आप। वो बॉक्स आने के बाद जिधर भी आपको कैल्शियम दिख रहा है, उस पर जाके वो बॉक्स रखिए, और मुझे बताइए व्हाट यू विल अप्रिशिएट इन दिस। एक मिनट, इसको दिख रहा है आपका कैल्शियम, अभी कैल्शियम अलग दिख रहा है आपका, आरटी अलग दिख रहा है, राइट? अगर आपका कैल्शियम है ना, तो वो बॉक्स जाके उधर ऊपर रखिए, तो कैल्शियम अलग दिखेगा आपको और आरटी अलग दिखेगा आपको। दिख रहा है इसमें? यस। तो जब भी आप फिल्मिंग करते हैं ना, तो दिस इज वेरी हेल्पफुल, क्योंकि डॉक्टर बस लिख के दे देंगे स्टेनोसिस करके, कहाँ है किधर है, दैट यू हैव टू डिसाइड। आगे आपको ये ऊपर रखिए, इसको बॉक्स ऊपर लेके जाइए। अगर नहीं आ रहा तो बस हाथ उठाए, मैं आता हूं उधर ही। आगे आपको राइट क्लिक, नहीं उसी पे राइट क्लिक, ये वाला, हाँ उसी पे राइट क्लिक, ये वाला राइट क्लिक, हाँ फैक्ट्री डिफाइंड और सीवियर कैल्शियम। आगे आपका डिफरेंशिएशन, ठीक, डन, ओके। अब ये हो गया, तो देन विल मूव फर्दर फॉर थर्ड स्टेप। तो राइट लेफ्ट हैंड साइड में ऊपर आपको दिखेगा ना, 2 कोरोनरी एक्सट्रैक्शन, उसको क्लिक करके गो फॉर 3 कोरोनरी एनालिसिस। थ्री कोरोनरी एनालिसिस। हाँ, अगर कुछ आपको एरर आ जाए तो एरर क्या बताए मुझे, बोलता हूं मैं वो। कैलकुलेट लूमन फॉर ऑल वेजल्स, राइट, उसको नो क्लिक कीजिए, उसको नो क्लिक करेंगे। हाँ, तो लास्ट बैच ने आप पूछा था प्लाक एनालिसिस के लिए, अभी वो लोग सब चले गए शायद, ठीक है। ठीक है, तो इसमें क्या कीजिए आप, देखिए आपने अगर सॉरी ये नहीं, एलईडी उठा लीजिए आप, एलईडी। अब इस पे आप डिफाइन कीजिए प्लाक किधर है करके, या कैल्शियम जो भी आप बोल सकते हैं, उसको कहां है देखिए, वो कैल्सिफाइड, नॉन कैल्सिफाइड है ना, ठीक है। आपको जो स्ट्राइट एक इमेज दिख रहा है नीचे में, लास्ट में जो स्ट्राइट इमेज मैं दिखाता हूं एक बार। डिस्प्ले डिस्प्ले एक बार देख लीजिए, डिस्प्ले देखिए एक बार, एक मिनट, डिस्प्ले देखिए एक बार, ठीक है। इसको मैं एक मिनट इसको करता हूं राइट क्लिक, कंफर्म वेजल, थर्ड स्टेप में कोरोनरी एनालिसिस। अगर ये ऑप्शन आ रहा है तो उसको नो क्लिक कर दीजिए एक बार, नो क्लिक करेंगे। हाँ, तो इसमें क्या कीजिए ना, आपको जो वेजल है इसको कीजिए एलईडी, एक बार बस डिस्प्ले देखिए, फिर उस पर अप्लाई कीजिए, वेजल कीजिए एलईडी, ठीक है। जो नीचे दिख रहा है आपको स्ट्रेट एमपीआर, इसको थोड़ा कॉन्ट्रास्ट, थोड़ा ब्लैक कीजिए, ओके। ब्लैक करने के बाद आप भी आप देखिए, इट्स फुल्ली अक्लूडेड, आर्टरी जो है वो पूरा अक्लूडेड है, ठीक है। और जो भी आपको जो ब्राइट है ना कैल्शियम्स, कैल्सिफाइड, तो ये आपको दिख रहा है ऑटोमेटिक लूमन में आ गया वो, सॉरी अवे फ्रॉम द लूमन, ठीक है। अभी हम क्या करेंगे, उसको जो सेंटर लाइन दिख रहा है ना आपको, द लीजन लाइन,
तो लीजन लाइन क्या कीजिए, सेंटर ऑफ द इमेज पे जाके रखिए उसको, एक बार डिस्प्ले देखिए फिर उस पर अप्लाई कीजिए, वरना डिफिकल्ट हो जाएगा वो। ये जो लाइन है ना, लाइन आपका उसको क्लिक करके स्क्रॉल कीजिए, उसको सेंटर लाइन को क्लिक करना है, लास्ट स्क्रॉल नहीं क्लिक करना है, सेंटर को क्लिक करके ठीक है। सेंटर पे रखने के बाद यू हैव एन ऑप्शन कॉल मार्क फाइंडिंग, राइट लेफ्ट हैंड साइड में थोड़ा नीचे में मार्क फाइंडिंग, उस पर क्लिक कीजिए। उस पर क्लिक करने के बाद ये जो है ना ब्लूमिंग सॉरी ब्राइट लेवल, उस पर क्लिक कीजिए। अभी क्या दिखा रहा है, एक्सेप्ट रिजेक्ट, एक्सेप्ट दिस and you will get a very beautiful 3D modeling of the plaque analysis, right? अगर नहीं आ रहा है तो वैसे एक बार मुझे बुला ले, हाथ उठाए मैं आता हूं, मैं नहीं आ रहा है सर, सबको नहीं, किसी को नहीं आ रहा है। Which one? Stenosis table is the second next step. हाँ, ये just plaque analysis है। आ गया ना आपको? Fair enough। आ गया? आ गया आपको? हाँ, आपका आ गया ना वो, सही है। इसको क्या करना है, इसको क्लिक करना है ब्राइट पे, क्लिक करके एक्सेप्ट, आ गया उधर। मार्क फाइंडिंग इस पे क्लिक कीजिए ब्राइट लेवल पे, एक सिंगल क्लिक एक्सेप्ट, आ गया। सो दिस इज योर, उसका क्या बताइए, फाइंडिंग वन, ठीक है, वैल्यू आ गया उसका प्लाक का, ठीक, डन। मैडम हो गया आपका? नहीं हुआ? अच्छा, ये आपने नॉर्मल वाला किया है ना, आपको आएगा नहीं, छोड़ दीजिए उसको एग्जिट कीजिए, उसको एग्जिट कीजिए, फिर दोबारा मैंने बोला ना कौन सा केस लोड करने के लिए, एग्जिट कीजिए उसको एग्जिट कीजिए। हाँ, जो है ना सेकेंड वन, उसको लोड कीजिए एक बार, ठीक है, हो गया, ओके। देन उसके बाद क्या कीजिए आप, फिर अगेन फॉलो डिस्प्ले, अगेन फॉलो डिस्प्ले हियर। ये जो है ना प्लाक एनालिसिस, प्लाक एनालिसिस, इधर इधर देखिए, इधर देखिए, डिस्प्ले देखिए एक बार, प्लाक एनालिसिस, क्लिक ऑन कोरोनरी एनालिसिस, हो गया, क्लिक ऑन कोरोनरी एनालिसिस, और फिर अगेन सेम जो हमने किया ना, मार्क फाइंडिंग, सेफ फाइंडिंग, क्लिक ऑन सेफ फाइंडिंग, जिधर भी आपको लग रहा है स्टेनोसिस है उधर जाके क्लिक ऑन सेफ फाइंडिंग, ठीक है। वंस यू क्लिक ऑन द सेफ फाइंडिंग, आपको इधर मिलेगा स्टेनोसिस ग्रेडिंग, सेफ फाइंडिंग, स्टेनोसिस ग्रेडिंग मिल गया, डन। स्टेनोसिस ग्रेडिंग मिल रहा है आपको, सेफ फाइंडिंग आ रहा है, स्टेनोसिस ग्रेडिंग, डन।
So how do we set reference?
No, 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 no. If you are setting any reference, this proximal and distal should be in a parallel. For example, if you are keeping this at a 2 centimeter level, this should also be 2 centimeter.
Fine, मतलब keep it at 4.
You can extend this. इसको हटाइए, then again you have to extend this also.
I want to see the stenosis that it gives for this calcified plaque. Right now it is showing just 17, which is obviously not right because the reference is not set right. So please set the reference to the right places. It is giving 64.
So in that actually you have area reference
And
diameter reference, and this should be in a equidistant. The reference, the lesion should be in the equidistance. अगर वो है then it's fine. See now it is telling us 78.
So if you go in the equidistant, it will come. Done?
Contrast opacification.
Hmm?
There's no distal contrast opacification.
No, distal it is there, no?
This and this is same, no?
This one, this is LED?
No, the thing that is projected and this one, these are same. Or
No, 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 this will be no, different one. No, both are. You can check or else let me know what I can do something for that. Done? उसके बाद आप क्या कीजिए, फाइंडिंग समरी. क्लिक ऑन फाइंडिंग समरी, आपका काम हो जाएगा बस. क्लिक ऑन फाइंडिंग समरी. Done? Finding summary आ गया आपका. The CAD RAD results. Save changes, बस काम तमाम. उसके नीचे बोलेगा save changes. तो इसमें आप देख सकते हैं जो आपने मार्क किया ना, जो सेगमेंट, मिड सेगमेंट, डिस्टल सेगमेंट और द प्रॉक्सिमल, तो it is beautifully shown. It is a mid segment, mid LED. Then save changes.
It will not do plaque burden on its own.
No, this is only for the coronary, the stenosis thing.
Only
Plaque burden is the second step. Sorry, before this step.
But you did it, but it is not. It will not show there.
No, it will not show here.
It will not show.
It will. We have to just picturize in a different way. That. You have seen that plaque, no?
How do you calculate plaque burden? SIS or?
One second.
I was asking, the final report that is being generated for plaque burden. What is the basis?
No,
for
that is the for the stenosis one.
No, is it just based plaque burden, P score, P1, P2, P3, P4? It's based on either the calcium scoring or on the segment involvement score, SIS.
It is by definition what you have defined in this level, not the calcium scoring level.
Just calculate one plaque burden for this.
You can just have a try with this. For example, I'll go with some different artery.
It's fine. There's enough.
So I have already defined this.
Now, can you go to that final report?
This is the final report of this. You can just have a look on
CAD
this. No, in the CAD RAT, it is for the only for stenosis.
Open now.
No, you show him the result here. Just open it in a report format.
This thing you can define this. You have to define that. You have defined. We have to define here. We have to define P1, P2, P3. It has to be defined.
Because see, it is A.
For example, I'm defining this as a.
Still, it is on your suggestion. AM is still correct.
Yes, this has been added, and one more thing here. The thing is, you have to define all these things. For example, it has stenting or not. After defining that, you have an automatic suggestion here.
I mean, these things can be done quite easily because these are just yes no things. But this is nice. This is nice. Because this will give a very good segment.
And one more thing. After defining all this yes and no, generate the report. Generate this report. ठीक?
Like that addition is good. That addition actually gives us a calculation for SIS.
SIS.
But that is not being calculated automatically.
No, that will calculate automatically if you predefine the area.
No, and you are getting here, no, the result, the plaque one. The degree of maximum stenosis, whether it's a plaque or stenosis करके. If you have defined this properly, then you will get here. With the plaque or without the plaque.
We are just defining the area where you want to see.
You can sit again. अच्छा ये दोबारा बढ़ के fill होगी. नहीं पुराना बैच है ये. First वाला बैच है ये. I think the batch has been like. चलिए. Done? हाँ ठीक है. So this is the final session. We are demonstrating the plaque one.
और किसी को देखना हो तो आके देख लीजिए.
Sir.
How can we calculate stenosis in this type of plaque?
सर आपको एक बार दिखा दूँ फिर मैं।
बैठो तुम सरोज, बैठो
है दो सिस्टम है सर, बैठे।
नहीं अब बैठिए बैठिए बैठिए। सर इसमें आपको दिख रहा है ना सर रेफरेंस पॉइंट, उसको बस स्क्रॉल कर लीजिए एक बार।
नहीं ये मुझे समझ में आया, अभी ये कैसे इतना, इसमें तो ल्यूमिन ही नहीं दिख रहा है, कैसे
एक मिनट
कैलकुलेट करेगा वो?
हाँ कर रहा हूँ करेक्ट। दिख रहा है सर आपको इसमें ये हमारा लूमेन हो गया।
अच्छा ये ल्यूमिन है,
ये लूमेन हमारा जो इसमें इसमें आपको यहाँ पर 2 मार्किंग, एक जो एक ब्लू कलर है, एक है येलो कलर। सो यू कैन चेक ऑन हियर, एक इसको किसी एक को क्लिक कीजिए आप, तो एक हमारा लूमेन हट गया अभी।
हाँ ये येलो वाला हटा ना।
हाँ तो वो है लूमेन लाइन, ये है हमारा वेजल लाइन। उसको पे क्लिक कीजिए एक बार, तो वेजल भी हट गया हमारा। ठीक है,
ये क्या था आपका?
ये जस्ट क्या बोलते हैं जो भी अपने डिफाइन करते हैं ना इधर, इट विल कम एज अ वेजल टेबल, फाइंडिंग टेबल। इस पे वी हैव टू डिफाइन विद रिस्पेक्ट टू लूमेन और विद रिस्पेक्ट टू वेजल। सर यू कैन क्रॉस चेक विद दिस।
ये देखो ल्यूमिन इतना जा रहा है ना, इसको कुछ देखो ल्यूमिन यहाँ पे बताता हूँ मैं। ल्यूमिन देखो, दिस इज योर ऑटोमेटेड सॉफ्टवेयर बट इट इज नॉट दैट मच एक्यूरेट। यहाँ पे देखो आप, ये ल्यूमिन बचा है ना, तो
if
इस पे
you
कैलकुलेट
want
करेंगे तो बस हो गया फिर।
तो if on that note you can edit that lumen। यहाँ कर सकते हैं या नहीं तो आपको ड्रॉ मिलेगा ऑप्शन आपको, या ना इधर एडिट फाइंडिंग एडिट कर। या इट इज डुअल, इट इज बाय डिफॉल्ट। इसको क्लिक करके एडिट लूमेन करेंगे। हाँ यू विल गेट द पेंसिल ऑप्शन ही। सो इफ यू वांट यहाँ करेंगे तो एक सिंगल सेल करना पड़ेगा।
ठीक है, तो उसमें अभी आपका वंस हो गया तो उसको फिर डिसेलेक्ट कीजिए। एंड अभी सेव करना है ना इसको, अगर सेव करना है तो
उसको फाइंडिंग चेक ये हम चेक करें प्लाक एनालिसिस का। अगर कोरोना चेक करना है तो वी हैव टू चेंज द प्रीसेट। सेव फाइंडिंग, यस सर।
नहीं मैं ये बोल रहा हूँ कि ये जो लाइंस आ रही हैं ये एक्यूरेट नहीं है। हमको भी ये जैसे बहुत ही कम ले रहा था तो हमको उठा के उसको एडिट करना पड़ता है। ये नहीं है कि इसने जो बताया और वो मान के बैठ गए।
19 20 ऊपर नीचे करना है।
हाँ ठीक है।
डन। हाँ फॉर विच वन? प्लाक एनालिसिस। यस ओके।
अपने सिस्टम से बता दीजिए।
हाँ
सब लोग देखते हैं।
So I'll do the last time for the plaque analysis. You can just have a look.